the patient can lose hearing, the patient can get vertigo. So all these things you must keep in mind.
Yes, sir.
Right. So
sir,
generally, we follow this patient in the OPD with the ophthalmologist. We ask him to go to the ophthalmologist, do the fundus exam for the papilloedema periodically, like every 3 months.
Yes, sir.
And we ask the patient to come back to ENT OPD whenever the patient has an occipital headache.
Yes,
headache can be a manifestation of idiopathic intracranial hypertension.
Yes, sir.
Okay.
Yes,
so
sir.
these things you must keep in mind. And some cases, in most cases, we do a lumbar CSF manometry. We do it typically like after 3 weeks. You can do it at 3 days also.
Yes, sir.
So you can do the CSF manometry. The pressures are very high. If it is more than 30, it is better to go for a CSF diversion like the thecoperitoneal shunt or ventricular peritoneal shunt. Some shunts are required. Okay.
Okay, sir. Okay, sir. Sir,
pressure is very intermediate between 25 to 30. You can monitor the patient. You can put the patient on diamox. Keep a close watch.
Okay, sir.
The
sir,
pressure is less than 20. You can just put the diamox and manage on diamox.
Sir, intraoperatively in these patients, do you routinely put lumbar drain?
Actually, it's a very good question, but I would say there's nothing wrong in putting a lumbar drain because see the CSF pressure is very high here, and whatever closure you do, there is a chance of the closure opening up. But the lumbar drain carries a chance of infection. So
yes, sir.
I sometimes just have an assessment indraw. The leak is so profuse and
yes, sir.
I feel it's high pressure. I go for lumbar drain, or else I just avoid lumbar drain.
Okay, sir. Fine, sir. Fine, sir.
Okay. And one more thing for the ENT, since we are ENT colleagues, see,
yes, sir.
There is something called the sleep apnea causing idiopathic intracranial hypertension.
Okay, sir.
So sleep apnea can be a cause of, I don't know if Dr. Vikas Agarwal is there or not. He calls the sleep apnea the mother of all diseases. No?
Oh, yes, sir. Yes, sir.
So with the sleep apnea, whenever the patient has the apneic episode, the CSF pressure drops.
Yes, sir. OT, we have lost the picture from the OT.
So for the sleep apnea patients, when you do the lumbar manometry during daytime, the pressure can be falsely low.
Okay,
you will miss it. So only during that night time, during the apneic episode, the pressure goes up, and that you cannot diagnose because you cannot do the manometer at that particular moment. That is not going to work out.
Sir.
Okay?
Yes, sir. Yes, sir.
Okay. So I think I will watch now, and if there's any more questions, we can ask. I was just wondering, what Dr. Ragesh was discussing. There's two completely different specialties. Airway, I just could understand like 10%. So it is a vast specialty. Like you have skull base, you have airway implants.
Yes, sir.
So
Yes,
very
sir.
good specialty.
Yes, sir.
Am I audible there? Is the mic working properly? Hello, auditorium.
Yeah, we are getting your voice, sir.
Only thing, your voice is actually sort of breaking here. That's the problem.
The voice is breaking a little bit.
Okay. So there is some echo from the other side. Okay. And I do have a hearing loss also, actually. Okay. Where's the 8 says glow? 8. Oh, I used one glow. So do you have a spare 8 says glow? Yeah, got it. I got it. Keep on ready for the next case also. Okay, I got it. And other thing is, some people they typically use the vascularized flap if they suspect an idiopathic intracranial hypertension.
Okay, sir.
But I have seen people like Dr. Nishit sir, he doesn't believe in that. He does a routine thing because he feels that idiopathic hypertension is very common in Indian population. So there
Yes,
are
sir.
differences in the way you do the surgery.
Sir, vascular flap means Hadad flap.
Yeah,
You're
Hadad
talking
flap,
about
yeah.
Hadad flap. Okay, sir.
Yeah. Yes. Can I get the cameras? Can you connect that monopolar needle, the Colorado needle tip here? Just here to निकाल के बोला. Okay. 0 degrees scope. I'll take the 30 degree also if you don't mind. Huh? Okay. Camera. So I have packed the nose. I've done the draping with betadine. Can you keep the monitor like this straight? Okay. Can you increase the light intensity? Okay, you keep it straight. Not 24. Just here's the regular. A monitor product tilted. No. Other way around. Okay. I get the white ghost. A white ghost. What white balancing? Can you do the white balance? White balance. Okay. Are you getting the endo picture there?
Yes, sir. We are getting the
Okay.
endoscopic picture.
So I just placed some decongestant packs on the left nasal cavity.
Okay, sir. Sir, how do you decongest the nasal cavity
I
preoperatively?
generally use a mixture of 10 ml 4% silocaine and 10 ml adrenal. That is what
Okay,
I
sir.
generally use.
Okay, sir.
See, can somebody, some postgraduate student there, tell me what is this? Any PG student there? What is this?
Any PG student?
Eh?
I think they are in the dissection also.
That's a Jacobson for me. Yeah, very nicely seen here. Okay. So that's the left nasal cavity. Can I get the elevator? My elevator? I need my elevator. This one is my elevator. Yeah. So the first step in most of my endoscopic skull-based procedures to lateralize the inferior turbinate. I use the blunt. See, this total, this elevator has two sides. One is the sharp side. There's a blunt side. I use the blunt side. I gently push it like that. Okay. And I outfracture the turbinate. Look. Now I get some extra space for maneuvering.
Yes, sir.
Okay. So that is my first step. And I'm going to cut this turbinate right away because see, you can the defect is in the medial aspect of the cribriform plate. You can do that by preserving the turbinate.
Yes,
But
sir.
since here it is leaking into the conga bullosa,
Yes, sir.
so you cannot preserve the turbinate here. Can I get the decongestion pack again? I need some patties also. Do you have some patties? Can I get the straight, give it back in the blackest, straight blackest, okay? Straight blackest, okay.
Sir, if the turbinate bone is hard, then how do you lateralize the turbinate?
What is that?
If the turbinate bone is hard, then how do you lateralize the turbinate in those cases?
You can see, you will have, once you give some pressure, that bone will break.
Okay, sir.
Or you can do the infraction, outfraction. Okay.
Yes, sir. So you always use the gel foam for decongestion, sir?
This is not the gel foam. This is Evolon pack, the Merocel pack.
Yeah, Merocel. Sorry, Merocel. You always use the Merocel, sir, for decongestion, sir?
Yes, mostly. This is the technique which actually the entire world learned from Dr. Sadish Jain.
Yes.
I think most of the places now they use it.
Yes, sir.
I still remember the workshop in Jaipur when where Professor Amin Kasam and Richard Harvey came and they saw Sadish Jain are using this technique. And nowadays, when I see Richard Harvey and Kasam, they all do this particular technique.
Yes,
Because
sir.
the Merocel absorbs a lot of it swells up and it does a very good decongestion. Okay, compared
Yes,
to the
sir.
normal patties.
Yes, sir. Yes.
My challenge here, see, there is a high circle deviation there. Can you see that?
Yes, sir.
This will impede my approach.
Yes, sir. So you will go for septoplasty, sir?
There is an option, but then let me see. Let me see. Can I get the Mayo scissors? The normal curved scissors? Yeah. So I'm going to cut the turbinate right away. So that's a middle turbinate. And I'm using a Mayo scissors, curved Mayo scissors. First cut. I need some patties also. And after the first cut, I can gently push it down like that. I close the knife, the scissors, and then push it down like that.
Yes, sir.
Suction, can I get a suction? Do we have a smaller straight section? Can I get the small scissors, which I brought the small straight scissors? May I was sort of scissors, you know? And this will be fine. I think. Do we have some patties there? I'll just place some decongestion and get a better bloodless view. Huh? And see, it's always nice that you have a bigger defect. See, because smaller defects, it's very difficult to find out during surgery. You got
Yes,
the point?
sir.
The
Yes,
bigger
sir.
defects you can always find out. So
Yes,
the
sir.
trickiest cases are the ones with the smaller defects.
Yes, sir.
Wash, give me some saline wash. Saline, wash. Good. Wash again. Keep washing. Keep washing. Okay. Can I get my scissors? So this is a bulla. Can you see the
Yes,
bulla
sir.
model is there?
We can see the bulla.
Okay.
Yes, sir. We can see the bulla.
There is some pus in the suprabullar recess there.
Yes, sir.
Okay. Scissors now? No, the small scissors. Okay. Other direction. Okay. Section. Right, Blakeslee. There is a fovea model. Can you see the fovea there?
Yes, sir. We can see the fovea.
And you can see a olfactory filament also here. Can you see that?
Yes, sir.
This one there. Right, Blakeslee. Straight here. Do we have some patties here? Some cottonoids? No, the normal patties. Okay. And do we have a smaller Blakeslee? Not so big. See, nowadays it is very rare to see traumatic CSF leaks ending up with surgery. Most of the cases in my scenario, in my experience, is spontaneous.
Yes, sir.
I do like probably 3 to 4 CSF leaks every month, and of that, I think only probably like 10% of my cases are traumatic. All others are spontaneous leaks.
Yes, sir. Same is the scenario here, sir. We mostly see spontaneous CSF rhinorrheas in our OPDs. Is there some defect?
I can see some CSF, but I don't see it. Can you
Yeah.
see that there is some CSF?
Yes, sir. Yes, sir. We can see this CSF and
Can I get the true cut? Thing is that, see, in cases of intracranial hypertension, the defect can be very small, and
yes,
because
sir.
of the pressure, it is coming out.
Yes, sir.
Even sometimes, if the pressure is so high, the leak can happen to the pores where the olfactory filaments come out.
Yes, sir.
And this patient, you have to put a Diamox postoperatively, and you have to do a lumbar manometry after 3 weeks. I can
Yes,
see
sir.
some fitness there. Do you have a true cut? True cut.
Sir, do you routinely use Lasix in these patients preoperatively in spontaneous
No, I
CSF
don't.
rhinorrheas?
I don't.
Okay, sir.
Some people use the mannitol, but I don't use the mannitol.
Yeah, sir. Okay, sir. And sir,
Can I get the elevator?
postoperatively also you put these patients on Diamox?
I
Postoperatively
put the
also
patient on Diamox. I put the patient on Diamox. I give like 250 milligram thrice daily. And after 2 weeks, can I get the mirror back? After 2 weeks, I pass the patient. Sorry, after 2 months, on the third month, we generally do the CSF manometry. So we stop the Diamox for 1 week and do the manometry. And if pressure is very high, go for other procedures. The pressure is low, we continue Diamox. The
So
pressures
for
are
how
normal.
long? So for how long you give the
borderline
Diamox postoperatively?
Diamox we give like for 3 to 6 months, but
Okay,
thereafter we
sir.
stop it, and intermittently with the patient has headache or papilledema, we start again.
Okay, sir.
See, after 3 months, the manometry shows a normal pressure. We don't continue Diamox further.
Okay, sir.
Because see, what you call this empty cell can be a normal finding, can be seen in normal patients also. Seeing an empty cell does not always mean the patient has a intracranial hypertension. Even though you have this Dandy's criteria and all, so all those patients need not have a hypertension. Can I get the Blakeslee first? Section. There is a posterior remote cell there. Okay. Can I get my elevator? I'll just gently examine the cribriform plate again. So there is a middle turbinate getting attached to the lateral lamella.
Yes,
And,
sir.
This is the area of cribriform plate, and here you have the
Yes,
this
sir.
is the area of foveus modalis. Okay, this is the lateral lamella.
Yes, sir. Yes, sir.
Can I get the 45 pleccus? I could get some wetness there, but I don't typically see a leak there.
Yes, sir.
You're seeing the dura there. Can you see the dura there? Here?
Yeah, yeah, sir. Yes, sir. Yes, sir.
Where is the dura of the lateral lamella? But anyway, I'm going to cover this entire area.
Yes,
45
sir.
pleccus. It's going to open up the frontal recess because I don't want to, my reconstruction closing that frontal of sinus. Okay, there we go. Can I get the curved section tip? So you are seeing the supraorbital cell there. Can you see the supraorbital cell
Yes,
there?
sir. Yes, sir. You can see the supraorbital cell.
45 pleccus. Can I get a saline wash? Saline wash, 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 wash. Wash, wash, wash. Wash, 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 wash. Wash, wash. Enough, 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 enough. And this is your anterior artery. This is the area of the artery. Huh? So this
Yes.
is the skull base. The skull base sort of makes a turn there like that. Huh?
Yes, sir.
So exactly at that turn, you have the artery. Huh? In front of the artery, you have a small cell which you can call as a suprabular or supraorbital or a frontobular based on its hematization. Okay.
Yes,
This is
sir.
that one cell in front of the this is the artery. This is that one
Yes,
cell
sir.
in front of the artery, and here
Yes.
exactly you have the frontal. That is the frontal sinus.
Yes, sir.
Okay. There is I don't know if you can see that. I can see that there is a frontal
Yes, sir.
sinus there.
Yes, sir. Yes, sir. Yes, sir. We can see the impression of the frontal sinus.
So I just exposed it because I don't want to have my flap closing that area. Can I get this one? Where is the frontal sinus? Okay.
Yes, sir.
You can see the sinus posterior
Yes,
table
sir.
there, the frontal sinus. Okay.
Yes, sir. Yes, sir.
So I'm going to now cauterize this area and put a flap over there. Huh? See, when the defect is very small, you need not have to place some. You need not do a tuck-in inside the defect. Huh?
Sir, can you delineate the defect once more for the audience?
Here, you can see
Sir,
olfactory filament coming out.
sir,
That's
can you use a
olfactory
ball
filament.
probe? Sir, can you use a ball probe to?
I can do that, but can you see the olfactory filament on my suction tip there?
Yeah, yes, sir. Yes, sir. We can see the olfactory filaments.
Can I get the ball probe? I'll show the defect. Okay. Can I get a small pipette? I'll clean it and show them. Huh? Small pipette. And I'll place the pipette, clean it, and do a valsalva maneuver, and we'll check for the leak. Okay.
Yes, sir.
And as you say, I not cut the turbinate completely. I left the middle turbinate pedicule posteriorly. Can you see that? Did you understand that? I have not
Yes,
removed
sir.
it.
Yes,
Only
sir.
released the vertical section.
Yes, sir.
The ground lamella is still intact.
So do you use the remnant of the middle turbinate as the last layer of repair in your cases or not?
I will place the Haddad flap and I'll take a small Haddad, I'll put it there because
Okay,
that will
sir.
see here it can. I don't really clearly see a very big defect. I just see multiple defects and some wetness on that entire area. So I'll be
Yes,
putting a
sir.
flap over that region. I'll put the turbinate on top of that so that the poster will look like a non-operated patient. You'll have the middle turbinate
Yes.
in place. So after like 6 months, when you put endoscope, you'll see that like a normal nasal cavity.
Yes, sir.
I'll clean it and then I'll do the Valsalva. Can you give a what? 45 electricity? Okay, enough. Can I get the true cut again? True cut. See, I can see some wetness there. I don't know. Can I get the ball probe? Can I get the ball probe? Ball probe. Yes, I can see some. Can you see that? Yeah. No, not very convincing, but I can see some wetness there.
Yes,
Can you
sir.
get the true cut?
Yes, sir. I think you have to remove this stump of the middle turbinate to find out the
Yeah, I'm going to
defects.
do that. I'm going to do that. That's why I just got the true cut. Can I get the bipolar? And the best way to do this whenever is to use your diamond rule, because sometimes when you cut it, you can cause a leak. The diamond rule generally is safe over the dura. Can I get the bipolar? See, I generally see. I go to many centers to operate cases. See, you don't have the Kassam's quarter in all those places, so we can also do the
Yes, sir.
surgery with the normal bipolar. The trick is that you have to put it like that. So that's
Yes,
the
sir.
nasal cavity. You have to put the bipolar like that.
Yes, sir.
See that?
Yes, sir.
Okay. So if I take
Sir,
it
can
like
we-
that, I
Sir,
can use
sir, one
that
question
normal
is there, sir.
bipolar for the. Beg
Sir,
your
can
pardon?
we use coagulator, sir?
Sir,
We
do
can
you
use the
prefer
coagulator,
coagulator or
we can. I just get the coagulator for the other table here. I can use the coagulator, the coagulation mode of the coagulator.
Which one is better, sir, in your opinion, sir? Coagulator or bipolar, sir?
Coagulator is useful because we have the suction also. You can see all the olfactory filaments. Can you see that?
yes, sir? We can see the filaments.
But actually, I'm not seeing the leak so well. Can I have
Yes,
the
sir.
Valsalva for me?
Sir, yes, sir.
Valsalva?
Still, the defect is not
Can
so
we
appreciable.
give the anesthesia? Can you have the Valsalva now? Can you give the back? Can you close the expiratory valve and give the mask? See, there is definitely some moisture there. Can you see that here? Yes, medial
Yes,
on the,
sir.
it is not on this side, but I can see the moisture there laterally.
Yes, sir. On the middle side of the
Correct,
middle
correct. And I
turbinate.
can see this multiple olfactory
Yeah,
filaments
some trickling of the fluid is there. I don't.
here. Can you give the Valsalva now? Valsalva? Give the mask. You give the. Can you press this thing back? More. Okay. Hold for some. Hold. You're close to expiratory valve, right? Okay. And give the mask. Okay. As per the cysternography, this is the site here. Here, but this entire area you can see some redness, huh?
CT scan
And that typically happens in this VH
हम
patients.
थोड़ा सा ऑफ ट्रैक है अभी जो मुझे समझ में आ रहा है
One more time. Release. Can you close the mask again and you close expiratory valve and give the mask again? Yeah. See, actually, there is some wetness, but I don't really clearly see a defect. And the
Yes,
scans
sir.
are also
Yes, sir. The defect
okay,
is
like that
not so
only.
appreciable.
Okay, but anyway, I just put the. This is called carpet-grabbing. When you don't get a clear-cut defect, you just put a hadad or a fascia over there and put the.
Okay,
That
sir.
is called a carpet-grabbing. Okay, enough. Thanks.
So you will put a Haddad flap for that area.
Yeah, because I suspect an intracanal hypertension. I generally.
Okay,
And
sir.
there is
Okay,
not
sir.
clarity also.
Okay, sir.
There is
Sir,
a.
sir, what is your experience with tissue glue? Sir, what is your experience with fibrin glue? Fibrin glue in these cases?
You can use the tissue glue. See, this is the anterior artery. The most common site of defect is where this artery
Yes, sir.
enters the lateral lamella there. Huh?
Yes, sir.
I use tissue glue, but there are alternatives like you can use the. If you have the blood bank in your hospital, you can use the PRP or the PRF.
Yes, sir.
Okay.
Yes, sir. Yes, sir.
So generally nowadays, when I have the CSF leak in an operated case, such as the patient underwent some surgery, some skull-based surgery other place, and the patient comes to the CSF leak, and when you put the endoscope, you can see the leak size.
Yes,
Then I
sir.
generally get PRP and PRF. I take the patient's
Okay,
blood,
sir.
centrifuge it, and
Yes, sir.
then use the PRP in the
Yes,
OPD
sir.
itself. I don't take the OT, and I have very good results with that. Elevator.
Yes, sir.
Elevator. Give me my elevator, the cortical elevator. Huh? Now we'll go for the Haddad flap. Okay, so that's the middle turbinate. The straight suction tip. Can I get the straight suction tip? And the other thing is, see, when you have a what do you call a patient with CSF leak and you're not able to see the defect in CT scan, you must
Yes,
look
sir.
at sites like the lateral ridge of sphenoid sinus, the lateral aspect of the and sometimes small cribriform plate and underlying idiopathic intracranial hypertension, a clival
Yes,
leak,
sir.
and sometimes a CSF otorhinorrhea.
Yes, sir.
Here, actually, being very frank, I don't have the fine CT cuts to completely check the skull base. So, but generally, the cysternography report is very reliable. That's why I just went ahead with the cysternography report. So there is a superior turbinate. You have the sphenoid austin somewhere. Can I get my elevator? There is a superior turbinate. Here is a sphenoid austin. Can you see that? This one.
Yes,
Huh?
sir. Yes, sir.
That is the sphenoid ostium.
Yes, sir.
Now the Colorado needle tip. So I am going to take a small Haddad flap here. That is my monopolar needle tip or the Colorado needle tip. So the incision starts at the level of the sphenoid ostium like that. How much is the monoporosity? Okay. Suction. So that is a Haddad flap. I am not taking a very big flap. So generally for the skull base, you can take the flap here till the level of the middle, till this level, at the level of attachment of middle turbinate, leaving like 5 millimeter of olfactory mucosa there. And once I reach the anterior aspect of middle turbinate, I can arch it all the way up to get the big flap. But here I just need a very small flap. And until you can come till the junction of the skin and the mucosa. Again, see, you can make this incision all the way down to the lateral wall if you need a big flap. But here,
Yes, sir.
you just need a small flap.
Yes, sir.
So there is a eustachian tube orifice there. There's a posterior tubal hole.
Yes, sir.
We had to start the incision like that from there. Okay. Okay. Now put the side suction tip. Can you get the glue ready? I think in another 20 minutes will be over. Can you get the suction tip, side suction tip? Elevator, give me my elevator, the cortical elevator. Yep, very good. So I'm taking I just get in the correct plane there.
Yes, sir.
See how I use, this is how I use the elevator, like that. Only sweeping motions, okay? I'm not exerting any pressure. No infiltration, nothing.
Yes, sir.
When you're in the correct plane, there is hardly any feed. Huh?
Yes, sir. Yes, sir. Yes, sir.
Can I get my small scissors now? Because this incision is
sir.
not complete there. My scissors.
Yes, sir.
Other direction. So the other one. Both are same side. Huh? Both are same side. Okay. Okay. Can you give a wash, please?
He's
आप संभाल लोगे वो कंफर्टेबल अब घूम रहा है हाँ ये
Okay, is elevator now? Elevator.
Sir, we have lost the picture from the OT.
What is that?
We have lost the picture. Yeah, now we are with you.
Okay. So I taking the flap, huh? Can I get the myos because this incision, the myos scissors, the normal myos, not myos, the normal scissors. The superior incision not complete, so I'll make it to the scissors. Okay. The only thing scissors will cause some bleeding. Yeah? There we go. There we go. Okay, the elevator now. See, when the defect is here in the cabriform plate, you can actually save the middle terminate, you can do the repair, but then if
Yes,
you
sir.
need the space, you can just remove the ethmoids and lateralize the terminate. If the space
Yes,
is
sir.
not sufficient, even after that, you can then like this and do the surgery. Okay. But anyway,
Yes,
in
sir.
all these scenarios, I'm actually saving the terminate. Even here, I not it back. Okay.
Yes, sir. Yes, sir.
And when I place the flap, I'm taking care not to occlude the frontal drainage. Okay.
Yes, sir.
Can you get a small patty? Small patty?
Sir, in your experience, how are the results with this carpet grafting of the area?
Results of what?
Sir, in your experience, what are what are the results in the carpet grafting of these areas where you cannot find the defect?
See, it actually, in case of intracranial hypertension, and if you don't see the defect, there is no other option. Huh?
Yes,
And
sir.
actually, I really hate these cases, but because intracranial hypertension, the results can be unpredictable.
Okay,
So
sir.
if you
Okay,
ask
sir.
me my results of CSF leak repair, generally,
Yeah. Yeah.
I would say like in the past, maybe just take my past 2 years,
Yes, sir.
I do like at least 3 cases every month. 3 cases of CSF
Okay,
leak
sir.
every month.
Okay,
So
sir.
maybe like I would have done at least 50 cases probably in the past 2 years. I think maybe yeah.
Yes, sir.
So of the 50 cases, I had 2 failures.
Okay, sir. Okay, sir. Great,
Okay.
sir.
The 2 failures actually the one was typically like the carpet grafting, intracranial hypertension patient. The patient came with a leak on the other side.
Okay, sir.
So I put the patient on. We did a manometer. The pressure was like 30, and we advised a shunt. The patient not willing for a shunt
Okay, sir.
because some patients, all patients are not willing for shunt. Some patients don't like to have the shunt. Okay.
Yes, sir.
Elevator.
Yes, sir.
And the other patient actually similar thing. The leak happened like 3 to 6 months down the line.
Okay, sir.
We put the patient on Diamox for a couple of. We increased the dose of Diamox. The leak stopped.
Okay, sir.
But it's very rare to have the patient to take the patient back again to the OT.
Yes, sir.
See now, if I put the graft like that, if the defect is underneath that, underneath the flap, the results are almost 100% because this is a vascularized flap. If you compare plugging a defect with your fat or something, like putting a cartilage and this flap,
Yes,
the
sir.
flap is definitely superior.
Yes, sir. The results are
Okay.
better with Westwise flaps.
Yeah. When I get a small mirror, I need to have the flap completely sticking in. A small mirror. Can you cut the mirror into 2 and give? Can you cut this? Yeah. Cut it. Cut this into 2. And you see, I like to. If you come, if I operate in some lives, so I'd like to have a lateral recess leak, a frontal sinus leak, a big defect, etc. Because those are interesting to watch. You will definitely see a defect. But here
Yes, sir.
we just had this particular case. But I think I have shown something useful to you. And,
Yes, sir.
okay.
Sir, do you secure these Westwise flaps with tissue glue or fibrin glue or not?
can use the glue if you have.
Okay, sir.
And here, even if you don't have the glue, you've done the repair properly. See, I'm now pressing the flap against the defect. Okay.
Yes, sir. Yes, sir. Yes, sir. Beautiful, sir.
Can I get the ball probe? I need to. Oh, this is wrong. I'll just use the dissector. Huh? And the other thing is, see, it is very rare to have the CSF getting a track indirectly. See, even if you have a small defect, the general principle in neurosurgery is the indirect leak generally seals by itself, huh? Unless it
Yes,
is
sir.
leaking into a big cavity like the eustachian tube.
Yes, sir.
Okay. If you
Yeah.
have a leak there, it won't track all the way here and come out like that. That is very rare.
Yes, sir.
That is something that is a general neurosurgical principle. Huh?
Yes, sir.
Okay. I'm sticking it all over properly like that.
Yes, sir.
And the pada, this actually this frontal is also kept. Can I get the teleposis now? The elevator, can you give my elevator, the normal elevator? I saw that. If you want, you can switch to the turbine. So it will hold a flap like that. Okay. Can I get the suction now? Okay. Elevator. And do we have the surgical? Can I get some surgical if we have it? Any questions on this?
No, sir. Beautiful, sir. Beautifully done,
Okay,
sir.
the turbinate is now back in normal anatomy position. It will seal so well. You put
Yes,
the
sir.
endoscope like after 2 to 3 months, it will look like a normal turbinate. You'll have some
Yes, sir.
crusting here. It will take some 2 to 3 months post to settle.
Okay, sir. Okay,
The
sir.
frontal sinus is patent. Can I get the small surgical?
Sir, I have one
Yes.
question, sir. Sir,
Yes, please.
in this patient, there was DNS on the left side or high DNS. So why did not you prefer to do septoplasty first, sir?
Because it was not required for that, because I could see the things even without septoplasty. That's why.
Okay, sir. Okay, sir.
You can do it. See. If you don't get the exposure, you can do it. There's nothing wrong in doing a septoplasty. Okay?
Yes, sir. Okay, sir. Okay, sir.
Can I get the glue now? Or maybe one more,
Yes, sir.
if you don't mind. A small piece of surgical. And generally, I don't know how true this is. What I learned from Professor Kasam is that he had some CSF leaks in skull-based surgery cases after using Otrivin nasal drops. So he says that when you use Otrivin, there can be vasoconstriction and necrosis of that the reconstruction area, and you can get CSF leak.
Yes, sir.
But after hearing that from him, I have stopped using Otrivin in these cases. So it is just based on expert's opinion. So generally, I don't use Otrivin in this sort of cases. I use saline sprays. I ask them not to use Otrivin. Huh?
Yes, sir. And sir, for how do you put any nasal packs post-operatively, sir?
There is an interesting question. See, here actually I have the turbinate. The middle turbinate is stabilizing the closure. Okay.
Yes, sir.
Okay. If you don't have some support to stabilize your closure, it is always
Yes, sir.
better to put a flap. See, there
Yes,
is
sir.
no ego in putting a flap. What is the ego in that? See, you have the closure, the pressure goes up, the closure can give way, right?
Yes, sir.
You generally place the flap for 3 days because it takes 3 days for the flap to adhere to the surrounding tissue. That is the principle of
sir.
putting the flap for 3 days,
Yes, sir.
right? But here, since I have the terminating position to stabilize the reconstruction, I can avoid a pack.
Okay, sir.
Right. The packing, no packing nowadays actually, I think there's a big deal in that. Just some personal preference and all that. I can leave it like that, but if I am going for I generally work in a corporate hospital. If I go for some dinner in the night and there is some oozing, they will call me. So generally place a pack. Or else in the night, there's some VIP patient
Yes,
will
sir.
come back.
Yes, sir.
So if I am around, I don't pack. It depends on your post of your schedule. Okay.
Yes, sir.
So I think I can leave it like that. You can just place some. No, pack. Okay, right. Okay. Any more questions or can I wind it up?
Yes, sir. Yes, sir. Fine, sir. Thank you, sir. Very nice demonstration, sir.
Thank you. Thank you so
Big
much.
round of applause for Felix, sir.
Thank you. Thank you so much. Thank you. So we'll have this. You want some pack? No, it's just other indication for packing. If you have an asthmatic patient, always pack. Because during extubation, it will go for laryngospasm. It will be difficult. Then it will be difficult to pack. They will also struggle to put a tube back. Because the asthma, the hyperreactive. So we'll keep it like that for the next case. Okay. Thank you. Now, what is the plan? We have had the inverter. So we'll have the inverter.
I was very, very frustrated.
We remove the mic to the other thing, other people.
लेकिन एनकरेजमेंट मिला कि ऐसा भी कर सकते हैं।
हाँ, इसका रिजल्ट एक बार
शेयर करना। हाँ, मैं करूँगा क्योंकि मेरे साथ ऐसा 2 केस में हुआ। मुझे डिफेक्ट हो गया, मैं बस 1-1.5 घंटे तक लगा रहा, कहीं डिफेक्ट नहीं दिखा। पैसा करा लिया, सब कुछ करा लिया, मैं यार
पता एक चीज है, आप पता नहीं होगा लेकिन एक्चुअली ना,
हाँ
में आप एक थ्री डायमेंशनल को बना सकते हो, जैसे एंटीरियर आर्टरी के एंटीरियर है या पोस्टीरियर है, ये तो पता चल जाता है।
ये तो पता चल जाता है, सही बात है।
हाँ अंकिता, गुड मॉर्निंग।
Our next case is patient Rajkumari Devi, 40 years female, came to the ENT OPD with the chief complaints of difficulty in breathing for 2 years. As stated by patient, she was apparently asymptomatic 2 years back when she developed difficulty in breathing that was associated with change in voice. There is history of tracheostomy in February 2023 in surgical oncology department of our institute. tracheostomy closure in July 2023 in our department. There is history of revision tracheostomy on 24th August 2023 by Dr. Rahul under supervision of Dr. Shiva S. Also, history of balloon dilatation of tracheal stenosis under general anesthesia by Dr. Shiva S on 25th of August 2023. There is also history of ADT intake for 9 months. She has stopped taking ADT 2 months back. There was no history of trauma or dysphagia. On examination, there is 2 to 3 centimeters scar mark of previous tracheostomy present on anterior neck. With this history and examination, we have kept provisional diagnosis of post-tracheostomy tracheal stenosis, and the plan of the surgery is balloon dilatation under general anesthesia.
लगा दो जल्दी और मॉनिटर ऑन करो पेशेंट्स स्टेट करो एक में पानी लो एक में ये लो एरिया लो 2 कटोरी
balloon dilatation.
बैठी डालो
Post-tracheostomy,
हाँ
soft.
हाँ रिफ्लेक्शन में हो गया दो बस गिर गया स्प्रे स्कोप सर्कल एक में सलाइन एक में फिलोपैथी लेरिंगोस्कोप हाँ कर दो ट्रॉली दो
Period में है ना?
इसमें कितने डाल दो पैसे दो और डाल देना नहीं ऑक्सीजन जनरेट हो स्ट्रॉन्ग लगो हाँ इसलिए तो बोल रहा था मैं हाई फ्लो लगा ना अरे ऐसे प्रॉन्ग नहीं है बोले प्रॉन्ग क्यों ना
भैया नेजल प्रॉन्ग
अभी मत लगाओ भाई गिरा अभी रुक जाओ
नहीं,
वाला मैंने उसको
ये मेरे को एक चीज राकेश कुमार तो सर को मैं ये चीज
जनरल सर्जन की तरह
नहीं यार हटाओ उसको
अच्छा लगाओ
So what you are going to washing your head or
10% लारिंगोस्कोप कहाँ है तुम्हारा
नहीं दो अलग अलग होती है एक्चुअली हमारा उनको जीए मिलता है एक ही होती है कॉन्ट्रैक्ट लिए हमको
मुंह खोलिए
हाँ वो उनका
मुंह खोलिए
मैं नहीं लग सकता मुझे उनका ये कहते थे टोटल
बस
स्पेशलिटी भी होती
कट भी दे दीजिए
नहीं देना नहीं है देना
फिर भी दे रहे एक्चुअली मतलब
नहीं, दो जी दो जी
एक जी एक है
आदमी
हाँ तीन
फैकल्टी 4 और 3
हाँ
4 दिन हुई।
एक्चुअली वो स्मार्ट एक्चुअली है ना ओटी से
भाई कर रहे हो प्री ऑक्सीजनेशन इज नॉट देयर है प्री
हेलो सर, राकेश सर।
या सर ये लगा दीजिए ऑक्सीजन पंप पेशेंट ऑक्सीजनेट हो जाए देन ओनली विल स्टार्ट। तो बेटा इंस्ट्रूमेंट में यूं रखना चाहिए, उल्टा उल्टा रखोगे तो गड़बड़ हो जाएगा। ये दिखेगा नहीं कौन सा इंस्ट्रूमेंट है। टिप पेशेंट डीट में जा रहा है ना।
भैया सक्शन क्या तरह दीजिएगा भैया
वो अभी गया है नहीं जाते हैं वैसे रहना और वो सिलेक्ट कर दिया हाँ लगाओ
हमारा सस्पेंशन सिस्टम का है लगाने वाला और एक शीट चाहिए होगी बेटा।
मेन यही कहना है सही थोड़ी देख लो तो पीजी को पढ़ाने के लिए पीजी को पढ़ाने के
रुको बेटा एक ही नॉस्ट्रल में चला गया। हाँ अब
में भी जाता
लेकिन स्टेट में उल्टा स्टेट में उल्टा है हमारे को कहते हैं आप जिला डाल के रखो
हाँ नहीं
ज्यादा मत करना अभी बता रहा हूँ मैं दिस वे।
कौन से आर्टिकल में हमारे
बैक मास्क में लेना तो बैक मास्क में ले लीजिए। Pre oxygenation of at least 6 minutes is required.
हमें पढ़ना इसी ऑफिस के बाद बैठ जाना है
जब आप कहेंगे तब सस्पेंड। सो ऐसा करेंगे लिसन straight away and lift the larynx. Okay, then you fix it here. Two things you have to take care. One is was patient under sedation, patient might move his head, so assist you have to control the suspension system. Okay, आपको इसको पकड़ना पड़ेगा, पेशेंट हिला सकता है।
क्या हो गया मेरे पीछे के पड़ गए
लाइट कैरियर दो, लाइट कैरियर लाइट कैरियर दो जल्दी से, सब लीड निकाल लो। अरे ये बाद में आएगा बड़ा, पहले डाल देते हैं। रेडी रखो तो खोल के रेडी रखो। ये नहीं लाइट कैरियर इसका लाइट सोर्स दो बेटा और उसका टेलीस्कोप आगे लाओ ना, ट्रॉली है और आगे लाओ इधर लाओ,
माले नहीं छोड़ा
इधर लाओ इधर। अच्छा टेलीस्कोप कहाँ रखा है? लास्ट टाइम बहुत स्ट्रगल करना है।
इसका नाम तो ग्रासी था।
ऐसे रखना है, ट्रबल शूटिंग बिल्कुल नहीं होनी चाहिए, है ना?
वो रूटीन डाल आप बना गया, आप लगता है कि जैसे आप चीजें नहीं करते आप, बिल्कुल तो ठीक है, मेरी गलती तो जिंदगी तो कटी रही है, बाकी तो
क्वालिटी से तय होता है ना, दोनों गेस कर देंगे।
लग जाएगा भैया, लगता है। पीछे करो। और ये हाथ क्या है? ये हाथ है क्या है? हाथ है क्या?
और
खींच लो साइड से, नीचे से यार। हाँ ठीक है।
मुझे ऐसा लगता है
हमें एक एमएलटी दे देना 4 नंबर की। अरे यार क्या कर रहे हो? पेशेंट का चेस्ट रिस्ट्रिक्ट करोगे, फिक्स करो जल्दी से। एक जने को ये पकड़ना है, ये भी टेलीस्कोप इमीडिएट।
बायोमेट्रिक सेंटर कंप्लीट तो हर कोई सेंटर
हेलो
हेलो
हेलो।
yes sir we are with you sir
Suspended the larynx to here fast.
yes sir we are getting the
1%.
picture now
Hello, 1% press it here. आप इसको पकड़िए मैडम, चल जाएगा। So now this is a good airway. Let me feel it first.
Yes, sir.
Suction नहीं, free suction दो. So I'm not using the suction, but I'm using the suction tip only, just to
Yes,
feel
sir.
the stenosis.
yes sir
So patient has got subglottic stenosis.
yes sir
Patient is spontaneously breathing. The age of the is a young patient.
yes sir
So this also looks like a hard stenosis on the posterior subglottis is relatively hard.
okay sir
And since this patient has a history of tuberculosis, most of
Yes,
these
sir.
patients are having periconditis,
yes sir
and that leads into the this type of firmness is there. So
Yes,
there is a
sir.
posterior. So just I'll do one thing. I'll just take out my laryngoscope. I'll see the movement of the cord because I can't see the movement of the cord. For this type of stenosis, sometimes fix the just मेरे को हाथ में दीजिए, आप हटा लीजिए हाथ. So I'm just looking at the movement of the cord, whether it is abducting or not, because patient is not under relaxant.
yes sir
So if you see it, patient is not abducting the cord.
yes sir
So this posterior glottic hard stenosis might be the cause of abduction and failed this thing problem. And
Yes,
cord
sir.
is almost like a cadaveric position with 5 mm of chink. So
Yes,
that is
sir.
why if the stenosis goes beyond 50% of the lumen, then the patient start developing the symptoms. And
Yes,
that is
sir.
why on resting patient is not having any symptoms. But once the patient has got physical activity, start brisk walking, patient has got distress. So hold it. फिर से वो suction देना without suction. इसको ऐसे पकड़िएगा. So what I'm going to check is the movement of the cricoarytenoid joint.
Yes, sir.
So it looks like the cricoarytenoid joint is also fixed.
Yes,
Because
sir.
once I move this cricoarytenoid joint, the other cord will also come on this side only. So this
Yes,
is
sir.
so only option left for me is to do the anterior, relieve the anterior stenosis.
Yes, sir.
This looks more fixed like the as compared to the left cord is still mobile, little bit cricoarytenoid joint, but the right side it is form like you cannot move the joint itself.
Yes, sir.
So right cricoid joint looks fixed. The other way around you can check is using a Lindholm vocal cord detector. So put the Lindholm detector in a reverse position. मिला detector वो एक Lindholm detector था ना vocal cord spreader होता है ऐसे करके
Dr. Rakesh, can we use general anesthesia for this case?
No, this patient is not tracheostomy, so we are preferring total intravenous anesthesia.
Okay.
So our anesthetist has given dextromethorphan, and this patient has got granulation tissue also. Can you see that?
Yes, sir.
And I will go just below also, below the cord and below the stenosis, and look
Yes,
for
sir.
the tracheal component also.
Yes, sir.
So
Sir, how we can prevent the
So,
aspiration in these cases, sir, post-operatively?
pardon?
How we can prevent the aspiration in these cases post-operatively, sir?
I just could not understand your question.
Sir,
Can
how
you
we
repeat?
can prevent the aspiration post-operatively in these cases after dedilatation?
Aspiration?
Yes, sir.
Aspiration will not be there because uh, sensation is maintained and the stenosis is long below the cord.
Sir, but the vocal cords are not adducting now. So how they will
But
prevent?
this will not affect as such. Only if the distance is too much, then only it will be a problem. So what I am going to do is I am not going to do the dissection with the coagulator also. I will just feel the anterior stenosis, and then I will think about it whether to use a coagulator or whether to use a cold instrument. The advantage of coagulator is there will be less of bleeding. If I use a sickle knife, there will be a bleeding. So let me first feel it again. Right carrier. एक मिनट रुको अच्छा इसको fix कर दो. Yeah. No, we'll keep it at very low level, and this much of irrigation will no problem for as far as the exchange of gases at the alveolar level. So that is not an issue as such, but we keep the irrigation at the very lowest level. अब आप जो है इसको दिखाएंगे ठीक से ऐसे कर बीच में करेंगे so that I can see, है ना? Obstruction लगाओ उसमें. So normally what in my setup what I do is I use a high flow oxygen, and I use not this otolaryngoscope. I use basically a modification of clean saucer in which I have made 6 holes on the back side of the clean saucer.
Sir, can you show us the external picture how you have suspended the laryngoscope inside the?
So I am using a otolaryngoscope, not the clean saucer.
Yes, sir.
I have not brought my own clean saucer because I thought since the high flow is not available here. So this case is basically a posterior glottic and the anterior glottic is anterior subglottic stenosis with limited abduction of cord. So patient will have some relief, but maybe because this is tubercular stenosis known to have periconditis, and since it looks like the right joint is fixed because of it, so patient might require later on open reconstruction because the posterior part of the cord is not suction. So this part मेरे को सिकल देना. मैं वो यूज नहीं करूंगा यार. I'm scared of using that. So tuberculosis of the larynx is an area very close to me because I am seeing a lot of cases of laryngeal tuberculosis. Sickle. And it present like a bronchial stenosis. It may present like because को tight है नहीं है, loose है लग रहा है. Tracheal stenosis. It present like a glottic stenosis, like this case, and it may present like a supraglottic stenosis. So tomorrow in my presentation, I'll show you the causes of थोड़ा सा दबाव ट्रैकिया बाहर से हल्का सा प्रेस करो. This looks like a hard stenosis. So I am using a cystoscope, not the normal nasal endoscope. I am using a cystoscope. And in my setup also I use the same cystoscope only. One can also use is a 5 mm of निकल लगाओ फिर से बैलून ले लेना बैलून 10 number 10 लेना. So इधर आ जाओ नरेन. How given the patient superior laryngeal block, transtracheal block, अब सक्शन दो, ब्लड आ रहा है, पैटी दो. पैटी दो, फॉर्सेप पे दो जल्दी से. और ये फॉर्सेप रखी थी हमने. हाँ स्ट्रेट फॉर्सेप. लाओ बैलून देना थोड़ा सा ठीक तरफ. अच्छा हाँ ब्लड कंट्रोल. आप उस पर देख के मॉनिटर पे मॉनिटर है ना थोड़ा सा लूज करो. हाँ भी बैलून लो जल्दी से दो. हाँ 10 है. ऑफ स्लेट आउट. बोलस रेडी. प्रोपोफॉल बोलस रेडी. देखिएगा पेन करेगा तभी दीजिएगा. डरेगा उसको पकड़ना. स्लेट निकाल लिया. अरे मिनट नहीं तो पहले वो करो ना 10 तक लेके जाओ. करो 10 तक ले जाओ. चुप करो. हाँ और करो 10 तक ले जाओ. 10 हो गया ना. वेट फॉर देखो कितने पे अपने यहाँ होता है. सेकंड नहीं अभी देखते. MLT है ना.
बैलून
हमें आइडिया है. घड़ी देख रहा ना सामने है. इसके बाद 12 ले लेगा. सेक्शन दो. नहीं only the सब glottis. For the bulk comes na the height because of the height of the. So normally height is around 4 centimeter I think. कितनी हाइट इसकी 4 सेंटीमीटर होगी ना. हाइट 4 सेंटीमीटर होगा।
हाँ प्लान कब तक बनूंगा?
चलो निकालो। देखिए यार कुछ पूरा कुछ फेल, something happened. Yes, some expansion is there. So something I could get. So final sizing is very important. Pre-sizing and post-dilatation sizing. So complications of a balloon is एक 12 नंबर पे इसके बाद complication of balloon is it might burst out, leading into the fluid to the airway. The other dreaded complication is at the critical level there are chances of death. Wait till it starts doing bag mass and look for the subcutaneous emphysema after 15 minutes of the completion of your surgery. Then feel that even in post-op also, so that it should emphysema. And lower down also the same problem can happen. That will be more dangerous than the. So that will lead into pneumomediastinum. These are the complications. So there is a specification for each and every balloon. There are two types of balloon. One is CRE balloon, other is non-CRE balloons. So controlled radial expansion is there, especially in gastroenterology. They have a CRE balloon that up to particular pressure they will expand to 8 millimeter or 10 mm or 12 mm. But the CRE, ये थोड़ा लेंथ इसकी ज्यादा है लग रहा है।
ये सेम है सर 4 सेंटीमीटर सारे।
अच्छा
16
जल्दी करो। हाँ there is a burst pressure specified with, I think इसका burst pressure 10 है।
So, sir, in tracheal dilatation, we usually use non-radial balloon dilatation, non-radial controlled.
तो देखो इसको प्रेस करना पड़ता है सर्जन को, जिसे आप दिखा नहीं पा रहे हो। नेक को प्रेस करके हाँ बीच में करोगे। And next is a protocol that we are using is a Canacort injection. Normally, I give 40 milligram at least, depending on the grade of stenosis and how much I can inject. Then after injecting, again we balloon it so that Canacort get displaced to surrounding area. And mitomycin C, we use it almost all cases. Follow-up is very important for these patients because the protocol which we follow is around 10 days post surgery. We follow then again 3rd week, then 6th week, and 3rd month. So normally the window time for any stenosis to reoccur is around 3 weeks to 6 weeks. So it might come back again after 3 weeks to 6 weeks when the healing settles. So during that time you can give serial injection of steroid in office. Chalo chodo सवा minute. So now patient, so final airway, but the problem with this patient is still the cord are not properly abducted. So abduction is not very good. That the right cord movement is still, so it looks like right cricoid joint is fixed because of, and we know that tuberculosis affect the posterior larynx more common than the anterior larynx, anterior glottis. So it is very clearly visible that left cord movement is there, right cord is fixed. So Canacort go jaldi sir. So follow up is very important. So normally my setup I usually give is ciprofloxacin ear drop, 1 ml of Ciplox D ear drop with either you mix it with normal saline or there is a hypernib. Hypernib is 3% saline. So hypernib, 3 to 4 ml of hypernib and 1 ml of ciprofloxacin and dexamethasone ear drop. That is minimum for 3 weeks. So the ciprofloxacin role is to prevent the pericarditis. And dexamethasone acts as a reduce. अच्छा नहीं है इसका भी होगा. Not very good. ये formulated है ना ये अच्छा नहीं है. Any question? कहना तो जल्दी से नहीं डाइल्यूट करना पड़ेगा इसको. ये जाएगा नहीं ऐसे. नहीं थोड़ा सा वो ले लो डिस्टिल वाटर ले लो. सलाइन ले लो थोड़ा सा. 1 ml ले लो. और ये निडल है यहाँ पे. इंजेक्शन निडल है नीचे मैंने कहा.
मैं वही पूछने वाला हूँ.
यहाँ पे होगी.
चलो ठीक है आज जाना है.
लंबी सी है निडल. नहीं यहाँ रखिए.
Hello, Rakesh sir.
Yes sir.
Sir, you have used the sickle knife in the region of the anterior commissure, below the anterior commissure
And posterior commissure.
Yes, sir. So the raw area which you have created will it not lead to restenosis of the lesion?
No, that is what I am doing it, injecting steroid and mitomycin C. So
Okay,
here I am
sir.
injecting it because this is the only joint where I can do it. Because right joint, cricoid joint is fixed. So lucky enough, I got the plane. Because right chord, देखो ये push नहीं होता है. इसके साथ सबसे बड़ी प्रॉब्लम यही है. इसलिए dilute करता है ना. Canal cord is very difficult to push. कितना गया? हाफ cc ना. तो ये है. So always dilute it. थोड़ा दबाओ ट्रैकिया. हल्का दबाओ. हाँ. Oh, it has come out. अब ठीक है. So what I'll do from superior supraglottis level. So that छोड़ दो. ना वो दो. देखो फिर से बैलून दो. वही सेम साइज. 12 नंबर. जल्दी दो. अरे यार डिफ्लेट तो करो यार. इसका स्टिलेट पड़ा है.
Sir,
स्टिलेट डालो नहीं ये जाएगा.
Rakesh sir.
Yes.
Sir, what is the pressure of the balloon which you have used just now?
Pressure.
Yes, sir.
Pressure I have gone to up to 10 atmospheric.
Okay, sir. And for how long you keep it there, the balloon?
How long? It depends on the. Otherwise, normally more than a minute, 45 seconds is good enough. निकालो जल्दी निकालो.
Okay, sir.
So
Sir, because the station tube company says that you have
with
to keep.
with high flow, you can leave it for 3 minutes also. It depends
Yes,
on
sir.
how's the lung condition of the patient. Start.
Okay, sir.
Depend on the condition of the patient and looking at the
And-
saturation.
Okay, sir. So do we have to repeat these balloon dilatations or one sitting is enough?
एक मिनट लूज करो. लूज करो. आप करो फिर से. जॉइंट हिल जाएगा. दोनों चीज हो जाए. अगर जॉइंट फिक्स होगा ना. नहीं रुको फिर से लग गया. इसके साथ यही प्रॉब्लम है. नहीं रुको डिफ्लेट करो जल्दी से. Now you do it. So there are other balloons also, which has got a, if you inflate it, it will first inflate the distal end, then inflate the proximal end and the middle. अरे यार फिर नीचे जा रहा है. हाँ, बैलून क्या है यार, दिख ही नहीं रहा है. इसको ठीक से दिखाओ बेटा, हमें दिख नहीं रहा. हाँ, आप करो. And the other important thing for the patient to have a good healing, for the residents, ENT residents, is you have to downsize the tracheostomy tube immediately.
Yes, sir.
So that patient start breathing from. फिर नीचे सरक जा रहा है, तो नहीं क्या?
Yes, sir.
देखो बहुत नीचे है ना.
Sir, do we have to repeat this procedure or only one sitting is enough?
Deflate करो, deflate. देखो तो यार, you have to see there ना. अब करो. नहीं रुक रहा. बैलून को क्या हो गया था? अब ठीक है. चलो ठीक है, ज्वाइन रहेगा. पैटी दे देना, माइटोमाइसिस. देखो ठीक से दिखाओ बेटा. हाँ. So that patient should start breathing from above, and epithelialization start early, and nebulization has to be done from the mouth, not from tracheostomy.
Yes.
For the
Yes, sir.
resident.
Sir, do
Nebulization
we
जो
have
है
to?
कराना है, डाउनसाइज कर देना है ट्यूब को.
Yes,
ठीक है,
sir.
तुरंत ही 6 नंबर पे कर लो इसको, नॉन कफ 6 नंबर पे, and give her one more another tube, extra tube, so that if it gets blocked, some problem is there, patient can change it, the attendant can change the tube and start phonating from day one. The patient will get confidence. On nebulization 7th or 10th day, you see patient again, flexible scopy. If there is some, it looks like some this thing, wait for another 7 days. Then 14th day, if you see there's a gallation, then give a shot of steroid in office. Intralesional steroid.
Yes.
CL injection of छोड़ दो. करो. अब दिखाओ ठीक से दिखाओ. अरे यार तुम दिखा नहीं रहे, क्या बात है? क्या देखेंगे वो लोग यार? You're not showing it properly. छोड़ दो, मैडम भी ठीक से नहीं पता है. Small mucosal flap which is hanging up. ठीक है.
Sir, do we have to repeat this procedure or only one sitting is enough?
अब लगाओ फिर से. No, one setting is good enough. But if the patient requires more than 3 to 4 sitting in a year, then it means this patient requires. इसको fix करो, ठीक से fix नहीं है. Fix करो. खुल गया आपका. उल्टा कर रहे हो. हाँ. ऐसे पकड़ो बेटा. हाँ, fix करो. अरे उल्टा हो रहा है बेटा. अब आप ऐसे पकड़ो बेटा ना. म्यूकोसल टैग है ना, उसको हटाना पड़ेगा. अरे बेटा अंदर नहीं लगा हुआ है, कहाँ कर रहे हो तुम, है ना? हवा में कर रहे हो. इसको अंदर डालो बेटा, है ना? हाँ, अंदर डालो, इसको फिक्स करो. लुक हियर. हाँ ठीक है, बस इसको उठाए रखो बेटा. लुक देयर इन द मॉनिटर, नॉट हियर. अब देखे रहो. हाँ बस लाओ. फॉरसेप दो. अप टर्न कप फॉरसेप. अप टर्न कप फॉरसेप.
Rakesh boss, good morning.
हाँ.
Myself, Dr. Jitendra Yadav from Jhansi.
Yes, boss.
Nice
Cup
presentation. So, what is the cause of stenosis in this case?
पोस्ट ट्यूबरकुलर. हाँ ये कफ फॉरसेप.
Post
tubercular stenosis.
Okay.
Post tubercular laryngeal tuberculosis.
This is a rare case.
Post tubercular stenosis.
Dr. Rakesh, Dr. Rohit Sharma. Hello.
Good morning. Good afternoon.
क्या हाल है जी? Good afternoon. What is your experience regarding coagulation assisted subglottic?
Subglottic, if it is hard, then you should not use a coablator. I learned the technique from Ramandeep. Well, he published an article. After that, I started using it, but very cautiously, especially in soft stenosis or a firm stenosis, but not the like this one, like cartilaginous stenosis. Better to use a cold instrument rather than use a coablator. Because this, you are sitting at the very important area, that is subglottis, where you have a high chances of. The problem with this patient is not the subglottis. The problem is with this patient is the right chord movement is not there. It is in paramedian position, and because of that, patient is having these issues. Subglottis can be managed by medical management also, by good position, downsizing the tube, and hopefully, if this remains like this, patient might not require any surgery. One chord, paramedian, still she can be managed. If the BMI is, the weight is very important. Weight of the patient, how much of oxygen is required for this patient. So these patients adapt naturally with this type of airway.
Does the length of stenosis have any bearing on your mode of treatment?
Yeah, 1 centimeter more will go for open. But it depends on the type of stenosis, which is I think is more important than the length. Type of stenosis means whether it's a granulation tissue, whether it's a fresh stenosis, whether the patient is having a firm stenosis, whether the patient is having hard. If it is hard stenosis of more than 1 centimeter, no use of any endoscopic. हाँ और है ना? लगाओ.
Any patient where you had to do a tracheal resection and anastomosis?
Anastomosis and open reconstruction, any form of open.
No, any.
कहाँ फंस रहा है?
So how many patients percentage wise कितनों में आपको जरूरत?
जरा एयरवे दिखा दो मेरे को.
Sir, what are the chances of recurrence in this case?
Chances, because post are very notorious for it. हाँ इसी पे देखा. So I am applying mitomycin C 2 milligram per. And normally there are two ways you can apply the mitomycin C. One is like this way. You just leave it there at the raw areas for 2 to 3 minutes. Other way around, you can apply it over the endotracheal tube on cuff. Just tie this fortnight patty over the endotracheal tube and put it in the airway so that it get absorbed from the mucosa. So role of this dual Budicort nebulization has got no role in this patient unless until patient has got some other pathology in the airway, that is lungs or some alveolar problem issue is there. But normally ciprofloxacin dexamethasone with 3% normal saline, that is hypernip, will do it. So
Is it a customized patient?
no, this is not a custom. This is spontaneously breathing patient. It's all, everything has got absorbed like that.
Check.
So this looks like a okay. And what I'll do is just downsize the tube. Tube ले आना 6 नंबर बदल दे. तो है ना? इसको downsize कर दे, non cuff अब इसको change ही कर देते हैं, है ना? अच्छा sorry, ये तो है ही नहीं. No, sorry, I get confused. नहीं, sir. Actually, I thought this patient is just mine.
What is your experience with T2 in this type of case?
No. Actually, मैं सोच रहा था कि no. So T tube is basically any stent in the airway. Not good actually, but being from a global south, poor country, we use a stent, and there are various indication for using a stent. Like if you have a long segment stenosis, then you can use a stent. Like or if you don't have a ICU backup, proper ICU backup, then you can use a T-tube because that will secure your airway. And otherwise, any foreign body in the air is always will cause some reaction in the airway. So best way is to do a single stage. But in my setting also, I am doing it double stage because ICU backup is a main concern. And third is the cost of the treatment. The cost of the treatment almost doubles if you do a one-stage surgery. So one-stage patient has to stay in ICU minimum for 3 to 5 days. So these are the issues.
Sir, if this patient come again restenosis, then what is your
That is what I am saying.
treatment of
If the patient has got more than 3 procedures, endoscopic procedure, then you have to go for open surgery. For this patient, in my setup, I would have done is right-sided in the same sitting, today's sitting only. I would have done the right posterior cordotomy with partial aortectomy, so as to give a patient a 4 mm of extra airway to this patient and wait for the 6 weeks time, so that patient can be managed endoscopically. But your question, I think direct question is that whether to use a T-tube or not, because T-tube is the simplest thing which you can do it in your setup. So T-tube is a viable option, but only if it is a long segment stenosis, or if you think that you don't have a ICU backup, like you expected, keep the patient for 5 days in ICU, then you can use a T-tube, but it should be at least below the cricoid. It should not come above the cricoid, because then patient will have a aspiration problem issues. So whatever will be there, patient neck movement, the T-tube will, the proximal end of T-tube will come above the cord. Once it comes above the cord, then the patient will have a aspiration issues and voice problems. And if the T-tube hits the proximal end of T-tube hits the posterior subglottis, then patient might have a granulation tissue formation that will lead into the joint fixation later on. So it is a foreign body actually. So you have to be away from the subglottis, and you can use it in the trachea. There's no problem. There's no harm into it. Because in All India Institute, they are using T-tube very often, and almost in all cases they are using T-tube. The other thing about the T-tube is, once you are putting a T-tube, always put a drain at least for 48 hours, because there will be some leak will be there, and patient might have a emphysema. So always put a drain above the muscle plane where you have repaired the trachea, above the muscle plane, so that if there is some leak from the surrounding area, it will not cause emphysema. So that depends on your post-operative round, which you take on day 1, day 2, day 3. If that emphysema is not there, then you can take out the drain after it. So these are the important caution you need to take when you are doing by putting a T-tube. But I am not against T-tube, because I am also using a T-tube, and it is always be safer to use T-tube because it secures airway. And life is very important for, there's no heroic in it, doing a heroic surgery and landing in a compromised way, or you lose the patient. So you should not lose the patient, and everything has to be controlled in a proper way. And whatever setup you are doing it, you have to justify it that, and don't give any relaxant once you are doing this type of endoscopic procedure. Suppose this patient was a tracheostomized patient, so that is what I was telling it. The patient is a tracheostomized patient, I would have immediately downsized the tracheostomy tube first, because that will help in the patient epithelialization of the raw area and nebulization from mouth, not from the tracheostomy side. For this patient, non-tracheostomized, so I was having that impression that patient is tracheostomized. So this is very important for even for if you're doing a suprastomal granulation. For suprastromal cannulation, if you are doing in a cuff patient who has got a cuff tracheostomy tube, you immediately do one thing is take out the cannulation, everything by cold instrument or whatever tool you are having, debrider or whatever, and first downsize the tube, because if you are using a cuff tube, that is a source of infection in that area. Because if you see there are a lot of secretion will be there, that will cause gram negative, gram positive, all type of infection will be there. So downsizing is start utilization from mouth, so that you will have very good epithelialization. The patient start phonetic from day one and start corking from day one, so that patient start speaking and he will gain confidence. And expansion of the posterior wall of the trachea will be there. So air will be flowing through it and epithelialization will be faster. And when the patient is having nebulization, patient has to close the tracheostomy and nebulize from the mouth. So that is how it has to be managed. Otherwise, if you put the same tube again, then again the suprastromal cannulation is going to come and patient will again have a stenosis. So downsize it, make it a non-cuff tube. Downsize if adult patient 6 number is the ideal size, so that from the sides patient can breathe. The outer diameter of a 6 number of not 7.6 or 7. So you will have a almost 50%. Adult trachea is 14 to Indian trachea 14 to 16 millimeter. So you will have 7 millimeter extra airway through which patient can breathe. And that is a good for patient to decannulate, because 50% airway is good enough for a patient to get it. Any question?
Thank you, sir.
Thank you, Rakesh boss. Nice presentation.
Thank you. इसके बाद भी सेम ही रहेगा.
Our next case, patient Harish Sagir, 14 years male, came to our OPD with the chief complaints of right ear discharge for 6 years. As stated by the patient, he was apparently asymptomatic 6 years back when he developed right ear discharge that was purulent, scanty, and foul smelling. Discharge-free period was 20 days and the ear was active. He also complained of right ear hard of hearing and frequent sneeze and cold. There is history of right cortical mastoidectomy with type 3 cartilage tympanoplasty by some local doctor on 19th of January 2022. There is no history of trauma, vertigo, vomiting, facial elevation, and right ear ringing sensation. On examination of the left ear, EAC was normal, cone of light was present, the tympanic membrane was intact. On examination of the right ear, scar mark was present of previous surgery in the right post-oral region. EAC was normal, cone of light was absent, pars tensa was retracted at the entire superior quadrant, and white debris was present over the attic that suggests cholesteatoma. We did pure tone audiometry of the patient. Of the left ear, it was normal. On the right ear, it was showed moderate conductive hearing loss. On CCT of the temporal bone, a large surgical cavity in the right mastoid antrum and the middle ear cavity with subtle erosions of the tympanic segment of facial nerve canal and extensions and erosions that suggest recurrence of the cholestoma. We came up with a provisional diagnosis of right-sided chronic suppurative otitis media of squamosal type with moderate conductive hair loss. We planned for right tympanomastoidectomy under general anesthesia.
फिर मैं माइक्रोस्कोप लगा मैं हाँ हाँ वहाँ बता दो उन्हें दिखा दो ना कि बस अब फिर हम शुरू करते हैं अपना अच्छा हो गया ठीक है लाओ फिर माइक्रोस्कोप दो क्योंकि बिना माइक्रोस्कोप के तो दिखागा नहीं नीचे ना ये थोड़ा सा मैं इससे हटा रहा हूँ ताकि डेमोन्स्ट्रेशन में आसान रहे ठीक ठीक है किधर माइक्रोस्कोप उधर गई ठीक है ठीक तो मैं तब तक और मोटा काम कर लेता हूँ और बढ़िया लाओ ड्रिल लाओ सिस्टम में हाँ हाँ वो तो उधर चला गया ना माइक्रोस्कोप हमारा जाएगा उधर कुछ अभी नहीं जा रहा ड्रिल लगाओ वो माइक्रोस्कोप ले गए ना तो वो टॉन्सिल करने के लिए तो ठीक है मैं और कर देता हूँ तब तक ड्रिल पे लगा देना बस कौन कौन से हैं अभी अभी तो ये ले लो आएगा कोई बात नहीं मैं 5 मिनट ऐसे कर देता हूँ ना इसकी वो देना मुझे बेटा सेक्शन थोड़ा सा चेंज करना कौन सा है ये नहीं किधर है ये पेडल एक बार ये वाला ना गुड गुड हाँ बस ठीक है अब पानी तब तक मैं ये सारी डस्ट हटा देता हूँ ना क्योंकि उन्हें दिखना भी तो चाहिए ना कुछ ये या तो ये है कि अब तब तक हम उन्हें मोटी मोटी चीज दिखा देंगे एक्सटर्नल कैमरे से दिखा सकते हैं एक्सटर्नल कैमरे से दिखा सकते हैं थोड़ा बहुत है हाँ जब तक वो माइक्रोस्कोप लगाते हैं एक बार हम तब तक बता देते हैं हाँ नहीं, मैं अभी तो मोटा मोटा कर रहा हूँ, माइक्रोस्कोप से दिखाएंगे ना उनको तो हाँ, तो मैं भी मोटा मोटा तब तक कर रहा हूँ ताकि उन्हें बता देंगे कि क्या क्या करना है। ये भाई ये एकदम इंटेक्ट चैनल लोग देखते नहीं है क्या चल रहा है, इतने बड़े प्लेटफॉर्म में, और वो भी कार्टिलेज लगा दिया है ताकि और भी हाँ वो बंद हो जाता, हो गया फर्स्ट से तो मैं भी स्लीप में फंसेगा ना। मैं कैविटी के साथ ही सब्सक्राइब करता जा रहा हूँ। अच्छा, वहां से क्या दिखेगा उधर? वो स्लो हमारी जा रही है या उधर वालों की जा रही है? अच्छा अच्छा। तो उधर से तो किसी की नहीं आ रही है। ये साइनस आने लगा ब्लूइश का। हैंडल बहुत गर्म हो गया।
आदत से है तो हैंडल बहुत गर्म हो गया।
हैंड पीस खत्म हो गया उसको लैपटॉप का भी यार हो गया देख लो
Our next case will be patient Kumar Pandey, 5 years male, came up to the ENT OPD with a chief complaints of open mouth bleeding for 2 years. As stated by the patient's attendant, he was apparently asymptomatic 2 years back when he developed open mouth bleeding that was associated with foreign body sensation in throat, frequent sneeze and cold, halitosis, and fever. There is no history of fever, trauma, prior ENT surgery, throat pain, and GERD. On examination, we found bilateral grade 3 tonsils. On X-ray of the nasopharynx, we can see adenoid hypertrophy. We made a provisional diagnosis of adenotonsillitis and planned for adenotonsillectomy under general anesthesia.
सक्शन चल रहा है क्या? चालू करो ना. All right. ठीक है. Can we start? Auditorium, please. Auditorium, please. Shiva, I am ready. Is the, yeah, you can, please. Can you let me know about the picture quality? How is the picture quality? Because I cannot see, na. Acha, it's coming up. Very nice. So who is moderating? Hi, Dr. SK. So after the tonsil, Shiva, after the tonsillectomy, the monitor has to come here. If you want to shift it now, you can shift it now. Yes, this monitor. अभी आपको जब कराना करा दो, या तो होने के बाद फिर 5 मिनट वेट करके करा लो. You tell me when I can start, because I do not have any feedback. Hello.
Yes, you can do.
You can start, sir. But we are not having a microscopic picture, sir. This is external camera.
Okay. No, we will have to see the microscopic picture first. All right. So you are able to see me, right? Please pardon me for keeping my
Yes, your face
mask
looking good.
Yeah, because otherwise the sound will not be clear. All right. And this is adenotonsil, so sterility is not a problem. Can you see the position of the patient?
Yeah, yeah.
I'm using microscope for tonsillectomy. I'll do 3 procedures in this patient. Extra can we have complete silence in the theater? Hello? Excuse me. Please, complete silence. So I'll do extracapsular surgery on the right side, intracapsular surgery on the left, and then endoscopic tonsillectomy, adenoidectomy as the third procedure.
Yes, picture is visible.
Okay, are you getting the endoscopic microscopic picture?
Yeah, yeah.
All right. So can you see that this is the right tonsil of the patient?
Yes.
Can you see that I have pulled the uvula with a infant feeding tube so that it does not get pulled into my suction? All right. Who is moderating?
Sir, myself,
Who is
Dr. Rajesh.
moderating?
Dr. Rajesh from Dr.
And
Rajesh, sir.
And Dr. Jiten Yadav from Jhansi.
Hi, Dr. Arya. So Rajesh, this is the, can you see this is the anterior pillar of the child?
Sir, microscope picture is not there, sir. Only external picture is there, sir.
No, there's
External
no
camera.
point. We'll wait. We'll wait.
Audio visual.
Yeah, they're doing it.
So cobbleter से कर रहे हैं. Cobbleter से कर रहे हैं. Cobbleter से. नई टेक्नोलॉजी है. नई टेक्नोलॉजी है cobbleter से. ये दोबारा हो जाता. निकालो पूरा.
Now we are getting, sir.
So the aim is to perform a bloodless and painless tonsillectomy. The other way.
All right. Audio visual, are you getting it?
Yeah, sir. We are getting.
The microscopic picture?
Yeah, sir. We are getting microscopic pictures.
Okay, is it clear?
Everything is clear, sir. Please go ahead.
All right. Yeah, thank you. So now you can see this is the anterior pillar. If you start the dissection here, you'll never get into the plane because the tonsil is ending here. Now complete silence, please. Complete silence. Nobody talks. So now what I'm doing is, this is the extracapsular tonsillectomy. I am pulling the tonsil completely medial and starting my incision at the lateral border of the tonsil. But you see, this is the anterior pillar. I am taking away a small rim of the anterior pillar. All right.
Okay, sir.
I'm just getting used to this system. Now you see, I have made my mark and I'll get the correct plane first. Can you see this?
Yes, sir.
If I do not get the correct plane, the tonsil is not going to come out clean. Now, can you see the tonsil tissue?
Yes, sir.
Give me the lux forceps. Obviously, the tonsil is pretty vascular. Lux forceps. All right, no problem. Yeah, tonsil holding is fine.
Internal carotid का आ रहा होगा बस.
So now I'll hold the tonsil with a tonsil holding forceps and pull the tonsil medially. All right.
Okay, sir.
And get lateral to the tonsil. If you do not get lateral to the tonsil, you will not get the correct plane. And if you do not get into the correct plane, the surgery is not going to be painless and bloodless. So are you able to see the tonsil plane?
Yes, sir.
And can you see that my
you are
probation
in-
wand is facing towards the tonsil?
Sir, you are in peritonsillar plane, na, sir?
Yes, I'm in peritonsillar plane. Absolutely correct. Because this is extracapsular surgery.
Okay, sir.
All right.
Okay, sir.
Now I'll try to hold it more lateral. So can you see the plane?
Yes, sir. Very nice, sir.
Correct. So
Capsule-
that's
capsule
the
is
plane you have
visible.
to get in. But at the same time, you don't have to open up the muscles. So I'll be dissecting on the connecting fibers, neither on the lymphoid tissue nor on the muscles. All right.
Okay.
That's the correct plane.
Yeah, yeah.
So no damage to the muscles. Can you see the fascia is absolutely clearly seen? Muscle is
Yes,
not.
yes.
Right. So if you do this, this will be a perfect painless tonsillectomy, even extracapsular. Now I am going inferiorly. I have opened the tonsil like a book. All right. See, till now there is no exposure of the muscles. I can see a very small twig. Who is moving the table, please? What are you doing?
Are you moving?
All right, do it. I'll wait. I'll wait. So see, there is no exposure of the muscle till now. Can you see this small vessel?
Yes, sir. Sir, this is the
Rajesh?
posterior. Yes, sir. Is this the posterior pillar, sir, on which you are dissecting,
This
sir?
is the posterior pillar. This
Okay,
is the
sir.
anterior pillar. This is the small vessel which I am coagulating. All right.
Okay, sir.
The patient is still moving. I'll wait till they finish their intervention.
Capsule is clearly visible.
Yeah, so see, anybody can do a tonsillectomy. What is the big deal about it? Idea is to do it painless and bloodless and guarantee that your child will not have pain and bleeding. Assurance is the only thing which is different. Now, you do not operate into the plane, you operate medial to the plane. So I'll again hold it more inferiorly. Can you see no muscle exposure till now? This small blood vessel I'm coagulating. right? And now again I get into the correct plane. Now you see at the posterior pillar and the superior and the inferior pole, the tonsil is firmly attached. So obviously I have to, can you see this? This dissection is
Yes,
not
sir.
as same as this. The fossa is very, very clear. The posterior pillar, some of the muscles are exposed. That's where the child is going to get a little pain. All right. Now I have reached the lower pole. Where is the lower pole? It is here. I have not still gone into the lower pole. But before going into the lower pole, I know that the tonsillar artery will not come here. It will come somewhere here. Can we have complete silence, please? Why are you talking? You take the microphone and talk, na? So what I'll do is, I'll coagulate the area. First, let me go a little more deep. Now, the tonsillar artery can come anywhere here. Can you see this vessel?
Yeah, sir. Very clear, sir.
Could it be the tonsillar artery or not? Very much possible. One of the branches of the tonsillar artery. Can you see this? Now,
Yes,
if
sir.
I open it here, it will retract, and this will open later in the post-operative period and bleed on the 7th day. So what I'll do is, I'll coagulate it along the length and then dissect it medial. That is the key to prevent bleeding on day 7, day 10. I'm coagulating the whole length of the tonsillar artery and then dissecting on the medial aspect. By doing this, your tonsil will not bleed on day 7, day 10. All right.
All right, sir.
Again.
Excuse me.
Yes.
What are your settings for the coablator? Ablation
7 and
setting
3.
7 and 3 only.
7 and 3.
And which is the wand, evac or which
evac
one?
70.
Evac.
Standard evac 70 extra SP. Standard one. So again, see, this is a complete tonsillectomy, but I'm coagulating along the length of the tonsillar artery. Rajesh sir?
Sir. Very fine. Sir. Very clear,
Dr.
sir.
Rajesh?
Very clear, sir.
Rajesh Vishwakarma sir here.
Okay, sir.
So now this is the technique by which you do 100% complete tonsillectomy without bleeding, without chance of or you can go intracapsular here. If you want, you can also go little intracapsular like this. But I'm showing a complete tonsillectomy here. So you can go little intracapsular or you coagulate and...
Sir, no picture is there, sir, on the screen, sir.
All right, I'll wait. Audio visual. एकदम क्लियर है सर ये कैसा बचाना है ब्लीडिंग now see the whole fascia there is no muscle exposure anywhere चालू हो गया auditorium are you seeing it auditorium
Fine, sir. आवाज है, सर.
ऑडियो विजुअल में हाँ ठीक है
आवाज है, सर. आवाज है, सर. हाँ.
पिक्चर है
हाँ, everything is fine, sir.
All right, ठीक है. So now see this. Either you can go intracapsular here like this, or even if you are extracapsular, first you coagulate lateral to this. तो जो भी tonsillar artery की branch वहाँ पे आ रही है वो बंद हो जाएगी उसके medial aspect पर, or you go intracapsular and last bit very small amount of tissue you can leave, है ना? ये दोनों भी करके आप दोनों में से जो पसंद हो वो करो. So here I am keeping a small cuff of tissue over the tonsillar artery, but अगर बहुत ज्यादा रख लेंगे तो वो बाद में tonsillar tag बन करके सामने आएगा.
Okay, sir.
Right? So you choose out of these two whatever suits you. Now it is a complete tonsillectomy. Here there is a very small bit of tissue, and this is a complete tonsillectomy.
Very good dissection,
All right.
sir.
Now I'll show you the.
Hello, sir. This is Dr. Misudia from Jhansi. Well done, sir.
Yes, sir. सर देखिए अभी इसमें मसल्स कहीं भी दिख रही है क्या? ये सिर्फ यहाँ पे मसल थोड़ी सी एक्सपोज हुई है, बाकी कहीं भी मसल नहीं दिख रही है. Therefore, this surgery is going to be painless and bloodless. All right, sir. Now we'll change the tube. Will come to the other side. A tube change, please. तो काम करने को तो 5 मिनट ही लगता है, उसकी तैयारी को 15 मिनट लगता है. Tube to the other side, please. ये दोनों. Tube for questions. Tube on the other side. करो करो. सॉरी, जब भी बात कर रहा होता हूँ मैं, इधर से डिस्ट्रैक्शन आएगा तो अच्छा नहीं होगा ना. आपका कॉन्फिडेंस है, क्यों खराब? Tube on the other side, please. So just give me 2 minutes. That changing the tube to the other side. Any questions on right side complete tonsillectomy? So Dr. Rajesh Vishwakarma is asking why you are leaving little bit of tissue on the tonsillar artery. तो जैसे अगर tonsillar artery को, as I explained, कि if I cut the tonsillar artery and coagulate, it might bleed later on. So either you coagulate it along the length and dissect on the medial aspect, then the chances of bleeding is much less. If you leave a very little of tissue, it acts like a natural ligature, and you coagulate it. So there's no need to take a tie. You can take a tie, but then if you take a tie, you will tie along with some tissue. That tissue will necrose. When the tissue necroses, there's a chance of secondary bleeding. Here, there's practically no chance of secondary bleeding because you have only coagulated the vessel and you have left a little bit of tissue at some point, or you, even if you do not leave, coagulate it along the length. Any other questions? Now I'll go for intracapsular surgery on the left side. So in extracapsular surgery, though this case we could do a very nice, we could get a very nice plane, but many a times you cannot get such a nice plane. So wherever, here also in the posterior pillar, you had little bit of muscle exposure. That part is going to hurt. And I had to sacrifice a little bit of the anterior pillar. So both the pillars will hurt a little bit. If I do intracapsular, I'll not even touch the pillars. So that will be completely painless. And I'll leave a little bit of tissue all around. So no chance of any bleeding. Is almost zero, sir. Almost zero. No, so see, it's not the tool, it is the understanding of the tool. So every tool has a learning curve. So that's what I tried to explain, how you can do a complete painless and bloodless surgery with the coagulator. Because in my initial days, I had a lot of bleeding, a lot of pain. Every patient would have more pain than routine tonsillectomy. So obviously, I took my time to learn. Yeah, so not a problem. It will take more time and more bond. Yeah, plane is not a problem. Plane is never a problem. If you do intracapsular, then you will take more time to reach. But if you take extracapsular, you pull it out. No? You pull it out. Pulling out is most important. Howsoever huge is the tonsil. Yeah, intracapsular you will take more time because you have to keep on melting it. So I'll show it on this case. Hey, Shirish, how are you? Nice to see you. Mouth gag, please. Yes. Shirish, yeah, I was also going to ask. Have you come on your bicycle? All right. So auditorium, any questions you have on the complete tonsillectomy? Dr. Rajesh in the auditorium. Is the picture, sound,
It's fine,
everything
sir.
clear?
Picture is very good, sir.
Thank you. So now, you see, I have shifted the tube to the right. Give me the throat pack, please. Are you getting the inside picture again?
Yeah, yes, sir.
All right. So I'll just put the throat pack. Now, the intracapsular tonsillectomy will take little more time. Why? Because here I have to do more ablation of the tissues. So this is like an adenodectomy, and the indication for this intracapsular surgeries are pure obstructive sleep apnea when the child is very small, even infective tonsil if the child is very small. So here I'll go to the setting of 9. Can you go on to setting of 9? Ablation on 9, please. And see, so basically intracapsular surgery generally we prefer for very young kids. Now see what I'll do here, I'll pull the anterior pillar laterally. Here the mouth gag is not fitted so well because the lower pole of the tonsil is not very well visible. The tongue is still coming in my way. Give me a minute. Give me a minute. I just, mouth gag is a little big for the child, and the other one we have is very small. All right, apply it now. So there is no harm in waiting for a few minutes till you get the correct exposure. Are you able to see it now, Dr. Rajesh?
Yes, sir.
All right. So now, see, this is the anterior pillar. So I'll retract the anterior pillar, and this is the whole bulk of the tonsil. So we'll melt the tonsil. Can you switch on the suction? The suction is not very strong. Can you increase the suction power of the wand? Suction power increase koi karega? No, it's not working. Please, suction. No, it's not working. See, your coblation will not work if the suction is not working. Suction, please. Microdebrider and coblation cannot work without suction. No. Yes. 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 Thank you. All right. So now what I'm doing is I am only ablating the tonsil. Now I am only ablating the tonsil, but I'll ablate it right till the fascia. All right. So now I'll make sure that I do not damage the pillars at all. Can we have silence, please? It's my humble request. Silence in the theater, please. Now see, the moment I go close to the pillar, can you see the contraction? So I'll make sure that I do not damage the pillars. Most important thing is that I still have to go right till the capsule. If I do not go right till the capsule, it will be an incomplete surgery. So this much is not enough. Many people leave it at this point. If you leave it at this point, what will happen is that sooner or later, the tonsils will regrow and you'll have to again perform the surgery. You can't leave all this tissue behind. Though this much is enough for the child's symptoms, but if you leave behind the upper pole, ये इसके बीच में ऐसा सर, ऑलराइट, ये क्या हो रहा है, इसका हैंडल मेरे हैंडल लग रहा है, नो प्रॉब्लम, ये हैंडल लग रहा है, ये हैंडल लग रहा है सर. So see what happened, accidentally this touched here because of the handle. You can't change the handle, na? Can you change the handle? हाइट ऊपर कर सकते हैं. All right. हाँ. All right. हाइट ऊपर किया तो भी all right. Is it focused? Are you able to see? Thank you. So now you see this tissue you can't leave behind. If you leave behind this tissue, the surgery is incomplete. So actually intracapsular surgery, you have to be more careful because you are facing the fascia. We can't damage the fascia. See this is all lymphoid tissue. I'm removing the lymphoid tissues. Layer by layer. Auditorium. See how much tissue is inside.
Sir, upper pole is still there, na sir? Upper pole tissue.
Yes. Yes, it's still there. You are absolutely right. That's what I said. This surgery takes more time. So if you are able to do a good surgery, extracapsular, nothing like it, because it consumes less bond, less time. Now see what happened here. Can you see this? So this was an accident because my wand here, I'm not used to this microscope, and this wand was obstructed by the handle. My control is lost. So this part will be painful. I should not have done this.
That is posterior pillar, sir.
Yes, posterior pillar. Upper pole is still there. I'll be more careful because this wand, the height of the microscope is different from what I use. So I was not used to this, and suddenly the wand got obstructed. So now let me show you the fascia from inside. See, still a lot of tissue is still there. Here I am not exposing any blood vessel. But I'll show the fascia in a moment. The tonsil is always so deep and more deep at the superior pole. See how deep is the tonsil. Now I am actually now getting near the fascia. So far I have not even got near the fascia. This is all lymphoid tissue. So as you get near the fascia, so that is the fascia now. Can you see? Now the tissue is becoming completely brown. There I have reached the fascia. Now I'll go for the superior pole. Can you see the superior pole?
Yes, sir.
There's still
Very
some
clear,
tissue
sir.
there. Now I am getting out the superior pole. So this is a mistake. So this part of the mucosa is gone away by mistake. There will be no long-term sequelae, but the child will have a little pain in that part. Otherwise, it would have been a totally painless surgery. Now, how to control this pain? We give some local anesthetic gargle, some lidocam gargles or lidocam tablets to suck. Because this is no muscle exposure, it's only the mucosa. So mucosa you can very well take care of by local anesthetic. All right, can you see the Can you see the contractures? That means I have reached the muscle. And complete removal of the tissues from the superior pole. See this? All right. Can you see that there is no lymphoid tissue left?
Fascia is there, sir, visible.
Correct. So unless you see the fascia from inside, your job is not complete. But at the same time, you do not open up the fascia. Now see, now this is complete. Now this is complete. Can you see the fascia very clearly?
Yes, sir. Sir, what about the lower pole, sir?
Lower pole is
tissue there?
completely
sir.
done.
Okay,
Completely. See this.
Okay.
Now you can coagulate whatever little bit of lymphoid tissue is there. You can coagulate. Suppose if there is a very little last layer, you can coagulate. Now here, a very little amount of tissue here. If you're not sure, coagulate. But if you leave behind too much of a tissue, it will come back. So this is your intracapsular surgery. Maybe I'll just all right. All right. Are you able to see? So very little amount of tissue if here, you can simply coagulate the last layer. But you have to see the fascia like this. Is it very clear?
Very clear, sir. Very clear.
So around 95-98% of the tissues are taken care of, not 100%. But this will never require another surgery, and there will be no bleeding. This patient can, travel even tonight, wherever he wants to go out of the continent also. Now we'll monitor on this side. Microscope sir ko de dijiye. Now we are going for adenoidectomy. Have you got that? Now we'll go for adenoidectomy. I'm monitor on the. Any questions on intracapsular tonsil now?
Sir, what are the indications?
Sir,
Yes. If you have to do tonsillectomy in a singer, if you, Vishwakarma sir, if you have to do tonsillectomy in a singer, intracapsular, no problem at all. No change of voice can happen because you do not even touch the musculature. So you can guarantee that there will be no voice change because of tonsillectomy. Now, sir, very nice question. Why don't we always do intracapsular? There is only one reason to it. It consumes more bond, more time, more patience. At the cost of the patient. अपना time ज़्यादा लगे, अपना patience ज़्यादा लगे, मेहनत ज़्यादा करनी पड़ेगी. टेक्निक आ गई तो वो एक्स्ट्रा कैप्सूलर उतना ही अच्छा है सर. एक्स्ट्रा कैप्सूलर फास्ट हो जाता है, लेकिन एक्स्ट्रा कैप्सूलर में यू नेवर नो कि आपको कब मसल आ जाएगी. इसमें तो कभी नहीं आएगी ना. So if I have to do, if there are huge tonsils of an मोटा पेशेंट जिसका इंटुबेशन मुश्किल है, मैं लोअर पोल पे तो हमेशा इंट्राकैप्सुलर ही करता हूँ. ब्लीडिंग का चांस ही नहीं छोड़ने का. No complications. Upper pole, I do not do intracapsular because I want to cut and rotate. So I remove extracapsularly. So now we are shifting the 0-degree endoscope, please. 0-degree endoscope. जल्दी जल्दी मोबिलाइज करना है endoscope. इधर रहिएगा, आप इधर रहिएगा. ऊपर की लाइट नहीं चाहिए, ऊपर की लाइट नहीं चाहिए. कैमरा, कैमरा प्लीज. कैमरा हेड. शिवा कैमरा. चलेगा इतना काफी। ऑल राइट, सो एडिनोइडेक्टमी के लिए विल बेंड द वॉन्ड। जब तक ये सब लग रहा है तब तक मैं बेंडिंग ऑफ वॉन्ड दिखा दूं। ऑडिटोरियम प्लीज, एक्सटर्नल
हाँ सर,
कैमरा।
प्लीज प्लीज। हाँ यस सर,
देखो,
वी आर
हाँ,
सीइंग।
तो एडिनोइडेक्टमी लोग कई तरह से करते हैं। मेरा मास्क नीचे, प्लीज डोंट माइंड। इफ somebody can pull my mask a little up, sir, because now microscope work is on. ठीक है, नहीं ठीक है। अभी आवाज ठीक आ रही है क्या कि खराब हो गई?
हाँ सर, नहीं नहीं सर,
ठीक
अच्छा
है
है।
आवाज? ठीक है, ऑल राइट। तो देखो, वॉन्ड, वी हैव टू बेंड द वॉन्ड इन द डिस्टल 1/3। ये प्रॉक्सिमल 2/3 है, ये डिस्टल 1/3 है। यहाँ वॉन्ड बेंड करके कोई फायदा नहीं है। वॉन्ड जब भी बेंड करना है, डिस्टल 1/3 में बेंड करना है। तो एट द जंक्शन ऑफ द proximal 2/3 and distal 1/3 you start bending the wand. All right, हमने यहाँ से wand bend करना शुरू किया, but now I cannot make an acute bend over here. I have to bend it further below. Can you see?
Yes.
And further below. Now this wand can go right till the coena. Clarity आ गई? Correct. So around 35 to 40 degree bend.
लाइका का है जो अभी
दूर
कैमरा जो अभी दिखा रहे थे,
अभी दिख शायद ये भी दिखा रहे हैं।
पूरा
connection. So we are just waiting. तो क्या होगा, ये wand will go through the oral cavity. इसलिए हम लोग टॉन्सिल पहले कर लेते हैं, so that बाद में wand को बेंड कर देंगे ना, इसलिए पहले टॉन्सिल कर लेते हैं. Now idea is to do a complete adenoidectomy because the child is 4.5 and the 5-7 years the adenoid spurt is still going to be on. जितना छोटा बच्चा है उतना डिटेल काम करना जरूरी है. You don't do half work in a 3-year-old kid. You do a complete work in a 3-year-old kid so that he doesn't grow it again. Waiting for the camera.
ये लोग भी तो नए नए निकालते रहते हैं।
इधर है.
हाँ, और क्या, तभी तो बिकेट।
और क्या हमारा हमने रिकमेंडेशन किया था,
नहीं आ रहा, लाइट नहीं आ रही.
स्पाइस वाला
कैमरा नहीं आ रहा है, पीछे करो ना, कैमरा पीछे. कैमरा
इसका पावर बढ़ा दीजिए।
पीछे कॉर्ड हिल गया. नहीं, लाइट सोर्स ठीक है, सिर्फ कैमरा चालू करो. वेट. ऑल राइट, नाउ वी हैव गॉट द अभी लोड हो रहा है. जस्ट अलाउ मी अ मोमेंट फॉर द कैमरा टू स्टार्ट. Are you getting endoscopic picture by any chance? Auditorium.
It is a live view, not the endoscopic.
वो सिस्टर
Endoscopic
थोड़ा
picture,
सा
please.
यस
Endoscopic picture to the audience.
पानी अब मत कॉटन बोल दे
Perfect. Large adenoids.
देखो अगर बात हो सके अब बताओ भाई. हाँ, अभी कुछ
Tell me when you get the endoscopic picture. सीधा करके बैठ.
can we talk with auditorium now?
सिवा देखो एंडोस्कोपिक पिक्चर क्यों नहीं जा रही है.
सर आ रहा है। We are
बोलोगे तब पता चलेगा ना राजेश।
हाँ सर आ रहा है सर प्लीज गो
बोलो
अहेड
ना
सर
भाई, आप
हाँ सर
बोलोगे
एकदम
नहीं तो
बोल
हमको
रहे हैं सर वी हैव ऑलरेडी टोल्ड सर आपने बीच में बिजी हो गए आप इसलिए सुना नहीं सर हमने बोला था
माय
आ रहा है
मिस्टेक।
सर बहुत नाइस पिक्चर सर
चलो ठीक है ऑल राइट। सो नाउ वी आर ऑन सेटिंग ऑफ 9।
क्वेश्चन बोल रहे हैं
प्लीज गो ऑन सेटिंग ऑफ 9।
तो
So now see, this is the adenoid. This is a 2.7 millimeter scope going from the right nasal cavity. Can you see the upper pole of the adenoid?
कॉटन बोल दो मुझे, चलो कोई बात नहीं। और
ये upper pole of adenoid है। राजेश, you please talk to me.
yes
आप इधर-उधर बात ही नहीं करो, आप मेरे से बात करो।
सर पिक्चर
See
इज
how
सर्कुलर
सर नहीं ओके सर ओके ही इज
now see,
स्टार्टिंग
this is the upper pole of the adenoids. ये इतना blood कहाँ से आ रहा है वो हम देखते हैं। But first I am defining the superior boundary of the adenoid. So you know that adenoid boundary was never defined before 2016. For 2008 I started doing coagulation and it took me 8 years to define the boundaries of the adenoid. तो ये अपना superior pole हम लोग सबसे पहले define कर रहे हैं।
Sir, you are starting surgery from the upper pole. Why not from the lower pole, sir? Why not from lower pole, sir?
Very nice question because बताता हूँ एक सेकंड। अगर मैं लोअर पोल से शुरू करूंगा तो ये सर्जरी होगी ना, ऐसे होगी करेक्ट?
तो हम लोग ऐसे करते हैं सर।
हाँ कोई नुकसान नहीं करने में, कर सकते हो, ऐसे भी कर सकते हैं ना, ज्यादा इजी है। बट मेरा कहना है कि अपना जो अल्टीमेट बाउंड्री है वो अपर पोल है, सो यू कैन डू इट आइदर वेज। यू नो मैंने ये थोड़ा सा फोकस और बेटर हो सकता है क्या कैमरा? मेरे तरफ से कुछ इशू है कैमरे में? नहीं वाइट बैलेंस किसने दबा दिया? अभी करिए वाइट बैलेंस, अभी करिए वाइट बैलेंस। ऑल राइट, all right, so idea is that we have to define छूटता कहां पर एडनॉइड सबसे ज्यादा? सुपीरियर पोल पे, करेक्ट? सुपीरियर बाउंड्री पे ही एडनॉइड सबसे ज्यादा छूटता है, तो हम सबसे पहले सुपीरियर बाउंड्री को ही डिफाइन कर देते हैं। Now see, this is the periosteum.
Yes sir.
Can you see the periosteum? I'm not
Yes,
opening up the periosteum, but I'm removing all the lymphoid tissues right till the periosteum of the sphenoid bone. Do you have a 4 millimeter 0 degree? 4 millimeter endoscope?
We have sir.
एक 4 millimeter ला करके रेडी रखिए।
Sir, they have 4 mm.
Correct, it will give you a better picture. 2.7 में ना इतना अच्छा डेफिनेशन नहीं आ रहा है जितना 4 mm में आता है।
Hello, Vikas sir. Hello, Dr. Rajat here.
Yes.
We met in Agra, midterm ENT Explore. Sir, I mean, when you were writing, I mean, reducing the superior pole, that is the area which usually bleeds a lot. I mean, how do you take control of that?
तो देखो ना ब्लीड हुआ क्या?
No, that's what I'm asking. I mean, usually when you do this area, it bleeds.
इसीलिए तो मैं होता क्या है, जब तक आप वहां पहुंचते हो ना आपका वांड खत्म हो चुका होता है।
Okay.
So see, the bulk of the adenoid, where will the blood supply come? Blood supply will come from here.
Right.
Let me take a 4 mm scope. और अच्छा आपको पिक्चर क्वालिटी मिलेगा।
And another question is, I mean, like when we do with this, it usually sucks in this tissue and it gets blocked. I mean, what is your technique and how do you prevent it? I mean,
देखो ना अभी कुछ हुआ क्या ब्लॉक?
that's what I'm asking. I mean, that is what we are here to learn.
पानी डालिए। तो ना अभी ये थोड़ा एक सेकंड डालिए पानी। तो see your endoscope, you can clean it on the tissues like this. Now let me first complete my dissection. This is the superior boundary, this is the lateral boundary. Now can you see all this adenoid tissue?
Right.
ये टोरस टुबेरिस के ऊपर का भी मैं टिश्यू निकाल रहा हूँ, क्योंकि यही बाद में ग्रो करेगा।
Right.
So now this is the lateral boundary anteriorly. So I'll remain 5 mm lateral to the eustachian tube orifice,
Right.
but I will superficially remove all the lymphoid tissue over torus tuberous.
Right.
ठीक है, देखो eustachian tube इधर है, वहां नहीं
Fine.
गया ना.
Perfect.
Now if I remove this, but I'll not get into the muscle.
Right.
This is the lateral boundary anteriorly.
Right.
Now I go to the lateral boundary posteriorly, which is the, बोलो कौन सी जगह ये?
Fossa frozen.
नाम बोलो. Fossa of Rosenmuller, correct. Correct. So that is the fossa of Rosenmuller here.
Right.
इसके पीछे यहाँ पर क्या आएगा?
Carotid.
So that is the fossa of Rosenmuller, which I am dissecting now.
Right.
That is the lateral boundary posteriorly.
Right.
And once you remove all this lymphoid tissues, layer by layer, layer by layer, layer by layer, you will get the posterior boundary, and that posterior boundary is called. यहाँ गई posterior boundary.
Perimysium. Perimysium.
Buccopharyngeal fascia.
Okay.
See, this is the fascia. Can
Right.
you see this fascia?
Right.
You don't need to open up this fascia.
Okay.
That's the fossa of Rosenmuller.
Right.
ये fossa of Rosenmuller में गहरे गहरे. See, you don't go laterally, go medial.
Right.
You can go superior, but don't go laterally like this.
Right.
If you have to go laterally, see what you are doing. You go laterally, very superficial.
Perfect.
Very superficial. Don't go
Right.
into the muscle. Now, this is the fossa of Rosenmuller. So
Right.
I'll first remove all this tissue from the posterior boundary, which is the buccopharyngeal fascia. Now I'm going deeper, deeper, deeper into the fossa of Rosenmuller.
Right.
Can you see that? There's hardly anything left now.
Perfect.
Why I'm not going laterally? Because I'll become blind over there.
Right.
If it starts bleeding, देखो laterally ऐसे जाएंगे ना.
Right.
अभी अपना ये suction block हुआ है.
Right.
Suction इनका थोड़ा strong नहीं है actually. थोड़ा strong करो ना suction को. थोड़ा सा suction को strong करो ना. थोड़ा सा suction का power बढ़ा दो. तो ये unfortunately suction power is less. इसको flush करिए. तो अभी मेरे को flush करना पड़ा. अगर suction power अच्छा रहता तो इसकी जरूरत नहीं पड़ती थी.
So the crux is that we should have good suction.
Good suction.
That is the main thing. I mean, that is why your thing is not blocking out.
Correct.
Sir,
Otherwise block होने का कोई सवाल नहीं है. Suction. चलिए लगाइए suction. Now, so you have seen all the boundaries except the inferior one. Now let me define the posterior boundary. ये buccopharyngeal fascia एकदम clean दिख रहा है ना?
Right.
Never open this. There's a little bit tissue more still in the fossa of Rosenmuller,
Right.
which I want to completely remove. And now I'm. ये देखो ये आ गया अपना buccopharyngeal fascia.
Right.
ठीक है, ये थोड़ा सा टिश्यू जो बचा हुआ है इसको मैं कोएगुलेट कर रहा हूँ. जरा सा टिश्यू बचा एकदम रोजेनमुलर में. लास्ट
Perfect.
लेयर को मैं कोएगुलेट करके छोड़ देता हूँ. ठीक है?
Yes. Perfect. Perfect.
बिकॉज वहां अगर वो एब्लेट करने जाओगे तो ब्लीडिंग हो सकती है. नाउ सक्शन अभी थोड़ा सा और स्ट्रॉन्ग रहता तो और अच्छा काम होता, बट वर्केबल, नो प्रॉब्लम. दिस सक्शन इज स्टिल बेटर. अभी नाउ वी आर गोइंग फॉर द इंफीरियर बाउंड्री.
Right.
व्हाट इज द इंफीरियर बाउंड्री? पैसिव एंड स्लेज.
Right.
देखो ये फेशिया आ गई. कैन यू सी?
Yes.
तो फेशिया बड़ी कर्व्ड होती है कभी कभी, स्पेशली इन द डेप्थ ना. फेशिया एकदम
Right.
स्ट्रेट नहीं रहेगी, ऐसा घूमी हुई रहेगी. So you will
Okay.
get confused. तो follow. ठीक है, ये पूरा फेशिया आ गया पूरा,
Yes.
बट खुला नहीं है ना अभी तक.
No.
खोलना नहीं है. ये अपना लोअर पार्ट आ गया पैसिव एंड स्लेज. ये अपनी एडनॉइड की सारी बाउंड्री डिफाइन हो गई. नाउ सी हाउ डीप आई हैड गॉन. यहां से लेकर के वहां तक इतना गहरा है ना.
Right.
So let me first do the complete dissection on the right. एक तो क्या होता है अगर सक्शन बहुत स्ट्रांग नहीं है,
So these are retinoid tissues, sir.
consumed more.
Right.
Sir, is adrenal tissue is still there, sir, on posterior wall? Yeah.
क्या बोल रहे हो?
Sir, is adrenal tissue is still there, sir? Some tissue at the lower side, posterior wall.
हाँ, बोलो कहाँ पर है? Correct, ये वाला ना, मैं निकाल रहा हूँ ना इसको. Absolutely,
Okay.
absolutely it is there.
Okay, sir.
इसीलिए एक और wand ready रखिए. एक और wand ready रखिए. I might require a second wand.
Sir, in all the cases, you use a fresh one. So you use all in all the cases you use fresh one.
नहीं, देखो almost इस तरह का अगर इंट्राकैप्सुलर टॉन्सिलेक्टमी नहीं किया होता ना तो सेकंड वॉन्ड नहीं लगता था.
Okay.
लेकिन इंट्राकैप्सुलर टॉन्सिल भी किया है. देखो अभी क्या हो रहा है, ब्लाइंड किया तो क्या हो गया, ब्लीडिंग हो गई. ठीक है.
Audio visual,
blind
can you please show the pictures?
Yeah. Fine. Sir, why not debrider assisted adrenalectomy, sir?
हाँ,
Why
कर
this
सकते हो ना,
problem?
कोई problem.
Sir, which
कर
one is
सकते हो.
better? Your opinion, sir. Which one is better? And
Tell
why,
me
sir?
your opinion. Tell me your opinion. Which one is better?
Sir, we are using debrider. Then for bleeding, sometime we use this coblation. Coblator
क्यों?
in our department. sir.
डिवाइडर क्यों यूज करते हैं? कोब्लेशन वॉन्ड बचाने के लिए, राइट?
Sir, no, sir, that is free supply in our department, sir. उसके लिए नहीं कर
Then
रहे
why
हैं.
do you use divider?
The plane clear, that plane is very clear with debrider, sir. That fascia and
But
everything.
bleeding भी तो होती है ना?
सर ब्लीडिंग होती है बट एडीआर से पैक किया वो कंट्रोल हो जाती है सर 5 मिनट में.
सक्शन थोड़ा इंक्रीज करो ना ब्रदर. I'm just waiting for the. Now can you see the deviated septum?
Yes, sir.
4.5 साल का बच्चा है. सेप्टोप्लास्टी करोगे नहीं करोगे?
No.
4.5 साल का बच्चा है. Can you see the deviated septum?
सर इतना एडनॉइड होने के बाद सर आई थिंक देयर इज नो नीड सर.
For this time.
Sir, basically it is the part of lower part of the septum, so it can be spectomy can be do.
एक वॉन्ड और खुलवाई ना, खोलिए ये वाला दूसरा वॉन्ड, क्योंकि सक्शन नहीं चलेगा तो वॉन्ड बिल्कुल भी नहीं काम करेगा. Now you see, I have no space to go in. Why do you think it will not be required? He'll still have a blocked nose on the
Sir, no
left side.
endoscope, no endoscopic picture is seen.
No endoscopic picture.
Audio visual.
रखो दो इसको, हटाओ, चेंज करिए वो. एटलीस्ट सर्जरी तो अच्छे से दिखाए. Do you have a 70-degree scope?
We have a vision now.
Change करिए 70. अगर अच्छा है तो
17-18 रुपए.
चलिए चेंज करिए फास्ट. तो see what I'm saying is debrider से bleeding होती है ना, wand बचता है. There is only one reason to use micro debrider, which is saving of the wand. Wand is a recurrent cost. Debrider में तो आप 10-15 केस करो तो कोई फर्क नहीं पड़ता है. Cost is the only reason. Otherwise, you obviously want a blood test. And this is a good practice. Can you switch on the camera?
Sir, picture is not clear.
चलो कोई बात नहीं, वेट करते हैं. These are
Sir, you always use this coblation. Sir, you always use this coblation for adenoid and tonsil.
नहीं आ रहा है. Somebody help me with the suction ना please.
Vikas sir.
जी.
You always use this coblation for tonsil and adenoid.
I need शिवा सर हेल्प करना. कोब्लेशन कैसे काम करता है? विदाउट उसके नहीं काम करेगा ना, चेंज करना. कोब्लेशन लगाओ ना. हाँ, sorry, there was some question from down.
Please do this tonsil and adenoid with coblation or
Yeah. So देखो ये basically this is a good practice for your tongue based surgery.
Okay sir.
Unless you have done 100-200 adenoidectomies and you have a complete control, you're not even qualified to touch tongue base.
Okay.
And the more you do, more your hands will be. I'm waiting for the camera to the light cable light source of the camera to get started. Light source. ये वाला light source दे दो ना. Actually, there are so many. इतने सारे लोग एक काम में बैठे हैं. So please just hold on. Yeah. Light sources come. Yeah, correct. Thank you. Now see, there's no space for me to go on the left side. So I would actually even perform a septoplasty in a 4.5-year-old kid in my private.
Sir, we are not getting the endoscopic picture.
अरे यार, दो भाई endoscopic picture 70 degree scope.
आ गया सर, आ गया.
Yes, sir. Now.
नहीं तक गया.
आया गया. अच्छा है. Good.
सर जो हो रहा है वही आपको बता रहे हैं हम लोग.
हाँ नहीं, बराबर है. I'm also enjoying it. जब आ जाए तो बोलना.
Yes, sir. Yes, sir.
सर आ गया, सर आ गया.
We are with you, sir.
We are
अब
getting.
नीचे.
Later.
So now you see, this is the 70 degree view. दिख रहा है ये nasal septum है. इतना सारा adenoid है. ठीक है. So now I'm demonstrating the 70 degree. चल नहीं रहा है. Font नहीं चल रहा है. ये font change किया कि नहीं किया? भाई ये वाला font connect करो ना brother. ठीक है, no problem. वो चाचा चौधरी वाला हुआ, कह रहे टीवी नहीं चल रहा है. पता चला कि प्लग ही नहीं लगा था. ये 5-3 क्यों बता रहा है? स्विच ऑफ करो. स्विच ऑफ. ब्रदर वो स्विच ऑफ नहीं है. अभी चालू करो. वेट करो. अभी उसको 9 करो. All right. So now see. All right. So now I am doing. अब ये छोटा बच्चा रहेगा तो जैसे करेंगे ना, नाक में जगह नहीं है तो क्या करेंगे? अभी उधर डीएनएस है. You see, I get kids of 1.5 years, 2 years. और एक बार आपने सर्जरी कर दी ना, 5 साल का दोबारा सर्जरी के लिए आएगा ना बच्चा, प्राइवेट में नहीं चलता है. आपका नाम खराब हो जाएगा, आपके पास तो आएगा नहीं. आपको जो करना है एक बार में करो. या तो क्लियर बताओ कि हम अभी इतना कर रहे हैं, उसको सेकंड सर्जरी लग सकती है, लगेगी. So now
अभी तो
that's the choanal adenoid. Which I am trying to get from the oral side.
उससे पहले कोई symptoms हमारे भी नहीं आते.
यहाँ ये ध्यान रखना है कि अपना back of the bone should not damage the soft palate.
So you have placed one feeding tube, na sir, to protect the soft palate.
Correct. इसीलिए वो रखना सबसे ज्यादा जरूरी है. और let me tell you, 0 degree से करना सबसे easy है. ये oral cavity से करने में ये सारे issues आते हैं.
Sir, this is first time I am seeing this adenoid by using this 70 degree. Sir, can we press that infrared turbinate laterally on left side to pass the endoscope?
Yes, you can. लेकिन उसकी प्रॉब्लम टर्मिनेट में नहीं है ना, प्रॉब्लम सेप्टम में है. Here we have not taken consent for a pediatric septoplasty. तो देखो कितना इसमें झंझट होता है. पानी आते रहता है ना बार बार. इसलिए नेजल कैविटी से करते हैं तो पानी अपने विजन के बीच में नहीं आता है. फटाफट काम होता है.
Definitely, sir.
So let me bent the wand a little more so that I can reach the. अभी कुछ लोग बोलते हैं हम बिना बेंड के ऊपर तक काम करते हैं, कैसे करेंगे? मैं अभी यहां तक नहीं पहुंच पा रहा हूं उतना बेंड करने के बाद. So I do not subscribe to that. ये पूरा मैं नेजल कैविटी में जाकर के सर्जरी कर रहा हूँ ओरल कैविटी से, और प्रॉब्लम यही होती है कि बार बार ये पानी आ जाता है बीच में. So what normally in my place there is a second suction which is put. आप रख सकते हैं, दूसरा सक्शन है आपके पास, डाल दो ना, एक दूसरा सक्शन है तो डाल दो ओरल कैविटी में. So I'll do a complete job in any case. टाइम 10 मिनट ज्यादा लगे कम लगे, I don't mind. Now what is the advantage of using 70 degree? If you have to go behind the torus tuberis, नहीं चल रहा है दूसरा सेक्शन ना. So advantage is that if you have to go behind the torus tuberis, ये एरिया ज्यादा अच्छा दिखता है.
ओके सर.
जितना मजा उसमें आ रहा था उतना मजा इसमें नहीं आ रहा है ना.
नहीं सर हम लोग का आ रहा है.
एक सेक्शन डालो ना एक्स्ट्रा, एक सेक्शन डालो ना. हाँ नाउ असिस्टेंट, हाँ बस आप पानी सक करते रहो. थैंक यू. देखो अभी अच्छा लगेगा. नाउ दे दे, अभी एक दूसरा सेक्शन रख दिया हमने, अब काम फटाफट हो जाएगा.
सर एक नया ऑप्शन पता सर, एक और रूट हम लोग देख रहे हैं अभी 70 डिग्री से. अदरवाइज वी जस्ट ट्राई टू पास angled endoscope from the same nostril, sir. On right side, we use 30 degree, then visualize the adenoid and remove the adenoid. This is also one of the options, no, sir?
Absolutely.
We can use
complete करके देना है.
हाँ नहीं, काम तो complete करना है, sir. We can use angled endoscope in the same nostril.
देखो जिस पेशेंट को तुमने टच कर दिया ना, वो पेशेंट दोबारा थिएटर में नहीं जाना चाहिए किसी के भी.
हाँ नहीं सर, नहीं आएगा.
जिंदगी में एक ही नियम बनाओ. If you do a surgery, वो ये थोड़ा सा टिश्यू बचा है जिसके लिए मैं ये सक्शन ही नहीं काम कर रहा है. ये कितना अच्छा सक्शन है, देखो नहीं बना. चलो सक्शन लगाइए. सक्शन अच्छा सक्शन लगाया तो काम करता है.
Sir, one question is there, sir. Sir, can we use 30 degree endoscope from the right nostril, sir? To visualize the nasopharynx?
Yes, you can. Yes, you can do that also.
That will be easy, na, sir?
वो आपको no problem. That you can do that also. 30 क्या 70 से तो मैं 70 डाल के दिखाता हूँ ना. Now see, इसके पीछे का जो काम है ना, अभी मैं torus tuberis को सिर्फ coagulate कर रहा हूँ. Can you see?
Yes, sir.
ये ऊपर का पार्ट ये पूरा निकाल दिया, पूरा नेजल कैविटी में. ठीक है.
Yes, sir.
अब जाकर के काम कंप्लीट हुआ. नाउ क्वेश्चन इज, ये बेटर है कि ये बेटर है? राइट साइड इज बेटर, लेफ्ट साइड इज बेटर?
राइट साइड. राइट साइड.
राइट साइड इज बेटर. यही डिफरेंस है कि आपको इधर से कभी भी इतना दिखता नहीं है पूरा, जितना नेजल कैविटी से 0 डिग्री से जितना अच्छा दिखेगा ना, ओरल कैविटी से साइड व्यू मिल रहा है. साइड व्यू मिल रहा है तो लिटिल डिफेंसिव. अब मैं राइट साइड को पकड़ करके चल रहा हूं तो कर पा रहा हूं. देख रहे हो कितना टिश्यू बचा हुआ था?
Yes, sir. Yes, sir.
Now that is the answer to why not do it always from the oral cavity side.
Sir, this plane is very easy to identify with this debrider, sir. That is why I am saying we are using debrider to first remove the adenoid.
I'm absolutely okay with you. I'm absolutely okay with you. If you feel that is better, please go ahead. मेरे हाथ में नहीं चलता है. मेरे हाथ में ब्लीडिंग होती है तो मेरा दिमाग ही खराब हो जाता है. दिमाग ही नहीं चलना बंद हो जाता है. अरे यार ब्लीडिंग क्यों हो रही है? Got my point?
Yes, sir.
I don't want to see unnecessarily blood.
Sir, have you ever tried? I mean, is ever this has happened to you that you have left any soft tissue?
जब भी आप लोग एमबीबीएस में इंटर भी नहीं हो गए थे, तब मैं डिब्राइडर से ही करता था। From 1999 to 2008-9, I was doing with micro debrider only.
Yes, sir. Yes, sir.
That time there was no coblation.
Got it? Sir, हाँ जी sir. So the question
माइक्रो
is.
डिब्राइडर से कर करके वो पूरी वहां पेशा तक उस जमाने में भी जाते थे।
हाँ जी सर, हाँ जी।
लेकिन एक पेशेंट को ब्लीडिंग काफी हुई, हमने बाइपोलर से अच्छा कॉटराइज किया, पेशेंट मैलिग्नेंट हाइपरथर्मिया में गया,
राइट,
ऑन स्टिमुलेट हो गया उसका पूरा, 11 साल का बच्चा।
राइट,
उस दिन हमने बोला कि भाई या तो पैसे नहीं थे, बैंक से लोन उठाया और कोब्लेशन खरीदा।
राइट,
आई बात समझ में?
राइट सर। सर जस्ट अनदर क्वेश्चन, लाइक समटाइम्स आपके यहाँ से कभी सॉफ्ट टिश्यू छूटा है एंड हैव यू ट्राइड मेडिकल मैनेजमेंट आफ्टर दैट रिड्यूसिंग टू रिड्यूस दैट
देखो उसके लिए एक वर्ड है मजबूरी का नाम महात्मा गांधी।
हाँ, आई मीन दैट इज फाइन। हैव यू एवर ट्राइड इट? आई मीन
मजबूरी का नहीं, सवाल ही नहीं है। इफ यू आर डूइंग अ सर्जरी, डू अ कंप्लीट सर्जरी।
ओके, no, my question is, does that work or does it not work?
Sorry, come again.
Does that work or doesn't work? I mean, if you go for a medical therapy, leaving behind some soft tissues in which areas you are not comfortable doing a removal, and you leave the
answer to your question is, what percentage of kids with adenoids and tonsils are getting operated today?
Okay, I mean
10 to 15, 85-90
right.
तो मेडिकल मैनेजमेंट चला ही रहे ना।
राइट,
आंसर तो उन सब चीजों का है ना। मेरा कहना है कि जब काम करे तो पूरा करो, पॉलीपोसिस कर रहे हो तो पूरा करो, दोबारा सर्जरी नहीं होनी चाहिए।
सर बट
एक ही बार सर्जरी होनी चाहिए। That is the whole system.
Has this ever happened to you? I mean, even after complete removal, you have seen adenoids again?
Yes, on the torus tuberous.
Okay.
I have done my own revisions of
Right.
torus.
Right.
Huge tubal tonsils. देखो ना अभी इसको क्यों इतना coagulate कर रहा हूँ, ये वापस से नहीं regrow करे। See, this child still has 7-8 years of growth.
Right.
This I'm coagulating, removing, doing everything. So now see, finally I took lot more time on the left side.
Right.
0 degree. My surgery is over. I'll just show you. Still, this child will not have a good breathing on the left side. Why? He's got a deviated septum. So we'll have to still tell the parent, give me a small suction, very small suction. Now, can he breathe on the left side still? So you should tell the parents that fine, he's too young for no septal surgery if you don't want to do it.
Right.
But or patla suction. But be aware that there is a problem that we need to follow up.
Yeah.
All right, it's not as bad as I thought.
Right.
It was more of a, so fine, this is not as bad. So this child will possibly do pretty well. खाली इसका expiry है ना, देखेंगे कैसा रहता है. All right, so surgery is over. No bleeding. Yeah, we are shifting to the other side. Intracapsular, extracapsular, and adenoidectomy.
Perfect, perfect.
So,
round of applause for you,
so
sir.
thank you very much. Yeah. Any other question? Till the transmission is getting shifted.
Amazing, amazing demonstration, sir.
हाँ हाँ.
हेलो हेलो
ओके. ये सब फैशनेबल सेक्शन में चलते नहीं है. ये सब सेक्शन क्या चलेंगे?
हेलो ऑडिटोरियम. हाँ जल्दी.
पता नहीं दूसरा लास्ट इंडिया वो ठीक था शायद, ये वाला था.
विकास सर.
हाँ बोलो. यस यस
सर सक्शन भी बता दीजिए, which one is the best सक्शन सर?
सॉरी,
सक्शन मशीन सर किस कंपनी का अच्छा है?
जो आपके शहर का सबसे पुराना लोकल जो अपना स्टैंडर्ड मोटर लगा के बनाता वही सबसे अच्छा था. ये फैशनेबल डिजाइन वाले कभी मत लो. डिजाइन वाले काम नहीं करते.
सर आपके लिए कल ही मंगाया सर, कल वो 2 सक्शन मंगाया गया सर स्पेशली फॉर दिस वर्कशॉप।
जो अभी लास्ट में दिया वो अच्छा चल रहा था।
हाँ वो पुराना वाला है
मशीन
सर।
नहीं लो, पुराना वाला मशीन सर जो प्रॉपर वो हॉर्स पावर वाला मोटर रहता है ना, हाँ क्रॉम्पटन ग्रीव्स की मशीन।
My sound is going there.
हाँ, हमको पुराने वाले एकदम वो अच्छे हॉर्स पावर वाले घोड़े के ऐसा काम करते हैं।
सर hello sir, please.
Hello, sir. We are with you, sir.
We are with you, sir.
Okay. Yeah, this was a revision case. Somebody has done cortical mastectomy with cartilage tympanoplasty. On
Yes, sir.
CT scan, there is a huge cavity and
Yes, sir.
60 decibel hearing loss. What we have done till now, we have done the mastectomy and have removed the cholesteatoma. And on CT scan, there was an erosion of the facial canal. So we have done almost 90% of the mastectomy. You see, now we are now dissecting the cholesteatoma, and you will see the exposed facial nerve. Are you able to see? This is the facial
Very
nerve.
clear.
Yes,
Very
sir, we
clear.
can see this.
I am dissecting the cholesteatoma from the facial nerve
Perfect.
because CT scan was showing facial nerve exposure, so I was little careful and I used this blunt instrument for dissection.
Perfect, sir. Rather, I learned this using this instrument from you only, sir. This is really clear, sir.
Yeah. Now we will dissect because we thought that he will finish very fast, so we have done most of the mustard work. This is the cartilage the previous surgeon has used. See, white structure.
Yes, sir. Yes,
I
sir.
will remove. I will remove it. This white structure is the cartilage used by the
Yes, sir. Yes,
previous
sir.
surgeon, and the problem in revision mastectomy start from the incision only.
Right,
There was
sir.
lot of fibrosis. The second thing, it was difficult to find the graft. Second
Fine,
thing,
sir.
all of the landmarks were destroyed.
Right,
Okay.
sir.
We will I'll remove this granulation tissue and this cholesteatoma from the facial nerve, and then we will. This is the whole cholesteatoma with. This is the whole cholesteatoma, you see,
Yes, sir. You can see that.
which we dissect from the medulla and from the facial nerve.
Perfect.
And this is the cartilage piece.
Yes, sir.
This flap I have already elevated. This is the
Okay.
inferior flap, and
Perfect.
this is the superior flap.
The skin is preserved, I mean.
Yeah, with great difficulty.
Yeah.
Because
Re-
everything
revisions-
was everything was filled with debris,
Yes, sir.
and now we will little bit drill out the posterior canal wall to expose the this foot plate area.
Right,
Where's
right,
the
sir.
pedal.
So you're using a cutting burr, sir?
No, it's a diamond only.
Okay.
Posterior canal wall just to expose the sinus tympani and posterior part of the foot plate, because that is the hidden area for cholesteatoma.
Right.
And
Yes, sir.
I don't want to leave any disease.
Right, sir.
And facial nerve is under my vision, so I am very well confident that where is the facial nerve.
Right, sir. Right, sir. Right, sir.
So in cases of cholesteatoma, you should always drill out the posterior canal wall
Right.
to expose the sinus tympani, or second option is use the nasal endoscope.
Okay. Yeah. Angled angles for, I mean, for seeing the hidden areas.
Yeah, yeah. So these are the area where you may leave the disease.
Right. I think the area you are actually drilling, sir, this is the most critical area usually, which needs very fine drilling.
Yeah.
Can we use angled endoscope to remove the cholesteatoma from sinus tympani or the hidden areas, sir?
Not very frequently, because I did posterior canal wall, and most of the time we are able to remove the disease. Yes, for examination I use many times whether I will remove the disease or not.
But sir, sometimes beginners, they may hesitate to remove this bone, the part which you are removing, sir. For beginners,
No, beginner, yeah, that's why I'm telling you, you can safely remove till you see the tip of the pyramidal process, there is no problem. And here in this case, there is no problem as well, because here is the facial nerve, you can see this is the facial nerve.
Right.
So, because once you identify the facial nerve, the job become more easy.
Perfect. The tympanic segment guides you about the direction.
Yeah. Just a second. Now you will see the foot plate area.
Perfect. We can see that, sir. Very nicely exposed. Very nicely exposed. You're planning a vertical strut, sir?
Yeah. This is the now you can see the foot plate. I will remove all the tissue.
Perfect.
This bluish structure is this one, and this is mobile.
Right.
This is the stapedius tendon.
Okay.
This whitish structure. This is the stapedius tendon.
Okay.
This is the foot plate.
Right.
There is no cholesteatoma in the sinus tympani.
Perfect. Sir,
This
for
all
everyone.
ciliary mucosa. I'll show you the Eustachian tube also.
Yeah. Sir, can you also show us the tensor tympani tendon and the facial nerve for everyone, and the processus cognitive performance?
Yeah. I will show you. This is the Eustachian tube.
Yeah.
This one. It's little difficult. This one. Now you can see my probe is going in the
Can you please? Yeah. Thank you. Yeah. Better now.
I will do suction and show.
Yes, sir.
Yeah. Now you can see this. My probe is going ball probe.
Yes, sir.
And
yes, sir.
This was the processus popliformis area. This one.
Okay. Okay.
Here was the tensor tympani tendon. This part of the bone I have preserved, this one, because here I will place the graft.
Okay, sir.
This will the entire foundation for my graft. This one.
Right.
This one. Revision cases are always difficult, because many a times you struggle to find out the good graft, and same as here, we have to go very high. Then there is a lot of fibrosis. When you elevate the flap, there is a lot of bleeding and all. Everything is messed up.
Right.
Further, I will go down and you will have a better idea for Eustachian tube. This is the Eustachian tube. My suction is now in the Eustachian tube. And this is the facial nerve. This is the tensor tympani tendon here. See, this one.
Perfect. So basically, this is to show all the junior colleagues that
This
usually
one?
they are confused with the tensor tempori as a facial nerve.
Yeah, many times.
Yes.
Because it looks like that's
Yeah.
when they see.
And facial nerve is
This
about
is
that. I
the
mean,
facial nerve, and this
right,
is the
right.
process cochleariformis, and see this cord-like
Yes,
thing.
sir.
Sometimes it looks like just like facial.
Yes, that's it. I mean, at that point, eustachian tube can be a good landmark.
Yeah, yeah.
The
So
thing
these,
close
these
to
are
eustachian tube,
our flaps, superior
skin
and
flap.
inferior. See, this is the remnant of the tympanic membrane which were able to save.
Perfect, sir.
Sister cotton ball.
Usually in revisions, there's a lot of bleeding from the middle ear. I mean, from the mucosa and the fibrotic bands.
Yeah, yeah.
So,
There is
and so,
revision. There is a lot of fibrosis and new
how
vascularization
do
due
you
to
take care of that, sir?
inflammation.
Yeah.
You know, I'm using pure adrenaline shock cotton ball
Okay.
in the middle ear, and I have used lot of adrenaline ball to stop all these mucosal bleeding.
So patience is the key. I mean,
Surgery is under general anesthesia. She has given us a very controlled BP. Otherwise, it could have been a really problematic.
perfect.
Now,
Right, sir.
I have already harvested the inferiorly based flap to obliterate the cavity, which I will show you.
Okay.
I have already done the myotoplasty.
Okay.
And I have already reshaped the septal cartilage graft for.
So, sir, for everyone, I mean, I know that you have a bank for septal cartilage, so I think you must have brought it.
Yeah.
Yeah. So,
They also have.
Okay.
They
And
also had here,
so for everyone, can you just tell us how to make a septal bank?
No, when you do septoplasty, take the inferiormost portion of the septal cartilage.
Yeah.
The inferior part of the septal cartilage, and preserve in 70% alcohol. 70% alcohol means ask your pathologist to give you absolute alcohol.
Right.
And take 7 ml of this absolute alcohol and
Right.
add 3 ml of this double distilled water.
Double distilled.
And keep the cartilage in that solution, and
For how long?
keep on changing the solution in 3 months.
3 months. Okay.
And this will give you the adequate consistency of this septal cartilage. If you use higher concentration, it will be very hard, and if you use lower concentration, it will be soft.
Okay, sir.
So what we are doing, we are putting the temporary spacer graft.
Right.
Before that, I would use these septal cartilage, this conchal cartilage graft, which I have taken from the during the this myotoplasty to elevate the height of the middle ear. I'll put in the sorry, doctor, cartilage was what.
Sir,
So
can you do a
because
bit of fine focus? I mean, we cannot see the middle ear properly.
Yeah.
Fine focus, fine focus.
Yeah.
I'm better now, I guess.
Problem is there is something wrong with transmission. In microscope, the things. No,
For how many days we can use this cartilage, sir? For how many days?
Usually, you can use up to 3 months. They work well. After 3 months, we use. After 3 months, usually we change the solution as well as the cartilage pieces.
Okay.
Okay, sir. Okay.
Otherwise, there is no time limit. But if you have a plenty of cartilage, then better to change in 3 months.
So you're doing attic reconstruction by using cartilage, sir?
Yeah. Attic reconstruction is this will raise the middle height and will give adequate space
Okay.
for middle aeration. Because for any ossiculoplasty, you need a good aerated middle ear.
Right.
If you just put the graft there, sometimes it get blasted.
Right.
Here, this will raise the height of the and
Middle ear.
anteriorly I will put the graft here on this foundation.
Got it, sir. Got it. So have you ever used a soft tissue in the place of cartilage to raise this bar?
Dr. Vijayan use fibrofatty tissue, but I am using cartilage, which this is enough.
Okay.
Enough cartilage which you get from this one.
Right.
But he is using this.
I mean, after seeing him, I think we lot of people like me, we have started using soft tissue.
I had a reservation because it may reabsorb, but cartilage is a very strong thing. Even in this case, you have seen patient has a perfuse discharge, and it was the whole of the external canal and the mastoid cavity was filled of cholesteatoma, but
the
cartilage was still intact. Three things which are even resistance to the cholesteatoma. One is cartilage, graft phalanx. Another is choroida, cleft repositor. And third is stapedius tendon, which I have seen. They are never destroyed even by the destructive lesion like cholesteatoma.
Yes.
कुछ बॉल प्रॉप दे दो, कोई बात नहीं. This must cut graft we got with very great difficulty in this case.
Yeah, we could make out. Revisions are always difficult, sir.
Yeah. But the only thing, because we are doing lot of revision in our city.
Right.
So we are always.
Yours is, I think, sir, yours is more of a revision center, I guess.
No, we have one wonderful surgeon who do 40, 50
I know,
cases.
sir. Yes. That great surgeon also against implants.
And what this guy do? He just push the cartilage through the perforation.
I think he just made a world record also.
He just pushed the cartilage through the perforation.
Yes,
and block the eustachian tube and your editors, everything.
Right.
And the central perforation become unshaped CSM. And when you remove this cartilage block, you find that everything in the middle. मुझे वो दे दो, एक गीला जल from the.
Sir, can you do some fine focusing, sir?
Yeah, the problem.
Picture is still blurred, sir. Not very clear.
मेरा focus तो अच्छा, but
it is okay, sir.
Sir?
ये माइक्रोस्कोप नीचे जा रहा है, ऐसे टाइट करो थोड़ा. हाँ, थोड़ा सा इसको टाइट कर. Oh, it's going down. With the.
Sir, have you done the ossiculoplasty, sir?
No, I will do just because first I am stabilizing the
graft. Okay.
I'm just.
We thought, sir, you are just packing.
No. I'm just stabilizing the this graft and this tympanomeatal flap.
Sir, you do anti-word reconstruction in every mastoid cavity.
So we obliterate the mastoid cavity with cartilage and this inferiorly based flap in every case.
Okay, sir.
So after now you see that the flap anterior superior and the part of the tympanic membrane is covering the graft. After stabilizing, I will put a sukha gel foam. I will put a dry gel foam here just to stabilize this end, and then I will elevate the no, because these are the things where you have to spend few minutes, because these are the very fine things. A piece of gel foam is half is placed over the graft and half over the tympanomeatal flap. By capillary action, it will after stabilizing this one, now I will do the ossiculoplasty. It's just a bulb probe.
Sir, do you put gel foam in the middle ear or not?
No, I'll put now 1 or 2 piece to
Because
support
nowadays
that,
many,
to support
many
the.
surgeons say that.
No, I'll put little bit to support the graft and to support the my ossicular prosthesis.
Okay, sir.
Oh, sorry. आपका नाम
Nowadays, sir, many surgeons say that we should not put the gel foam in the middle ear because it causes fibrosis and it can lead to adhesions.
But we are using since 40 years. We have never seen. I have even revised my cases on, but fibrosis
Yes, sir.
I have never seen.
Yes, sir.
Don't believe if someone says something.
Yes, sir.
We are using since last 40 years. Never find any problem. So, because if somebody says something, it is always not true. Once I was in US, Dr. Ashok Shah, who is the authority in thyroid surgery, and the hall was filled. Means so many US persons, everyone was there to attend his lecture on the thyroid surgery.
Yes, sir.
And the first sentence of his, what was he said?
Yes, sir.
Always keep in mind rule of 2. Rule of 2 means if somebody say I have done so many cases, divide
Yes,
it
sir.
by 2. And if someone say that he had so many complications, then multiply it by 2. So that giant was saying, and even somebody the person who was editor of Lancet for 7 years, I read her article that she was some lady from UK. She said that it is very unfortunate to say that more than 50% of articles are fake, but we have to publish them. So always believe what you see. If somebody say that no, this happened, and you have not seen that thing in your case, then that has nothing.
Yes, sir.
So we always use, and we are using it since 40 years. And now see that I have put many cases. This
Yes,
will
sir.
support your graft. It will not allow it to fall over the middle ear mucosa.
Yes, sir.
This is the foot plate.
Sir, what
In
is your
this case,
experience of putting silicone sheet in the mid layer?
I have never used, so I cannot comment.
Yes, sir.
I have never used. I have removed few which have been put by cartilage, ossicle, which have been put by another persons, but I have never used.
Yes, sir.
What's up with? I have already reshaped this bronchial cartilage, and the inferior end I have designed in that way that it will fit in the foot plate. Oh, ball, yeah, ball. There is enough space between facial nerve and the prosthesis. See how nicely it has fitted in the, and I'll try to show you the round window reflex. Just a minute, if I can. Here you can feel some movement. At this point. This here you can see the reflex. This the, I don't know whether you can appreciate, but we can demonstrate it. You can feel here. And I am just pressing it, moving it. It is very smoothly fitting in the foot plate. It will not fall, I know. Okay, Rajat?
Yes, sir. Fine,
Rajat?
sir. Nice demonstration, sir.
Sir, Rajat is not here. Everything.
Yeah. This substance you get without any cost, gel foam. And believe me, we are using it since last 30 years, and we have very long follow-up. Tomorrow in my lecture, I will show at least 7 cases which have a follow-up of more than 10 years. They are all doing well. Few pieces just to support this. So these few pieces of gel foam we have just placed to support the this prosthesis. Bas. Now I will just put it back.
युवा को बोल दो कि सर यहाँ पर सब ऑडिटोरियम में बोल रहे हैं कि करंट लिखना चाहते हैं.
And here you can feel this is the impression of cartilage. If I don't I will do the fine focus if you can appreciate it. See the length. This graft is sitting here.
Sir, picture is not very clear, sir. Sir, picture is not very clear.
Fine focus.
Yeah.
Audio visual.
Fine focus.
Yeah, I think.
Yeah, This,
It is better now.
see, this is the cartilage.
Yes, 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 you can see that.
You see the impression of cartilage and how nicely you can see the impression here.
Perfect, perfect.
So the length is absolutely fine.
So have you ever used boomerang? I mean, you have have you ever tried using a boomerang?
You know, Rajat, why?
Yeah.
Because I am getting good result with these simple things. So I have not
Right,
tried
right.
the new one.
Okay, because there are like people like me who don't have a bank. So we guys are using boomerangs.
I am just telling you, there are many ways of doing one thing.
Right, right.
The only thing is the ultimate results. If you are getting good result by some technique,
Right.
keep on doing that. If I will have some problem, then I will try that also.
Sure.
Because you can try new things.
Yeah.
Initially,
yes.
we were not. I was very reluctant by doing tonsillectomy by coblation.
Right.
But when I saw Vikas 2 years back, then I
Right.
start doing, because I was having coblation since 8 years, but I was
Right.
using only in angiofibroma and adenoid, not for tonsillectomy.
Right.
But by seeing him, I found it very comfortable, because sometimes
So
nowadays we are getting children of 2
right,
or 3 years with severe OSS,
yes, sure.
where you cannot afford even 50 ml blood loss.
Right,
So in those cases, this technique is wonderful.
right. So this is a compressed gel form?
Yeah. Compressed.
Okay. Because I mean, it is not taking up the blood also.
Yeah. After
So are you using a plain or it's a soaked with the tea bag or something, Muparosin?
these are the
Because
planes, but
these
many
are plain
times
ones.
we use the drop also, because I'm using dry.
Okay.
It will be more stable. For
Right.
rest of the cavity, we
Once-
can use drop. It will the dry gel form will dissolve in 3 weeks. Wet
Right.
gel form will dry in 1 week. That's
Right.
why I'm using dry. Yes. Now
So
I'll show.
any technique you would like to tell us for making a compressed gel form? Because when I am doing it and I take my gel forms into the cavity, they soak the blood, but your gel forms are not soaking up.
No, this Akanksha will tell you. Dr. Akanksha is assisting me. But
Okay.
otherwise, we have a graft holding forceps. We compress it
Right.
with that. And ask sister to compress before, when you are doing in the starting of the case, and at the end you will have this type of gel form.
Right.
They are using. She told me they are using needle holder to compress the.
Okay. Even I am using a needle holder, sir.
Now I will show you the just a minute. We will show you the
Flap.
how we have harvested.
Yeah.
Just a minute. This is the big flap.
Right.
Which
Perfect.
we have harvested, and this will cover the
This will
most
go
of
right.
the cavity.
Right.
Yeah. So cavity will be very small in this case. So this flap has covered half of the cavity. This is inferiorly based flap.
Yeah. So now, would you like to place the part of the graft over the muscle, or the muscle will go over the way you have placed it?
In this case, because I have a very small graft, it is not coming up to this place. But in our clinic, we put graft deep to this muscles.
Deep to muscle. Because like a lot of people put a lot of people
Over
put
the bone.
graft onto the muscle so that it takes up the vascularity from the muscle and supports up.
So graft, if you place over the bone, it take graft vascularity from the bone also. So we
Okay.
keep over the bone. We
Yes.
have not seen much difference. So this is another thing which I want to show, that how nicely you can fill the half of the cavity.
Right.
Now
Right,
see your
right.
cavity.
Perfect, sir.
This is your cavity up to the this bone this ridge. You have
Right.
blocked your cavity.
Perfect. Perfect, sir.
Sir, this is
Meatoplasty-
inferiorly based flap, sir. Sir, inferiorly based
Yeah.
flap, sir.
Yeah. This is base here. Inferiorly
Okay, sir.
placed flap. This is vascular flap, means pedicle flap. Meatoplasty we have already made. This skin will come over this raw area like this. This one. See? So at the end we will not have any raw bone. Can you see this meatoplasty skin flap here? ऑप्टिक में तो फोकस ठीक है, वहां नहीं दिख रहा है. अच्छा ठीक है, लो होल्ड करो सिस्टर, ये नीचे जा रहा है ना तुम्हारा अपने आप ही, पकड़ ही लो इसको.
Now it is better, sir. Now it is better.
Yeah. So this part of the cavity will be covered by this skin. We will put a suture like this, and this upper and superior flap will be kept in position. So there is no raw area, and your cavity will heal very fast. But just I want to make a comment. Why the previous surgeon has done cortical mastectomy with such an extensive cholesteatoma? I'm surprised. Okay. Okay. No, we have done almost. We will put the stitch. Thank you very much, everyone.
Thank you, sir.
sister.
Thank you, sir.
Thank you.
Nice demonstration, sir.
Nice
Thank you so much, sir.
Yes. Thank you to all of the OT staff, and I'm really thankful to my anesthetist who have given us the dry field. Otherwise, it could have been very difficult.
Our next case demonstration will be eustachian tube dilation.
चालू करो ना. तुम एक्सटर्नल से यहाँ फोकस करोगे, नहीं कर पाओगे. इधर मैं अच्छा एक टॉवल दे दो सिस्टर, एक टॉवल दे दो.
Namaskar, sir.
Namaskar, Rajesh. So
Sir,
after this hectic day of one after another surgeries, let's come back to something which we are doing it for the first time, or one of the few first times, right? So we will be talking about the new concept which is being developed regarding eustachian tuboplasty. Okay. So before I start, this is just to demonstrate what a eustachian tuboplasty is and how it is done. So first of all, let me show you the instruments that are being used for eustachian tuboplasty. Okay. And I am very much thankful to the department to have me here. I feel always like home when I come here. Now, see, for eustachian tuboplasty, there are 3-4 things which are always
External
needed.
camera, can you please focus it?
Focus करो, मेरे पे नहीं, यहाँ focus करो यार.
On the instruments, please.
ठीक है. So we have first of all the balloon, eustachian balloon. Can you see this?
Yes, sir.
This is the eustachian balloon. The balloon is in this part, right?
Right.
It can go up to 5 thickness, and it is 14
Right.
millimeter long. Actually,
Right.
for a pediatric patient, we want half the size, right?
Right.
But because this is an adult balloon, we will be using half of this balloon when we inflate in this pediatric patient. Okay. Then
Okay.
this is the first marker that tells you the limit of the balloon,
Right.
right? And then you have this point where you can put in the suction, or you can hold it, and then you have a latch which you can attach on this, so that you can increase the length of the holding facility. Okay.
Right.
So you can hold with this, and with one hand you can do both the things. Okay. So
Right.
this
Right.
is the first thing. Second, you have a stillet. Stillet would go into this balloon.
Right.
Okay. So you have to prepare this first, and then you have the eustachian guide catheter. Can you see this? So
Yes.
this is
Yes.
guide catheter, and if you look at the tip, it has a 55 millimeter angle. Okay,
Right.
55 degrees, sorry, right? So this is the 55-degree angle, and you have a blue tip that will tell you that you are near the eustachian tube, and then you are going in. Okay. So now,
Perfect.
before you start the surgery, first of all, with an endoscope, you have to identify the site where you want to do. In a patient like this, which has already undergone an adenodectomy, who has a very narrow opening of the nasal opening, a DNS, it is not possible to put a 4 millimeter endoscope inside and have a look at the eustachian tube, right?
Perfect.
And we will not be able to put this all together. So we will do through the oral route. Okay. So when we do
Okay.
it through the oral route, like Dr. Vikas just now only showed that you can focus here. He showed that the surgery of adenoid, which is being done from the oral route, that would need a endoscope with a 70-degree, or you can use a 30-degree. I use most of the time 45-degree. It does not matter. You should have a vision of the eustachian tube on the lateral walls. Okay. So
Right.
we are using 70. So we are using a 70-degree 4 mm endoscope, right? So before we
Perfect.
start, let's just check the site where we will be putting the eustachian tube balloon. Okay.
Yeah.
So
What's
before
the
this,
indication of doing this surgery, sir?
see,
In this
don't
patient?
ask about the indication in this case, but the indications actually are like when you know that there is a eustachian tube dysfunction which is causing a secretory otitis media. In adenoid cases, most of the time when it is advised that you do adenoidectomy and laryngotomy and bromate, right? Now
Right.
we are working on this thing that if we do not have to do a laryngotomy, right? So you
Okay.
do an adenoid, do a eustachian tube dilatation, and then it should be like that the whatever secretion has been deposited in the middle ear should drain from here once this starts functioning. Or there are some fibrotic bands here that can break and let the air in. Okay. So here on the
Right.
left side, you see the eustachian tube opening. Similarly, on the right side, you can have the view of the eustachian tube opening. Can you see that? Okay.
Sir, we are not setting the endoscopy.
Yeah, we
no,
can
we
see
are
that, sir. We can see that.
Right. So this is 70-degree, but even with a 30-degree and 45-degree, you would see it well. If you have a 70-degree, that's well and good. Okay. One thing
Right.
which I forgot to show you here, external camera, is the insufflator device. Okay.
Right.
So
Right.
this will be used to push in the saline and inflate the balloon. Okay.
Yes,
So
sir.
as we go ahead, we'll show you the use of everything. Now, once we have identified the eustachian tube, then you take the eustachian tube guide catheter, then take the balloon and load this eustachian tube catheter. Okay. So with
Perfect.
this, you are up to the banding part of the eustachian catheter. Okay.
Right.
If you want, you can always have the latch fitted so that it becomes easy for you to handle. Right. Most of the time, I don't use the latch.
Right.
अरे यार क्या मटके जो? Put in. Don't bend it, huh? हाँ तो पंचर दल है नहीं वो बड़ा चाहिए ना वो छोटा है हाँ okay give me so this latch they say that it always needs to be punctured before you load okay because I don't use so now we will put it inside okay so now you are in right so now
Right.
this is the system is ready okay then
Right.
you take up the endoscope we use a 90-degree suction because we have to do the suction in the adenoid region okay so you just use the suction and you
Right.
are at the gestation tube opening okay
Yes, sir.
now
Yes, sir.
the angle you have to maintain you should know that this is a 55-degree turn of the guide catheter can you see that the tip
Yes, yes, yes.
you can see
Yes.
it doing in the eustachian tube okay
Right.
can you see that so
Yes, sir,
once
we can
you
see
have
that.
to be only at the mouth right
Right.
you don't push it and you don't tear or don't find a false passage okay now you have to have an
Yes.
assistant who will push the thing push the guide catheter remove the stillet first so
Right.
the stillet is removed okay and then we will have the assistant slide the balloon
Yes.
slide it you can see we'll just start okay be slow very slow yes push it in can you see jawab hai you are having a resistance just a second yeah now you can yes can you see the movement and you see that black
Yes.
mark okay
Yes.
that
Yes.
black mark is the end of the balloon right and because
Right.
this balloon is an adult balloon we do not want to push it completely in okay
Right.
so what I will do is I will withdraw this guide catheter guide hold the balloon I will withdraw this a little and push it in yes leave it so now you see the balloon is in but half is in half is out okay
Right. Right.
see the tip yeah now we will ask the assistant to insufflate the balloon catheter so insufflate please so half of it will नहीं वो तो उसको हम लोग इधर कर रहे हैं रुक जाओ हाँ so this is half in half out okay
Right.
so this pressure is up to 4 atmosphere okay 3.8 to 4 atmosphere pressure should be given in a pediatric patient and then count up to 10 right so 10 seconds at one go so 10 9 8 7 6 5 4 3 2 1 deflate now this is deflated you can see you can withdraw so this thing can be repeated 2 times or 3 times can you see that opening there and the pulsations coming out see leave it give me the suction okay so this will break open any fibrous bed there and it will increase the mouth opening can you see that the eustachian tube opening you can see that now so
Right.
this is
Right.
dilated can you see this so this is
Yes.
because it's a pediatric patient we don't need to do it for 2 times or 3 times maximum I would advise 10 seconds 3 times in a pediatric patient but most of the time 1 or 2 times is more than enough so the
Okay.
opening which was not visible now you can see that
Right.
some fluid is coming out maybe whatever was there in the middle ear would try to come out right or some
Right.
mucosal like collection which is there present there because of some fibrosis or some blood that will come out but we have observed that doing this and then keeping a follow-up and Valsalva and everything the patient improves So we are doing a study on this eustachian tube balloonplasty to see if we can avoid a myringotomy and a gromate in patient with adenoids who have the early secretory changes. Okay, so this is
Yes,
on
sir.
the left side. So it's very simple, straightforward, and can be done by anybody. Just you need to have the balloon and you need to know where you want to go, right? So that is the eustachian tuboplasty on the left side. We can repeat the same thing on the right side. So let me show you on the right side again.
So do we have to repeat this procedure or it is a single sitting procedure?
Single sitting procedure. It's a single sitting. Can you see this? Because you look at both the sides. Okay, it's a single sitting procedure. If you have to like repeat the procedure, then I don't think that the job was done well in the first time. Okay.
Okay.
So now we come to the right side. See, look at the opening of the right side. Look at the opening of the left side. Can you see that? There
Yes,
is
sir.
a gross difference. This is
Difference, yes, sir.
completely closed, and here you have an open eustachian tube. Okay. So now let's come to the left side. Stillet. Stillet Naki. Put the stillet in. So we will put the stillet in again. Have some light. Okay. Okay. Yeah. So these are all simple procedures. Some technical details. Now again, as you come to the eustachian tube opening, engage the balloon. Right. Engage the catheter first. So you have engaged the catheter. Just a second. Yes. Okay. So the catheter, guide catheter is engaged in the eustachian tube, and then you take off the stillet, remove the stillet. Okay. Now push the balloon. Just a second after I put the endoscope. Put in. Yeah. Now we can push the balloon. Okay. So you see this balloon being pushed in. Pushed in. Yes. Okay. Okay. Goes a little further. Still further. Yeah. And still further. Still. Yes. Just wait. Okay. Now I will withdraw because this is the pediatric. And now we again insufflate. So use the insufflator device. Go up to 4 atmosphere. Okay. Count up to 10. You can see the balloons coming, bubbles coming out. 1, or we always go down. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Desufflate. Okay, so that's again you can see the withdraw the balloon. Okay, and you have the secretions coming out there, the bubbles there. Let me do a suction now. Can you see the opening now? So you have a bigger opening of the eustachian tube visible. Okay, so that's the eustachian tuboplasty, right? So with gadgets, you can do things which can improve the patient's well-being, and it should be used with some training so that you don't damage the nearby structures. Can you see now both sides you have a bigger opening? Can you see that? So you have the adenoids removed, you have the eustachian tube opening there, and the tonsils was also removed. So the patient is definitely going to improve. Okay. So thank you very much. That was the eustachian tuboplasty.
Thank you, sir. Thank
Okay.
you for a nice demonstration, sir.
Thank you. Done? बंद कर दो अभी अब सैलो एंडोस्कोपी होगा ये सब खोल दो बराबर ये सब खोल दो ले लो खत्म करो बराबर
Our next case is Arvind Kumar Singh, 39 years male, came up to the ENT OPD with chief complaints of swelling in right submandibular area, which increases in size while eating for 15 months. As stated by the patient, he was apparently asymptomatic 15 months back when he developed swelling in right submandibular area, which increases in size while eating and subsided in few hours. He also complained of pain over the swelling. There was no history of trauma, prior ENT surgery, increase or decrease in salivation, pus discharge from swelling, and dysphagia. On examination, stony hard swelling of 0.8 into 0.8 centimeter, palpable in right side of floor of mouth, submandibular gland bimanually palpable and is non-tender. CCT of the neck reveals radiodense calculus noted in right sublingual space measuring 9 into 8 millimeters with dilation of submandibular duct up to 6 millimeter. Features suggest right submandibular duct gland sialolithiasis with chronic right sialoadenitis. This is the picture of a CT scan. By this history and examination, the provisional diagnosis was right submandibular gland sialolithiasis. We plan with right submandibular gland sialolithiasis removal with marsupialization of the duct under general anesthesia.
वो भी इनका हाई एंड
होगा
लाइव अभी तक काम था और वो ना मतलब वो मतलब अलग ही लाइव करना इंटरेस्ट है सर्विस तो बहुत है लेकिन सर्विस खराब तरीका बहुत सब लोग हमारे
अब उसको पूछिए।
क्लिनिकल आज भी नानी पे वहाँ पे बीच में पट्टी अच्छा बोला वहाँ पे रखा था वो इन कंपनियों ने फिर आगे जो मॉडिफिकेशन था वही रियल सीन था उस समय की पैदाइश आप बता खुद को ना खरीदते हैं और बेचते हैं वो भी खाली वो लेके रिफाइनरी बस वो भी नहीं कर सकते अगर ना बेचते
Hear me अभी?
Second use.
लोकल में दो चीज याद रखनी है। तो एक तो ईयर में ना ऑलवेज हैव 2 cc syringe.
Next case is the system stepidotomy.
रुको रुको सिस्टर,
2 ml का syringe.
है तो दो, नहीं तो इसी से कराएंगे। अच्छा कहाँ दिए हो?
2 ml syringe. अजीत भैया,
इसको माइक्रोस्कोप के हैंडल,
माइक्रोस्कोप के हैंडल.
हेलो ऑडिटोरियम.
Yes, sir.
Hello.
Yes, sir. We
You
are.
can hear me, no? Yes. Okay,
Yes,
fine.
sir. Yes.
So now let's start the next case. So we have simultaneously induced two cases. One is this stapes autosclerosis, and the other case is saloendoscopy and submandibular gland, na? And submandibular gland stone removal. Okay. So this is, by the time that is being made ready, let us, yeah, please put in saline. So for any autosclerosis case where you do a stapes surgery, there are 2-3 things which you have to take care of. First, that before you start the surgery, you should sheath the tympanic membrane. मेरे को एक बिना कट वाला नहीं है.
Light focus.
Okay. Anyway, give me a proper size. इससे थोड़ा सा छोटा दो. इससे छोटा.
अन्वेषण सिस्टम.
अच्छा लगा.
हो गया.
Okay, so before you start the surgery, have a look at the tympanic membrane. Okay, let me just focus a bit. ये वाली ना. हाँ हाँ तो फाइन के लिए. हाँ ठीक है. ओके, पर वहाँ अच्छा है. मेरे को स्क्रीन पे अच्छा चाहिए. लाइट रुक जा. कौन सा नॉब? ये नीचे वाला. हाँ हार्ड है. नहीं हाँ नैरो बीम है, लेकिन वहां पे फिर रिफ्लेक्शन ज्यादा होगा तो फिर और कुछ नहीं दिखेगा. ओके, लेट मी सेटल इट. एनीवे, वैसे थोड़ा ठीक ठाक ही दिख रहा है ना ऊपर. ओके, so you have the tympanic membrane under your vision directly. Okay, so infiltration, we begin with the infiltration. Give me local xylocaine adrenaline. Okay, so now we will block all the 4 quadrants of the canal, and before we start blocking that, I will like to put in the local from post-oral groove, right? So if you take a line posteriorly in the post-oral groove, you can see here, and then you let the needle go in, come up to the posterior canal wall, okay, and then infiltrate. Can you see there? There you can see, and you press the posterior canal wall so that it will spread from 12 o'clock to 6 o'clock position. So this is the first infiltration that you do, and then you will do it in the canal system. को gel form थोड़े छोटे छोटे काट के एड्रेनलिन वाले एकदम छोटे नहीं पर वो काट के रखिए, हाँ, प्रेस्ड नहीं चाहिए, प्रेस्ड नहीं चाहिए, okay. Okay, so we don't rush in. First of all, infiltration is very important. So we will do the infiltration. अभी वो speculum use किया था कहाँ गया? वो वाला है, हाँ. That was it. Okay, so then we will infiltrate in all the quadrants, right? So infiltration, and always make it a point that the tip, the beveled edge goes in, turn 90 degree, and then infiltrate so that it goes or gives the local towards the bone and it will spread. Okay, so canal infiltration is important, because if the infiltration is not good, we will not be able to see what we are doing inside, because we are planning for a permeatal approach, okay, endomeatal, right? There are different ways of doing it. People do with post-oral approach, end-oral approach, and endomeatal approach, right? So we have been doing it transcanally endomeatal, which is the most widely practiced approach. So we'll start with that only. We'll spread the infiltration that we have given, put in some saline. Let's clean it further. Right? Dalo, हाँ, wash dalo, wash. Our area of target
Sir, you
is.
always do by the permeatal approach, or
Sorry?
sir, you
We will
always
do
do by the
permeatal. Yes. Yes. We will
Okay,
do
sir.
to the canal only, permeatal. Right? So now you see that there is some swelling here on the posterior area, means the infiltration has been well. Normally, after the infiltration, you should always wait for 10-15 minutes so that the infiltration becomes good. While you are waiting, you can put in a gel foam. Sister, एक gel foam मेरे को एक ना, हाँ, ADR, इससे बड़ा चाहिए, बड़ा चाहिए, बड़ा, इतना बड़ा, बड़ा मेरे को मेरे हाथ में दीजिए, लाइए, कैंची. See, always you should have the adrenaline soaked gel foam a little bigger for hemostasis. Yeah, ना sister, ये size, ठीक है? No. So we'll just cut few adrenaline gel forms, right? लाओ, डाल दो इसमें ADR. So that will be basically लाओ. एक मुझे crocodile forceps कुछ दे दो. लाओ, जब तक इसको गीला करो, लाओ डालो इसमें. सिस्टर डालिए ना, डाल के आप. वो लोकल इन्फिल्ट्रेशन था ना आपके पास, हाँ, वो डालिए इस पे. हाँ, एक इतनी एक इंच की है ना, 2 वीक बनाइए. So this is just a gel form soaked in xylocaine adrenaline. Normally you take only an ADR, right? So adrenaline से gel form. Sister विक दीजिए, वो ये कॉटन की, आपका है ना, कॉटन जेल फॉर्म जो भी है आपके पास.
इसमें भी ADR डालो, अमन.
कोई ना पट्टी नहीं है ये, सिस्टर हॉस्पिस है ना, काटिए हॉस्पिस को. वो रोलर बैग है ना, उसको काटिए ना, सबसे अच्छा. खोलिए, 1 इंच काटिए, इतना बड़ा, राइट.
Normally done by you, approximately 60 तक बहुत 65 की है, तो मैं वो क्या बोलता, और उसमें भी 2
हाँ, काटिए, गीला कीजिए उसको बस.
ADR, अमन.
दे दीजिए।
आप 100 का सेलिब्रेशन हो रहा है।
चलो चलो चलो। Okay, so I have already put in gel foam. Above that, I am putting a wick. This is just to compress and see that the infiltration that we have done settles well and takes some time to act. Meanwhile, we will prepare the instrument system. मेरे को order जो है circular knife, P knife, उसको रखिए line में. So we will have a look at the instruments that we have on the trolley. So we don't use many instruments for this. तो ये सब कुछ नहीं चाहिए, सब हटा दीजिए. बराबर? ये जो लाइट इस पर डालो ठीक से. ये सब हटा दीजिए. वो सब कुछ नहीं चाहिए. बराबर? एक कुछ दीजिए ऐसा जिसके ऊपर रखा जाए. खोलो. ये इसको डालो. चलो. हटा दीजिए. मुझे कुछ रॉड वॉड चाहिए जिसके ऊपर रख सके. सब टिप दिखनी चाहिए. सर्कुलर नाइफ और पी नाइफ का है.
डाल दो
फ्लैग नाइफ.
पायलट में टेंशन तो ये होता है ना जल्दी
ईयर के सेट में जो होती है ना वो चाहिए.
2 बजे पेशेंट बाहर हो गया था.
इतनी बड़ी मुझे सर्कुलर नाइफ चाहिए अगर आपके पास है तो.
तो जो है
थोड़ी छोटा है, कोई बात नहीं. और एक मुझे कर्व्ड पिक चाहिए. ओके. फिर अच्छा स्कूप चाहिए. मेरा परफोरेटर है ना. परफोरेटर है. हाँ वो सब रखो. मेजरिंग रॉड ये ठीक है. चलो. हाँ 90 डिग्री पिक रखो. ओके. Fine. So we have the required instruments ready. Now we remove the wick that we have placed. सब उधर थोड़ा साइड में रखो. जो मांगूंगा तभी देना.
इनकी वजह से हम शौक हैं. अगर सच में मेरे हाथ में सौरभ पर होते ना हम रोज 300 ऊपर निकल कर.
सही बात है. क्योंकि आप ज्यादा पढ़ना भी तो हो सकता है.
Right.
वो भी मुझे पता इसी को नहीं करना. पूरा डिपार्टमेंट कर पढ़ना.
So we are the auditorium. Can you hear me? Or are you getting my picture? Hello.
Hello, yes sir.
Yes, you are getting this picture. The ear.
Sir, विकास here sir. बहुत अच्छी picture आ रही है. Go ahead.
Okay. So you see directly the handle of malleus here, right?
Yes.
This is the annulus area. We want to have at least 4 to 8 millimeter of space for the tympanometal flap. But they are all theoretical things. You can have it a little bigger also. Does not matter. What you want is an exposure from 12 o'clock to 6 o'clock. And your area of work is in the postero-superior quadrant. Okay. So what we do is put your P knife or the flag knife at the annulus level near 12 o'clock. Can you see that? And then put an incision on the bone. Come posteriorly. So this is coming posteriorly. Right. Normally I would say that double the size of this knife. That much should be taken. Okay. So like say we are coming up to here. Okay. So
because if the overhang is much, then it should not become short. Sorry.
Yeah, because you will be removing the postero-superior hump. So you have to go beyond that. Okay. We have palpated it here. So we go beyond that up to this region. Okay. So this is at 12 o'clock position. Then you can put it at 6 o'clock position. Right. So this is at 6 o'clock position. Same level posteriorly on the bone. Okay. Then you connect these two. This is one of the simplest way of placing or putting an incision for the tympanometal flap. Now, this is the circular knife. You have seen that it is
You have to feel the bone below, right?
okay. So this is.
Sir, your voice was lost. Your voice was lost. Somebody can change the battery of your microphone.
भैया माइक्रोफोन की बैटरी चेंज करो. वहाँ आवाज नहीं जा रही है. कौन है इधर? audio visual person, anybody around?
बीच बीच में चली जाती है और
Okay, so maybe within a minute or so, you will
Yeah,
get that. Okay. कौन है? Cystic saline का कटोरा यहाँ रखिए छोटा. Okay, so they are just finding the battery and they will just change.
Yeah, now the voice is clear. It had gone for a while in between.
Okay, so maybe somewhere some loose connection or whatever. Okay.
Maybe.
So now,
Yeah.
okay, so they say that it is a network issue. Their mic is fine. Okay. So now we raise this flap. Now मुझे circular knife दे दो.
What is this Mumbai?
Time pass.
What is it?
General conference.
लो इसको पकड़ो. Hold it. Change.
चल रहा है.
Okay. So raising the tympanomeatal flap is very important. First step. Okay. So infiltration, then raising the tympanomeatal flap. Infiltration is very important because we do not want many blebs to be formed after the infiltration. Otherwise, it becomes difficult to raise. Now, see, this is not cutting this small thread. Let us
So
try
the
and
quality
cut it.
of the circular knife is very important.
Yeah, this is like it becomes blunt after so many uses. No, so just
Yeah,
scissor.
yeah.
Yeah, micro scissor. If we have, I will use a micro scissor to cut it. या दूसरा सर्कुलर नाइफ है तो वो दे दीजिए.
So वही
एक
है
strand-
माइक्रोस्कोप कोगुलेशन ये सब बहुत अच्छा होता है. फिर सक्शन काम नहीं करता है, नाइफ काम नहीं
हाँ.
करता है. तो छोटी
वो
छोटी
तो यार,
परेशानी होती है.
that's how it runs. Okay.
Yeah.
That makes life
And
interesting.
That makes life interesting.
yeah, so now we raise the tympanomeatal flap, we go down. We have to go down up to the annulus.
सर आपका पनेटी इंस्ट्रूमेंट्स के बारे में क्या ख्याल है?
पनेटी के बारे में, पनेटी के इंस्ट्रूमेंट्स अच्छे हैं, लेकिन क्या होता है कि you have to get used to it. And when you are trained in a microscopic way of working, then it needs a more learning curve for an endoscopic approach. Otherwise, वो
नहीं,
instrument
पनेटी इंस्ट्रूमेंट विद माइक्रोस्कोप.
Sorry,
पनेटी इंस्ट्रूमेंट्स विद माइक्रोस्कोप.
I didn't get you.
Panetti instruments with microscope, microscopic surgery,
अच्छा,
but using Panetti instrument, you don't have to use suction separately.
You can, because see, I use a lot of times the endoscopic suction elevator for microsurgery. No?
Right,
So
right.
that is a very good thing. Here, what happens that you have to put in, take it out, put in, take it out.
Absolutely.
अब जैसे
So
ये है,
that's what.
ये डालो निकालो, and then you
मैं-
need to have that perforated circular
Correct.
knife, and only it is
Correct.
fine.
Correct,
Otherwise,
correct.
it becomes difficult. इससे थोड़ा सा छोटा suction चाहिए.
So I bought the Panetti instrument in 2019, the first set.
Right.
I only
Yeah,
use it
yeah.
for elevation of the rest. Everything is fine, but this step you save a lot of time.
Right. So basically, you know, the instruments are designed well, and you have to get used to it. Like you have in that you have the suction elevator with like every micro instrument, right? So it becomes easy. Like
Yes.
when you are going like this, you want to
Correct.
do the suction of this blood, right? Here,
Correct.
what will happen? That you put a gel foam, you will put a
Correct.
some
Correct.
some like cotton, and then do a suction, or you use a perforated circular knife and then do a suction. So it takes time. उसके अंदर आप एक ही साथ एक बार में ही कर लोगे.
बस exactly.
तो आप मीन्स क्या है कि हर चीज को अपने हिसाब से सेट करना पड़ता है. But yes, it's a good set. I used it, but then we did not buy it. क्योंकि वो थोड़े लोकल वाले भी देने लग गए. जलंधर वाला और ऐसा.
हाँ.
Okay.
इसमें सर मैंने एक आशिम को देखा, आशिम देसाई ना.
हाँ.
आशिम का मैंने एक देखा कि वो क्या करता है, लेफ्ट फिंगर्स रखता है इसके ऊपर उधर ही suction हाथ में पकड़ लेता है. So he holds the speculum and this suction both with the left
हाँ,
hand.
बिल्कुल बिल्कुल
उसका
कर
मुझे
सकते हैं.
बहुत अच्छा लगा आशिम का.
हाँ, वो क्या है
उसने
कि
कुछ तो
लेफ्ट
लंबा
हैंड में
लंबा वाला
सक्शन,
section बनवाया है.
हाँ वो क्या होता है, एक कर्ड पिक दीजिए मुझे. वो जो सक्शन है ना, उसके लिए
हाँ.
जो ये सक्शन वाली ट्यूब है ना, वो पतली वाली आती है, सिलिकॉन
पतली
वाली.
वाली आती है.
हाँ,
Exactly.
तो
Exactly.
और वो एक्चुअली दैट इज द एक्चुअल सक्शन ट्यूब फॉर एन ऑटोलॉजी सर्जरी.
Correct.
क्योंकि
Correct.
पहले जैसे डॉक्टर ABR देसाई या हमारे डॉक्टर बंसाली साहब थे जो हमारे टीचर, वो लोग सब वो
Right.
यूज करते थे, लेकिन वो कॉस्टली आती है. और
हाँ.
अब क्या हो गया है कि सबको डिस्पोजेबल चाहिए सब चीज.
Correct.
तो सब चीज डिस्पोजेबल होगी तो फिर तो पॉसिबल नहीं है.
बराबर.
एक बार होगी, दो बार होगी, फिर तो आपको चाहिए कि नहीं वो करना है.
Correct.
बराबर. तो इसीलिए वो रह जाता है. So now you open this flap. Once you have entered the middle ear, again you
Sir,
can
for
use.
beginners, I am asking this question.
Sorry.
Hello. For
हाँ जी,
beginners,
बोलो
I am
बोलो.
asking कि इस स्टेज पर लाइक कभी कभी ये एनुलस फट जाता है.
हाँ.
तो what is the
अगर
tip?
yes, so whenever you are raising this flap, always you
Yeah.
can see this. You have to be flush to the bone.
Correct.
Scrap on the bone, not on the tissue.
Correct.
Right. So when you are scraping on the bone, then the
Correct.
tissue would not come in between. Secondly, you put more pressure on the bone, so you are there
Correct.
and have
Correct.
very sharp instruments. Right.
Very nice.
So
और अगर
once you
गलती
reach
से
the
फ्लैप
annulus,
फट जाए वहां पे तो पैनिक करने का कि नहीं पैनिक करने का?
बिल्कुल नहीं करने का, डाल देने का नीचे कुछ
करेक्ट.
पेरिकॉन्ड्रियम डाल दो या
दैट्स
कुछ
व्हाट आई
डाल दो.
वांटेड कि अगर
या
क्योंकि मेरे से सर शुरू में 99
हाँ
2000 में जब शुरू किया था ना तो वही होता था, नीचे का फ्लैप
हाँ
फट ही जाता था.
हाँ.
तो पैनिक
So
नहीं करने का. यू कैन ऑलवेज पुट अ ग्राफ्ट.
never panic. इससे भी पतला दो एक सेक्शन. See this perforation, ये सब तो these all things can happen, but we should not panic and we should go ahead and correct that part. Right. So now you have here directly the round window. You see the IS joint. Right.
वेरी नाइस.
इसको जगह देंगे इधर. और now you see this is fixed when I touch. Now
सर
we
तो
will
एक
take
और
off
क्वेश्चन है.
this. Sorry.
Sir,
हाँ
one more
बोलो.
question. So before
Yeah.
taking up the patient for surgery, how do I know that how much overhang I'll get? इसका कोई pre-op कोई clue मिलता
क्या
है
how
क्या
much
patient को? Overhang निकालना कितना पड़ेगा?
improvement? हाँ हाँ
नहीं overhang निकालना कितना पड़ेगा?
हाँ.
Do you have any operative tip about the overhang?
It is very difficult to tell.
Hmm.
It is very difficult to tell beforehand that how much improvement in hearing you will have, or how much bony
Overhang will
suprastructure
be.
you will get, or how much otosclerotic focus you will get. Because nowadays what happens that we all do a CT scan for that.
Correct.
Okay. अब वो हर
That's
जगह
what
तो
I was
CT scan
questioning.
होता नहीं है. हाँ,
हाँ नहीं
हर
तो
जगह तो
सर
CT scan होता नहीं है.
exactly that was my point कि shouldn't everybody
Yeah.
be doing CT scan before taking up such a mushkil surgery?
Theoretically yes. Practically it is not possible.
Practically why difficult, sir? How CT scan is not a
No,
costly
not difficultly. It is
investigation.
not possible everywhere to get a CT scan done for all patients. Government में कहीं होता है, कहीं नहीं होता है. Private में
Right.
you can definitely get it done, right?
Hmm.
But then again, the reporting for that also needs an expert who will do a good reporting. Okay.
और CBCT के बारे में
और
क्या ख्याल है सर आपका for otology CBCT स्टेपिस के लिए?
CBCT हम नहीं करते, हम HRCT कर देते हैं सीधे.
All right.
But
So sir,
yes,
CBCT
nowadays
is just a
more and
great
more people are
resolution.
नहीं कर सकते हैं. Nowadays more and
Right.
more ENT surgeons are buying that cone beam CT
CBCT, correct,
for
sir.
for their
Correct.
routine practice. It has two benefits: financial as well as academic, right? And it also helps you navigate through the difficult situations, and everything is in house, so you can immediately get it done. क्या गिर गया
Right.
देखो. So now, so we have to expose the
Yes, sir.
supra superior region. Yes, please.
Absolutely. बहुत
Yes,
अच्छा
you
है
were
सर
saying
CBCT.
something.
No, मैं वही बोला था सर CBCT is a excellent tool. You can have it in your clinic itself.
Yes, yes.
And it
Yeah,
gives
yeah, yeah.
excellent resolution of the
It gives a very good
abdominal
resolution.
anatomy.
Yes.
Excellent resolution.
Many of my friends use it regularly for the CTPNS.
Right.
Right. So now we still
In
need
fact,
a
I've
little
got
more
two of
of
them, sir. Both my
exposure.
clinic.
Exposure
Yeah.
should be up to the facial, right?
Right.
And you should be also be seeing the stapedius tendons base, right? So pyramid दिख जाना चाहिए तुमको. ये
पिरामिड का बेस या
facial
पिरामिड का
up to facial आपने कर लिया तो that is fine. You will see the whole of the foot plate. Okay.
Sir, any particular direction of removing this overhang? नीचे से ऊपर, ऊपर से नीचे, ऐसा कुछ है?
वो again उसमें क्या है कि आप जो removal जो when you are doing, you don't go towards that membrane, tympanic membrane, right? So here,
Alright.
if you go from above downwards, you are not
Hmm.
going to damage any of the ossicular part like this, okay? But at the same time, you can go from below upward also.
Correct.
You have to
So
have
there's
a
no fixed rule.
controlled movement. Yeah, yeah. You
And
should
how
have
to
a
protect
controlled
chorda
movement
from
of your
getting
hand.
damaged, sir? Sir,
Yeah.
ये हमारे again I'm asking these questions for the beginners. How to prevent chorda from getting damaged?
Yeah, you have the chorda directly under your vision. So
Correct.
keep an eye on it, right? And when needed, you can just push it down or up, right? So it will not come in your way. अरे यार ओटी में एसी चल रहा है कि नहीं चल रहा है? हाँ। तो पसीना छूटने लगता है तब याद आता है कि ओटी में एसी है कि नहीं. Okay, so now, AC. No, so now let me do a suction.
Sir, do you ever use drill to remove this posterior bony canal wall overhang?
Yes, means I used to do drill, but I'm like if you have a good scoop, it is equally good.
Okay, sir.
अच्छा हो तो तुम्हारा ये एक्सपोजर दे ही देता है पूरा, right?
Yes, sir.
Right. And have you used that osteotome छोटा वाला gauze?
नहीं, हाँ वो तो यूज किया, पहले वही करते थे ना. We learned on that osteotome only.
Overhang निकालने के लिए भी.
हाँ वो पहले उसी से करते थे हम. We actually learned stapes surgery with that osteotome only, stapes osteotomes only.
Wow.
But then उसमें क्या है कि कभी आप स्ट्रोक मारो तो वो जो फ्रैक्चर लाइन कभी इधर उधर भी जा सकती थी.
Right. Right.
और scoops now have become so good that you don't need it. But yes, you can do it, and it should be sharp. And actually, that does this work within a second. एक झटके में पूरा निकल जाता है. और अच्छा भी लगता है.
उसमें कॉर्डा और फेशियल को कभी
स्मूथ कट नहीं होता है.
हाँ नहीं सर, लेकिन उसमें कॉर्डा डैमेज होने की कितनी चांस रहती है? आई हैव नेवर यूज्ड इट.
काफी चांस है, क्योंकि कई बार वो बोन के अंदर ही कॉर्डा फंसी हुई रहती है.
करेक्ट. सो वी शुड नेवर डू दैट, राइट? वी शुड यूज क्यूरेट ओनली.
ये स्कूप क्या है कि बहुत कंट्रोल्ड चीज है.
एब्सोल्युटली.
So that is good. You should have a good scoop. That's it, right? So अभी जैसे ये स्टेपिडियस टेंडन जो बेस पिरामिड से जहाँ से आ रहा है वो आपको पूरा दिख रहा है, राइट? नाउ
क्या आप कर्व्ड वाला यूज करते हैं, स्ट्रेट वाला यूज करते हैं?
क्या चीज?
अभी आप जो स्कूप यूज कर रहे हैं वो कर्व्ड वाला है, बेयोनेट है या स्ट्रेट है?
ये कर्व्ड वाला है.
बेयोनेट है ना? तो you like the curved one or you like the straight one?
Yes, I use both.
Okay.
खाली ये टिप पे शार्प होना चाहिए. ये कर्व्ड वाला है.
हाँ, कर्व्ड वाला है, ठीक है.
ओके, राइट.
मुझे भी कर्व्ड वाला ज्यादा पसंद आता है.
हाँ, 90 डिग्री मुझे वो चाहिए. इसे थोड़ा बड़ा है 90 डिग्री. So this is the 90 degree hook. We then check the IS joint. See, it is fixed. Can you see that?
Can you zoom the picture a little bit?
हाँ. नहीं, ये फिक्स है इधर.
सर zoom, सर थोड़ा पिक्चर zoom कर दीजिए ना सर.
एक सेकंड. हाँ
सर तो समझिए इस टाइम पर अगर इनकस भी फिक्स्ड मिला तो क्या करने का?
ये दिखता है अभी, इसको फोकस करना पड़ेगा। फाइन,
Focus.
नीचे से ये वाला। ओके,
Better.
इज इट बेटर?
Yes, sir. Yes, sir. Now
Sir, suppose if
Okay.
at this point of time, if your incus is also fixed, if you think the incus is also not moving,
Yes.
then what decision will you take? How will you approach?
Yeah. So, like if the incus is not moving, malleus is not moving, then what to do?
Correct.
So, it could be a fixation at the incus and malleus joint in the attic. That is a possibility, right? And if you feel that incus is not moving, malleus is not moving, and you are not going to benefit, then you can abandon it. Means that's what I would do. I would not go ahead with the surgery, right?
This is a very, very
Because
important thing for juniors.
रिलेटिव को
Don't
समझाया तो फिर समझा
I mean,
देने का कि नहीं हो पाएगा।
सर क्या होता है, जितने जूनियर हम होते हैं ना उतना ही बड़ा हमारा ईगो होता है।
नहीं, आपकी आवाज नहीं आ रही है, सॉरी, फिर से बोलिए।
मैं बोला जितने हम यंग होते हैं ना हमारा ईगो भी उतना ही बड़ा होता है। कह रहे मैंने केस अंदर लिया तब तो सर्जरी तो करनी है। दिस इज द मैसेज।
नहीं, ऐसा नहीं होता है, फिर वो फंस जाते हैं।
Exactly, this is the message that juniors should never take it on their ego कि नहीं सर्जरी करनी है। The patient has to benefit. Yes.
ठीक है, तो अब what we will do is we will see, I will be doing in the straightforward mode, not the reverse mode. Okay, so because वो सुबह कैडेवर पे देख ही लिया, now you disconnect the incus from the stapes. Okay, so go into the joint, IS joint, we are removing the mucosa, and you see now we have disconnected. Okay, so the stapes is free from the incus. Okay, now what you need to do is you can cut the stapedius tendon. Can you see that? So I will use a scissor. Give me the scissor, sharp scissor.
Sir, so stapedius should be cut towards the stapes or towards the pyramid? Any difference
See,
it makes?
it should be cut near the stapes.
Reason being?
कई बार क्या होता है पता नहीं चलता है, दोनों बीच में ही कटता है।
Correct. उसका कारण क्या है?
Near the stapes. वो इसलिए कि जब स्टेपिडियस कट होता है, जब स्टेपिडियस का रिफ्लेक्स आता है, तो एटलीस्ट वो मूवमेंट आती है उसकी, पर उससे कोई फर्क नहीं पड़ता है। ये सब आई जस्ट डोंट अंडरस्टैंड बिकॉज दे आर ऑल थियोरेटिकल थिंग्स। What benefits it's going to give?
Once you've already cut it, how does it make a difference, right?
You cut it, so you cut it. Either you cut here or here, it hardly matters.
Doesn't make a difference.
If you are
That's the
going to
answer.
preserve the posterior crura, right, or then only you can not cut and remove only the anterior crura and the anterior part and leave it there. So now you have a cut stapedius tendon, you have disconnected IS joint. Now what is needed is to remove the stapes suprastructure. Okay, so stapes suprastructure can be removed in many different ways. You can use a skeeter, you can use a laser, you can use a chlorotomy scissor, but the time tested and the oldest method is the leverage method, wherein you stroke at the neck of the stapes head. You stroke at the neck of the stapes head and give a movement, so that the anterior and posterior crura are fixed, so it will just take off the suprastructure. So now you see, I don't know if you can see there.
So you don't make a fenestra first?
I would make a fenestra later.
Why?
Right.
So that you get more space.
See, making a fenestra first is a good thing. You prevent any floating foot plate, right?
Correct.
And you can make the fenestra. But
Sir,
actually it does not
sir,
matter
आपका
much.
हाथ बीच में आ रहा है. We cannot
अभी
see
आ रहा
आपका
है?
हाथ बीच में नहीं आपका हाथ बीच में आ रहा है. No.
Just a second. थोड़ा दूर से पकड़ना पड़ेगा.
Correct.
Now we can see. Now
Yes,
giving a
thank you.
stroke here. Can you see that?
Wow.
So that
Wow.
stroke is called a leverage method, right? So it is
I find it very risky, sir.
type 1, type 2, type 3 levers, right? So here you are giving the force at the neck.
I find it very risky.
Sir, why don't you prefer reverse strapedotomy?
नहीं, I don't prefer वाली बात नहीं, कैसे भी कर सकते हैं। वो सुबह दिखाया ना, इसलिए अभी ये दिखा रहा हूँ। कैडेवर पे रिवर्स दिखाया ना।
सर इसमें कभी
जीवीएस राव सर ने सुबह
बाहर आए क्या?
हैं?
Sir, have you ever had a floater whole foot plate coming out while doing this?
देखो, yes I had, but then again that can also be managed. सिर्फ थोड़ा से पानी में डालिए.
So then does it make sense to drill the posterior crus with the skeeter?
It is like always good to make a hole first, stepidotomy first, and then
Correct.
take off the suprastructure. It is always
Correct.
good, right? But I just want to show that it does not matter even if you do it in
Right.
this way. Now you see, you have more space to make the hole. Okay.
Correct.
And secondly, when you are using a skeeter or a perforator, perforator can have its limitations while making the hole, but the skeeter will give the right point and right pressure, and it will create a hole immediately. Do I have a skeeter?
Right.
Iska bar kahan hai? So we have a skeeter here.
Very nice.
Bar.
So what size of fenestra? 0.6 or 0.8? What will you make?
0.6 I would prefer, पर
Right.
अब जहाँ जो है उससे करेंगे. कौन सा है ये?
पिस्टन कितने साइज का डालना है? 0.4 या 0.6?
0.4.
हाँ, तब तो 0.6 का ही होल बनाना पड़ेगा ना.
हाँ, 0.6 है. ये 0.6 है. ठीक है, दे दो ना. हाँ, 0.4 दो. ये कितना है जो तुम भर दे रहे हो मुझे?
अरे भारद्वाज भैया
वो नहीं चाहिए, पिस्टन दो ना. और अरे नहीं, वो वाली कहाँ है?
Sir, given a choice, will you drill the posterior crus or will you?
नहीं, मैं हाँ ठीक है ना, कोई फर्क नहीं. तुम खाली बता देना कौन सा साइज दे रहे हो. ठीक है.
मतलब लेकिन सर मेरे को
Okay.
डर लगता है.
So now at this point of time we would like to put a adrenaline soaked gel form like वो कहाँ क्रोकोडाइल तो हटाओ मत कैसे. एक ही चाहिए, बाकी सब चाहिए नहीं मुझे, हटा दो उसे.
नीचे तो वो है ना, नीचे कैसे जाएगा? ये तो नीचे तो
एक
प्रोमेंट
अच्छा क्रोकोडाइल चाहिए खाली.
कभी कभी फुट के बाहर आता है ना.
इसके अंदर वो मैंने स्टेपिस सुपरास्ट्रक्चर रखा है, उसको हटा लो जगह से.
इसलिए मैं नहीं करता हूँ.
So we will do a suction of this blood that has got collected here in the stapes area, and then we will come back.
स्टेपिस सर्जरी में तो है तो यूज करो.
Sorry?
नहीं सर, मैं वही बोला था, given a choice, if you have a
Yeah.
skeeter, you would like to drill the posterior crus and make it absolutely weak before breaking. अगर नहीं है तो फिर you can always do that. तो मुझे लगता है सर नहीं भी है तो पहले वो स्कोर करके पतला कर लेना चाहिए क्या ब्रेक करने से पहले?
हाँ, वो एक्चुअली अच्छी चीज है. आप पतला कर लो और फिर उसको ब्रेक करो. बराबर
कि एक्सीडेंट होने की संभावना और कम हो जाएगी.
बिल्कुल. हम लोग तो क्या अगर
सर आपका हाथ आते आते तो 25 साल लगेगा ना सर. 20 साल लगेगा. मैं बच्चों की बात करूं जो नए नए शुरू करते हैं, तो मेरे हाथ में सर ये टेक्निक से शुरू में जब मेरे पास नहीं हुआ करता था स्कीटर, 2004 की बात कर रहा हूँ सर.
फुट स्विच कहाँ है स्पीडर की? ठीक है, मिल गई. ओके, सो दिस इज 0.6 साइज बर. अरे तुम्हारी जो स्पीडर बर है, सो पोस्टीरियर 1/3. ओके, you make a hole, you go slow.
Very nicely seen.
Okay, so
Wonderful.
that is the stepidotomy. Okay,
Wonderful.
you can make it a little more smooth. Then you take the piston and put it. That's done. Okay, now
आसान करके बताएंगे ना तो सारे बच्चे कल से आके करने लग जाएंगे. बहुत कॉम्प्लिकेटेड बताइए, थोड़ा तो सरल करिए कम से कम.
See, even this thing can be done with a hand burr, like perforator and a hand burr then. Okay, so now we will measure the distance. Okay, so we have the measuring rods, we have that measuring meter of stars. Stars का या ना किसका है? जिसका भी है. हाँ, डेसिबल ने बनाया है. हाँ, मेरा था वो, ये मतलब ये अच्छा है। ओके, नाउ सी हम लोग क्या है कि अब वो जो फिक्स्ड मेजरमेंट वाले आते हैं ना रॉड्स, वो आजकल
सर
यूज
ये
नहीं करते हैं।
सर ये जेलफम में क्या है? इज इट प्योर एड्रेनलिन?
सॉरी,
ये जेलफम इज व्हाट? प्योर एड्रेनलिन?
आई कांट हियर यू, हेलो।
The gelfam we are using is having pure adrenaline
ये
because labyrinth is
हाँ,
already
प्योर
open.
एड्रीनल, सलाइन एड्रीनलिन है।
So
जेलफॉर्म इज सोक्ड इन सलाइन एड्रीनलिन।
saline adrenaline. So again, the message is that you cannot use 4% after you have opened up the labyrinth.
Yeah,
You can
yeah.
still use pure adrenaline or saline adrenaline, but you cannot use 4% xylocaine.
You know, there are different types of measuring rods. This is a metered measuring rod. Can you see this? You
Yes.
have a marker which you put it at the incus, and then at the upper end you have this measuring zig here. So it's the markings are done. Let me just change the focus and show you. You can see the markings are done on this. ये जैसे ही आप पुश करते हो ना, ये मार्किंग्स आ रहे हैं, ठीक है। So 1 millimeter, फिर 0.5 millimeters, ठीक है। So you
Yes.
see where you are. Okay, 1, 2, 3, 4, फिर 4.5, 4.25, 4.5, 4.755. Okay, so this is the measuring thing that we use. Okay, so now here the tip is not out. As I push in, it will come out, and you see at whatever level you get it, that is the length of the piston that you will use. Okay, so now
Right.
let me come back. Hold this.
So how important is this measuring zig? I have it, but I have never used it. मैं अंदाज से piston लगा
See
करके
what
देखता हूँ कि
happens.
कितना अंदर जा रहा है.
हाँ, नहीं, because
तो
इसमें
आपका
क्या
क्या
होता है कि
इसमें?
ज्यादातर घुमा फिरा के इंडिया में जो अपनी पॉपुलेशन है ना, ज्यादातर को 4.5 सेट हो जाता
Absolutely, you are absolutely
है।
right.
इसलिए
Unless
अगर
somebody is
आपको
making
मेजर
6
किए
feet
बिना भी
long.
डालना है तो 4.5 डाल दो।
हाँ,
बराबर, तो इसके अंदर भी देखना वो आएगा 4.5 भी।
correct.
लेकिन
Average
अभी
5.
एक
हाँ, मतलब
एक ये
5.25 से
एक्सरसाइज है, वो
पौने 6
करनी
वाले
पड़ती
तो
है।
सब.
हाँ, नाउ लेट मी सी। इसलिए क्या है कि कुछ कुछ इंस्ट्रूमेंटेशंस बहुत जरूरी है। यू लुक हियर। सो मैं क्या करता हूँ कि थोड़ा सा निकाल के रखता हूँ, फिर पुश करता हूँ।
ठीक है.
सो हिलाना नहीं टेबल, अभी टेबल टच मत करना। ओके, सो दैट्स द लेंथ। नाउ इसको मैं गिनता हूँ। कितना आ रहा है? 1 2। हाँ, सो ये बस वही आ रहा है, ठीक है। सो फाइनली वो घुमा फिरा के वही आता है कि 4.5 पे आके
Correct.
अटकता है।
सर, और अगर मेजरिंग जिग नहीं है जिसके पास, तो व्हाट इज द
तो
बेस्ट वे
नहीं, वो
टू?
फिक्स्ड लेंथ वाले आते हैं ना, you can use the
हाँ सर.
fixed length measuring rods, or
हाँ
you can have the Teflon pistons already made, means cut to 4.5, 4.25 and 4.75, or 4.
All right.
This okay, and use that and see, check which one fits in well.
All
ये
right.
हम लोग भी करते थे कभी कभी,
या
right?
सर, एक टेक्निक मैं क्या करता हूँ कि मैं 6 मिलीमीटर वाला पिस्टन मेरे पास रहता है, लेंथ वाला. उसको
हाँ,
रखता हूँ और देखता हूँ कि वो इनकस के कितना ऊपर है. उसका जो कर्व
हाँ,
है, इट शुड लाई ऑन द इनकस. कट करके वापस से लगा के देखता हूँ इनकस के कितना ऊपर है, बिकॉज द थिकनेस ऑफ दैट लूप इज अराउंड 0.25. तो अगर
हाँ,
मेरा लूप वहां पे बैठ रहा है तो होल बनाने के बाद वो उतना ही अंदर जाएगा. सो 0.25 अंदर जाएगा. दैट इज अ वेरी वेरी गुड guide
हाँ,
on the table to do if you do not have a. I don't want to use a measuring jig. तो मैं आज तक वही 25 साल से वही करता आ रहा हूँ, 99 से.
हाँ, नहीं, बिल्कुल बिल्कुल कर सकते हैं। वो जैसे हम लोग वो टॉर्प पॉर्प में यूज करते हैं ना, कि उसके
करेक्ट
प्री
करेक्ट.
फिक्स्ड वो आते हैं और उसी को लेके आप कर लो, बराबर। सो नाउ दिस इज द piston that we will be using it. Okay, so इसकी
Right.
लेंथ तो ज़्यादा है, तो हमको 4.5 की लेंथ में कट करना है. So you should be having this jig. So 4.5 में डाल के फिर हम कट करेंगे, ठीक है।
All
So now
right.
give me a forceps. हाँ, क्रोकोडाइल इसको उठाने के लिए फाइन चाहिए, थोड़ा
कौन
खड़ा
से
है
ब्रांड का पिस्टन है सर? Which piston is this?
पिस्टन। कौन सा ब्रांड है भाई? ये ईऑन कंपनी का है।
Yon, okay.
सी कंपनी और वो ब्रांड वो आप
Doesn't
तय कर
matter.
सकते हो, लेकिन टेक्निक तो सेम ही रहेगी जो भी यूज करो।
हाँ नहीं, I just asked.
हाँ नहीं
आप कौन सा यूज करते हैं सर?
मैं तो ग्रेस का यूज करता हूँ।
हाँ मैं भी
I
दूसरा ही बोला।
don't compromise on the quality of the piston. So I would be
Great.
using, means I always
Great.
use the Teflon Grace piston, or if it is titanium then Coors.
All right.
और ज्यादा टाइटेनियम ही हो रहे हैं आजकल।
Oh. तो ग्रेस का सर मेमोरी बहुत अच्छा है, मतलब एक बार डाल दिया तो फिर
अरे बहुत
देखना नहीं
अच्छा है,
पड़ता है।
तो
Memory
फटाक
is
से
very
वापिस
good.
आराम से बैठ जाता है, झंझट ही नहीं है।
बल्कि इतना जल्दी बैठ जाता है कि सिस्टम फटाफट
हाँ
डालना पड़ता है।
थोड़ा फास्ट रहना पड़ता है।
हाँ थोड़ा फास्ट करना पड़ता है ग्रेस में।
यार रुक, ठीक है, पंखा भी चल रहा है ना। कोई बात नहीं, ये तो हाथ से भी डाल देंगे। Okay, so you are in 4.5, then keep a finger here, turn around and then cut sharp blade.
ये भी 6 मिलीमीटर वाला था, लगता है 6 का था।
So अरे पंखा चालू रखो, तुम चिंता मत करो। Okay, so this is sharp blade cut. Okay, so now you have a length of 4.5. Okay, so
Sir,
this is
regarding
4.
direct piston versus vein graft.
हाँ, vein graft is good, definitely,
आप
but you
करते हैं?
don't need it always. है नहीं,
आप
मैं तो
करते
अगर
हैं?
कभी फ्लोटिंग हो गया और
वही करते हैं।
स्टेपेडेक्टोमी हो गया तो करता हूँ,
Absolutely.
अदरवाइज नहीं करता।
Absolutely.
आई
Otherwise नहीं
यूज फैट या ईयर लोब्यूल फैट रख देता हूँ मैं साइड में।
करता। Even I do the same. तो वही question is कि why not?
ईयर
It
लोब्यूल
is
में
not
से थोड़ा सा फैट लेके रख देता हूँ मैं।
correct. Correct. Direct piston
दैट
में
इज
क्या
ऑल्सो
problem है?
टिश्यू। हाँ क्या बोल
कोई
रहे?
problem नहीं है, right? Direct piston में कोई problem नहीं है ना, मतलब वही बोल रहा हूँ, मैं भी नहीं करता हूँ। But my experience is
कोई
much
फर्क
less
नहीं
than
पड़ता है
yours. कोई फर्क नहीं पड़ता।
अगर प्रॉपरली प्लेस्ड हो तो कोई फर्क पड़ता नहीं है। Okay, so now let's come back. Margins पे शक करो, डायरेक्ट मत शक करो। See, I am
बराबर है।
away from the hole
Correct.
and we
What
are
is the
just
number of suction you are using? Which number? 24, 25?
कौन सा है ये?
Suction
25 के आसपास।
25 के आसपास, correct.
पतला तैयार रखो, पतला तैयार रखो। हाँ, पतला वाला तैयार रखो।
20 is too thick. वही मुझे लगा कि थोड़ा मोटा है इसलिए।
हाँ ये ऊपर है ना, वर्क तो 26 का करेगा सबसे अच्छा, लेकिन क्या होता है कि वो सब ब्लॉक हो गए होते हैं ना यहाँ पे। देखो 24, 25,
24, 25 should be fine. 24 should be the best. So one thing sir said, never suck inside the hole. Never, ever. Because you will just suck out the labyrinth.
तो कटवा था। हाँ एकदम जो सबसे पतला आपके पास है ना वो दे दो।
सर एक क्वेश्चन है कि अगर इस टाइम पर अगर फेशियल डेसेंट है थोड़ा, will you put the piston or not?
See again, you have to judge that facial descent is there, but how far it is.
Absolutely correct.
If it is on the, if it is on the step is foot plate, and you don't have space.
हाँ अगर ओवरहैंग है तो अलग बात है, अगर ओवरहैंगिंग फेशियल नहीं सिर्फ डेसेंट है तो do you even check if it is not overhanging? Do you even check for dehiscence?
Yes.
But even if it is dehiscent, you will still put the piston, right?
Yes, yes.
Correct.
मैं तो आजकल क्या करता हूँ, एक पेरिकॉन्ड्रियम या ये लेके जो डेसेंट फेशियल पे रख देता हूँ और साइड में
पिस्टन डाल के बाहर हो जाते हैं। करेक्ट।
हाँ सर,
नहीं इसीलिए मैं ये सब सवाल पूछ रहा हूँ बिकॉज
हाँ नहीं that is what is needed because yeah.
I remember when I was very young, so I was doing stay-pace and facial was absolutely decent. Overhang was very minimal. I had enough space to put the piston, but मैं इतना डर गया कि बाहर आ गया and उसको मैंने hearing aid दे दिया and that was मतलब मैंने फेनेस्ट्रा भी नहीं बनाया लेकिन सुपर स्ट्रक्चर निकाला था और फिनिस्ट्रा बनाया नहीं, तो आई जस्ट लेफ्ट इट लाइक दैट. आई वाज वेरी यंग. इट वाज माय फर्स्ट और सेकंड ईयर ऑफ प्रैक्टिस. टुडे व्हेन आई लुक बैक, आई वाज, व्हाई डिडंट आई डू इट? जरूरत ही नहीं थी ना, जब ओवरहैंग था नहीं तो अपने को क्या जरूरत थी? रहने दो, डिसेंट है डिसेंट है.
वो आपके एरिया से दूर है तो कोई दिक्कत नहीं है.
कोई दिक्कत नहीं है. आई एम आस्किंग दिस क्वेश्चन सो दैट youngsters, when they get those situations in the OT, they should not panic.
Yeah. और हर एक में सर्जिकल लैंडमार्क इम्पोर्टेंट होता है. अगर आपका सब सर्जिकल लैंडमार्क, आपका टारगेट एरिया ठीक ठाक है तो कोई दिक्कत नहीं है.
करेक्ट.
सी नाउ व्हाट आई एम डूइंग इज, आई एम जस्ट, ये थोड़ा सा बड़ा कटा हुआ है कि एक जेल फॉर्म में हाइपोटिम्पानम में रख देता हूँ कि वाइल पुटिंग द पिस्टन अगर थोड़ा इधर उधर हुआ और गिर गया तो नीचे हाइपोटिम्पानम में गुम ना हो जाए.
Very nice. That's a very nice tip. Very good tip.
क्योंकि बहुत लोग का गुम होता है. I have removed up to 3 pistons in a revision surgery.
सर, और अभी एटिक में कभी गुम हुआ है क्या सर?
एटिक में अभी को जगह नहीं बनाई है ना, तो इसलिए गुम नहीं होगा.
गुम नहीं होगा.
अभी
करेक्ट.
हाँ, दूसरी चीज के जैसे ये कौड़ा है तो थोड़ा सा कौड़ा को हम लोग नीचे ले लेते हैं.
करेक्ट.
देख रहे हो,
वेरी नाइस.
नीचे इसलिए रहता है कि बाद में वो पिस्टन को भी सपोर्ट करता है.
करेक्ट.
पर कई बार इसमें टूट भी जाती है.
Very important tips. Small tips, but very important.
Sir, if you encounter perilimb gusher during making the fenestra, how do you manage it?
क्या बोल रहे हो? While
Sir, perilimb gusher. If you encounter perilimb gusher while making the fenestra.
कुछ नहीं, कोई बात नहीं. वेन रख देने का, फेशिया रख देने का, वेन रख देने का, उससे कोई फर्क नहीं पड़ता है बहुत. Okay, so now you see you have a direct angle, you have the incus, you have the cauda placed inferiorly. Okay. अब
Sir, I think सबसे important point ये कि डायरेक्ट एंगल दिखना चाहिए, क्योंकि माइक्रोस्कोप करता है ना तो फिर अपने को लगता है जगह कम है.
हाँ, फिर जैसे ये पिस्टन है तो आई वुड ऑलवेज पुट अ पिक एंड मेक इट ओपन. राइट.
करेक्ट.
सो ये पिक से इसको ओपन करते हैं और इस पे जैसे चढ़ाते जाते हैं वैसे ज्यादा ओपन होते जाता है. बराबर.
करेक्ट.
एक मुझे अच्छा क्रोकोडाइल थोड़ा सा सॉफ्ट है, मतलब ये अच्छा खुलता बंद होता है एक बार में. 2 ये थोड़ा सा कड़ा है, पकड़ने में गड़बड़ दिख रही. तो कप है, कप नहीं चाहिए
तो
मुझे.
सर ने ये जो जेल फोम रखा है ना, उसका एक फायदा ये भी है कि वो आपका टिम्पैनिक मेम्ब्रेन फ्लैप को भी पूरा एकदम दूर रखता है, नहीं तो फ्लैप बार बीच में आते रहता है डालते टाइम पे.
बिल्कुल. देखो है कि नहीं है. Now to hold the piston you need a good crocodile.
Correct.
So that you can just put it down. So I am just searching for a good crocodile. नहीं तो फिर जो है उसी से चलाएंगे काम.
सर, तो पिस्टन डालते टाइम पे आप हैंड सपोर्ट के लिए कुछ यूज करते हैं कि
नहीं? कुछ सपोर्ट नहीं यूज करता हूँ. वो तो क्या, इसका पेशेंट का शोल्डर होता है ना, वही काम कर जाता है.
वही पूछा था सर कि वो हैंड सपोर्ट उस टाइम पे, क्योंकि कई लोगों की आदत है ऐसे हाथ उठा के रखते हैं तो ट्रेमर बहुत आता है.
नहीं नहीं, कौन सा ये? हाँ, ये ठीक है. दिस इज ओके. थोड़ा लेकिन छोटा है, लेकिन चलेगा. बराबर. आ रहा है एक और लाइट.
लाइट
हाँ.
सर, तो आपके हिसाब से स्टेपिस सर्जरी में सबसे क्रूशियल स्टेप क्या है?
स्टेपिस सर्जरी का हर स्टेप क्रूशियल है, लेकिन सबसे क्रूशियल हो जाता है पिस्टन रखना.
Correct.
Once everything is done, then you should be in a position to put the piston in one go. कई बार नहीं हो पाता है.
Absolutely correct. So that's why I asked this question. कि ये सर का एंगल देखिए, he is not hold it absolutely straight, it's little tilted.
थोड़ा सा एंगल रखना पड़ता है.
करेक्ट. क्योंकि अगर एकदम स्ट्रेट रखें तो हाथ पूरा ऊपर आ जाता है, फिर ट्रेमर बहुत आता है. So all those small things.
ये देखो, ये बंद हो गया तो मुश्किल हो गया, मुझे छोड़ना पड़ रहा है. बराबर. ये एक्चुअली क्या है कि इयन वाला जो प्रोस्थेसिस है ना,
हम्म
इसकी मेमोरी वेमोरी सब उतनी अच्छी नहीं है और वो थोड़ा सा टफ प्लास्टिक टाइप है।
ओ
तो कहीं भी
थोड़ा
थोड़ा
खोल
इधर उधर
करके
टच हुआ, टेढ़ा होगा, खुला है तो खुला
हाँ
रह जाएगा, ये सब होता है
ओ
इसके। तो इसकी
ओ
जो क्वालिटी ऑफ टेफ्लॉन आई डोंट फाइंड इट सो गुड। लाइट दो इधर,
हम्म
लाइट। जस्ट हम लोग थोड़ा सा इसको खोल के रखेंगे थोड़ी देर के लिए। आई विल पुट इट इन दी
करेक्ट वार्म सलाइन सलाइन
हाँ, इसके अंदर 2 मिनट रखेंगे तो वो क्या है कि खुल जाएगा ठीक से।
हम्म
मीनवाइल
और सर अगर गलती से अगर इनका हाइपर मोबाइल हो गया, इस टाइम पे हिल गया, हाइपर मोबाइल हो गया, तो क्या करेंगे?
अगर हाइपर मोबाइल हो गया तो आइडियली करना नहीं चाहिए। मतलब उसको
सर्जरी करनी चाहिए।
क्या है कि एक जेल फोम वगैरह रख के छोड़ दो, फाइब्रोस हो जाए तो 1 आध महीने बाद फिर से करो।
दैट्स द राइट
ऐसा
आंसर। सो अगेन अगेन अगर इनका पूरा एकदम हिल रहा है तो प्लीज डू नॉट ट्राई टू पुट पिस्टन ऑन दैट, बिकॉज वो पिस्टन काम तो करेगा नहीं और बल्कि टेढ़ा मेढ़ा लग जाएगा तो लैब्रिंथ भी तकलीफ देगा। सर तो जब दोबारा जाएंगे इसमें तो फिर लैब्रिंथ को वापस से खोलना पड़ेगा ना, तब तक तो लैब्रिंथ बंद हो
हाँ, वो
चुका
थोड़ा
होगा,
फाइब्रोस ऊपर आ गया होगा
फाइब्रोसिस
तो
हो
फिर
गया होगा।
खोलने का हो तो दैट इज ओके।
सो उस टाइम पर लेजर रखना इंपॉर्टेंट रहेगा सर?
रहेगा ना, बिल्कुल।
करेक्ट। आई एम
लेजर
आस्किंग
विल
दिस क्वेश्चन सो
डेफिनेटली।
दैट कि सारे सिचुएशंस लोगों को
हाँ,
अब वही होता है कि अगर ये पिस्टन बहुत अच्छे क्वालिटी का ना तो इनका हाइपर मोबाइल होने का चांस बहुत बढ़ जाता है।
हाँ, बराबर। सी नाउ दी long point, this piston base is in the opening that we have made, that is the stapediodome,
करेक्ट
stomacite, and you have the
करेक्ट
ring on the incus. Okay,
करेक्ट
so we'll give some time
एब्सोल्युटली।
for it to just retract and close. मैं क्रीम विम्प करता नहीं हूँ क्योंकि ये सब
सर लेकिन
रिस्टन
ये
जो यूज करते हैं ना, आराम से दे टेक देयर मेमोरी एंड कम बैक
हाँ,
एंड दे
लेकिन ये
क्लोज।
वाला ग्रेस में हो जाता है सर, इसमें नहीं होगा। तो
हाँ,
इसको
तो
कर दीजिए, इसको
इसको
कर दीजिए क्रिम।
हाँ,
ग्रेस में
इसको
हो
अभी
जाता है, इसमें
करते
नहीं
हैं।
होगा।
और ये भी मैंने देखा कि जैसे ये है ना, ये बंद तो हो ही रहा है
हो
अभी।
रहा है क्या?
लेट्स वेट फॉर अ मिनट एंड देन व्हाट वी डू इज वी चेक के बराबर है कि नहीं। सो वी डू अ हैंगिंग एंड अ बेंडिंग टेस्ट। सो व्हाट इज दैट? दैट यू लुक एट द इनकस, ये लो, इसको ऊपर करके देखो, ओके, और इसको नीचे करके देखो, ओके। सो ये अगर बैंड होता है, ये देख रहे हैं मूवमेंट आ रही है इसकी,
करेक्ट।
ओके। सो अगर ये लंबा होगा तो बैंड हो जाएगा और छोटा होगा तो ऊपर करेंगे तो हैंग करने लग जाएगा, राइट। सो वी ऑलवेज डू अ हैंगिंग एंड अ बेंडिंग टेस्ट एंड देन ओनली वी कंफर्म दैट ओके दिस इज फाइनली प्लेस्ड। सो और ये जो कॉर्डा है इसको हम नीचे की तरफ रख देते हैं ताकि ये अगर थोड़ा इधर उधर करे, खराब क्वालिटी भी हो तो स्लाइड ऑफ नहीं हो जाए, ठीक है। एंड देन वी रिपोज इट बैक दी टेम्परेचर फ्लैप, but I always use a small piece of fat to support this. So give me a local infiltration. तो लोब्यूल जो है, इधर लोब्यूल में से हम थोड़ा सा फैट ले लेते हैं। यहाँ इंजेक्टेड स्टेब नाइफ ये ले लो। और एक पेशेंट हिल रहा है, पेशेंट हिला। 10 मिनट और दो, ये वो खबर हो ही चुका है। दिस इज डन। उधर रेडी हो गया है ना, सतीश सर का रेडी हो गया उधर। हाँ हाँ, तो जब बोलोगे तब उधर शिफ्ट करेंगे। यहाँ तो हो ही गया है, इधर खाली पैर रख के बंद ही करना है, बराबर। सो नाउ जस्ट अ स्मॉल इंसिजन। लाओ एक कप फोर्सेप दो, कप कप, स्मॉल कप फोर्सेप इसमें है। क्रोकोडाइल वाला कप दो ना।
लोकल में
एक फैट ये भी थोड़ा सा एक्चुअली बड़ा है, थोड़ा सा छोटा चाहिए होता है, ये काफी बड़ा है छोटा नहीं तो जैसे कप फोर्स है वो, तो आप इसको पकड़ो, ये निकालो, एक छोटा पीस ऑफ फैट आ गया, दिख रहा है हियर, यू कैन सी द फैट, ओके, सो वी विल यूज टू पुट दैट फैट इन। अब मेरे पास एक पिक है, इसके ऊपर हम इसको उठा लेंगे,
कुछ भी लोकल में क्यों करना है?
ओके, गिव मी द स्पेculum बैक।
मैं तो स्टेपिस भी जी में करता हूँ, क्यों लोकल में करना है? जरूरत ही नहीं ना चेक करने की, आपने बराबर से पिस्टन डाला तो काम करने वाला ही है।
ओके, थोड़ा इस तरफ करो, हाँ, नाउ वी टेक दिस फैट एंड पुट इट एट दी स्क्रीन, नहीं आ रहा है, एक सेकंड
सर प्लीज सेंटर द पिक्चर।
हुआ?
सर ये फैट का पर्पस क्या होता है? डालता मैं भी खाली आपसे क्वेश्चन पूछने के लिए पूछ रहा हूँ।
नहीं नहीं, वो क्या है कि वैसे भी तो टिश्यू है ना, तो वो एक एपिथेलियम का लेयर बना देता है, सील कर देता है, आप उधर ब्लड का स्पॉट भी रख सकते हो, ब्लड क्लॉट भी रख सकते हो, ऐसा कुछ नहीं है।
करेक्ट,
इनफैक्ट
सो बेसिकली
भी रखो तो बहुत
कोई भी
ठीक
टिश्यू
है,
रखेंगे तो
ये
थोड़ा टिश्यू
टिश्यू हो गया ना,
थ्रोम्बोप्लास्टिन वगैरह
देखिए,
रिलीज
हाँ,
करेगा,
तो थोड़ी बहुत जो भी जगह है आसपास में उसको ये
वो उसको
फिल
भर
अप कर
देगा।
देगा, हील करने में
करेक्ट
हेल्प करेगा, ठीक है,
करेक्ट
सो दैट्स द फैट प्लेसमेंट, so it's going to help, that's what we presume, as you said, कि पता नहीं क्यों रखते, लेकिन रखते तो है, right? एक से छोटा सा जेल फॉर्म चाहिएगा मुझे, एंटीबायोटिक वाला, so sorry,
मैंने 2-4 दिन नहीं रखा तो कोई फर्क नहीं पड़ा, तुम याद आ जाता है तो रख देते, भूल जाते हैं तो भूल जाते हैं।
आवाज नहीं आ रही, आवाज नहीं आ रही, हेलो
देखो, हेलो
हाँ
हेलो
बोलो विकास,
सर,
हाँ
मैं बोला सर भूल जाते हैं तो कोई फर्क नहीं पड़ता है, लेकिन याद आ जाता है तो रख भी देते क्योंकि
यार मुझे कुछ सुनाई नहीं दे रहा है।
नो प्रॉब्लम सर, आप सर्जरी खत्म कर दीजिए।
एक जो बाद में क्या, एक छोटा सा जेल फॉर्म हम रख देते हैं अपने मन की शांति के लिए, वैसे इसकी कोई जरूरत नहीं है। ये हील हो जाएगा ठीक से, सब बराबर रहेगा इसके लिए, राइट, सो वी जस्ट प्लेस इट and then reposit the flap and that's it. Give me the p knife. इधर आगे थी, आगे यहाँ थी ना कहीं, कहाँ गया, अरे इधर ही रखी थी, सर्कुलर का जिससे इंसिजन रखा था ना, फ्लैग फ्लैग, नहीं तो कोई एलिवेटर वेलिवेटर देखो, ये रहा ये रहा ये रहा ये रहा, ओके फाइन, सो नाउ डिपॉजिट द फ्लैप बैक। रखते समय हर समय टेंशन होता है कि साला कहीं परफोरेट तो नहीं हुआ है, that's giving it back, okay,
वेरी नाइस सर,
and we will put a antibiotic soaked gel foam on the incision site only, that's it,
राइट
okay, so that's the end of the surgery, you can switch over to the other OT, okay,
थैंक यू सर,
thank you very much,
थैंक यू सर,
थैंक यू सर, थैंक यू सर,
thank you। तो उतना ही कट करना है, वो नीचे से मेजर करना होता है, अगर ऊपर से किए हो तो उतना कम रखना है, नीचे से किए हो तो उतना ऐड कर देना होता है। हेलो, हाँ,
Hello, auditorium. Can you hear me? This is Dr. Shirish.
yes hi Shirish, but we cannot see your picture,
ठीक है,
I am not able to hear your voice
एक
very clearly.
जेल फोम या कॉटन वाला दे दो, एक मुझे गॉस्पेल दीजिए सिस्टर,
Hello.
कोई भी
आप सही मिली।
yes Shirish, we can see you now, you can start.
Okay, so we are just waiting for the microscope to be shifted to this OT because we require the microscope for papilla dilatation.
What is the case?
Right, so we are doing that. This is a case of right submandibular silentoscopic obstructive salivary gland disorder.
Okay.
Quite a few times it is asked what will be your primary investigation. and I jokingly say my index finger is my primary investigation. So remember to palpate intraorally for all submandibular pathologies. So you can ballot the gland. Sometimes you are able to palpate the stone. So examination is very important for that. The other thing
Right.
is the immediate investigation that I would order would be an ultrasound. In ultrasound, we get either you get that the gland has a stone, or you say you get a picture of chronic sialadenitis with no stone. Now, no stone does not mean no stone, because no stone can mean stone less than 3 millimeters, which some of the ultrasound machines cannot detect. It can also mean the ultrasonologist has not traced the gland the duct right up to the papilla, so they have missed out on a distal stone. Distal is towards the papilla. Or the third possibility is that there is a stricture inside. So these are important things. If the ultrasound person can give me an exact location of the stone, and for that what I do is I send them a simple line diagram of the submandibular gland and ask them to mark where they find the stone is. But if there is any discrepancy, then what I do, and especially if the stone is not palpable, I will do a CT neck plane to give me an idea of where the stone is lying, how many stones are there, what is the size of the stone, and what is the lie of the stone. So in this case, we have a CT scan done. It is a 9 by 8 millimeter stone close to the hilum, which is the proximal end of the duct. So our plan of action is we'll dilate the papilla, go in through the papilla, visualize the duct, see if we can see the stone. If we can see the stone, if there is space all around, we pass a Dormia basket, trap it and get it out. But a stone this size will generally not have space all around it to get trapped. What I envisage is I might have to do a combined approach, internal combined approach, where I will dissect the floor of the mouth, remove the stone, and then do a check scopy, check that there is no stone stricture inside, go into the proximal ductal system, and if needed, stent. So that is the plan of action.
Sir, what's your stand on parotid stone in the parotid gland? Actually, sometimes patient presents to us. Sometimes there's near the opening there is a stone. Sometimes it comes out automatically, and then you feel like okay. So after 1 or 2 months, they come again with parotitis on one side only. So
Sometimes they have multiple stones. So one of the stones passes, they get temporarily relieved. The next stone obstructs and causes parotitis.
So what's the exact plan or manual we should follow in such cases?
The thing is, again, it's the same. If you have a symptomatic parotid obstruction, get an ultrasound done. You should be able to see the stone on ultrasound. If it is in the distal 1/3, that is from the anterior border of the masseter to the papilla of the parotid, you can sometimes try to do it under the microscope from the papilla itself. But mind you, if you cause fibrosis to the papilla, then it is going to end up with a parotidectomy. So better be careful about handling the parotid papilla.
So what you stand on this one? Because the nature of the stone in submandibular gland and in the parotid is also differs actually. So sometimes radiologically it's a challenging task for us to exactly locate.
No. Let us be very clear. There are no radio-opaque stones. I have not seen in my entire life any radio-opaque stone. Radio-lucent stone, sorry. All stones are radio-opaque. So generally you should be able, with a good sonologist, you should be able to find it. If you have any doubt, get a CT scan done. And for that, what happens is our sonologists also are not used to doing ultrasound of the salivary glands. You send them a requisition for ultrasound salivary glands, they write down a paragraph of the thyroid, and in one line, both submandibular parotid glands are normal. That's
It should
what
be
is the normal format.
the resolution needs to be changed in case of salivary gland.
So we have to ask them to tell us about whether they can see the duct, whether the duct dilates after giving vitamin C tablet. What is the nature of the parenchyma? Is there a stone there, or can they see multiple hypoechoic areas, especially in the parotid, which are indicative of multiple strictures in the gland, seen in autoimmune parotitis? Okay, now I think we will discuss things later. We have all equipment in place. Can I have the external camera, please? Okay. So this, can you see what I'm holding in my hand?
Yeah, what is that? What is that?
Can you see that or not?
Yes, we
We
can.
can.
You can? Okay, so
Yes.
this is a all-in-one style endoscope.
Okay.
As you can see, it has one fiber optic channel which carries the light source and carries the image back to the camera here.
Okay.
It has one irrigation port and one central port for instrumentation. Now
Okay.
this is in a protective sheath. This is the actual size of the scope. Okay, it's about 1.3 millimeters in diameter.
Wow.
Right. Now one important thing
Carl
that you have
Stone.
to learn in
Which company is
Carl
that?
Stone. Yes,
All right.
Carl Stone. One important thing that we have to now remember is all our ENT surgery is based on bony landmarks. But
Yeah.
here we do not have any bony landmark.
Okay.
So what we have to do is we have to orient the scope so that whatever is the actual picture is what you see on the screen.
Yeah.
Can you focus on the screen here? So in actual, I can properly read these letters, but if you see, can you focus? Okay. So the endoscopic picture is showing the letters in a vertical orientation. So what we do is we rotate the scope and the camera relative to each other till we get it correct.
Like
Are
when
you getting the
any
endoscopic picture?
endoscopic.
Yeah, can you see the
surgery.
endoscopic picture?
No.
No.
Okay. Just let me know when you see the endoscopic picture.
Waiting. Yeah, now we can see.
You can see the endoscopic picture? Okay.
Correct.
So we'll rotate it once again. So is this oriented horizontally or vertically for you?
Vertically.
Vertically. So that's not how it is for me here. It is horizontal for me. So we are going to rotate the camera in such a way that it becomes horizontal.
Right.
Can you see the rotation happening?
Yes.
Yeah. Okay. So why do we have to do this is because once you go in, if you are like mal rotated, then you never know which direction to go in. You could be seeing a branch coming at 3 o'clock position, but when you actually go there, it actually could be at 6 o'clock position or 9 o'clock position. So that's the reason why this orientation. See, in a nasal surgery, you know where the septum is, where the middle turbinate is. So even if the camera is rotated, you can still make out what is superior, inferior, medial, lateral. But that is not the case here. So we have prepared the scope like this. We have put in saline into the irrigation channel and we have kept it ready. Give me the protective sheet. Protective sheet, please.
हमें है भैया
हम बीच में जाके खा
And in
Yeah, it was the sheet. So now we are going to do the papilla work. I'm going to keep the scope under its protective sheet so that it doesn't get damaged. Just be careful. Don't pull it out too much. Now give them the endoscopic, the microscopic picture, please. Sanju, you will have to hold this for me, the lip like this. Yeah, but this should not.
Audio visual, please give the microscopic picture. We are still having endoscopic picture.
लगा दो वहां से. Once you get the microscopic picture, do let me know.
It's blank at present, sir. Yes, sir. We have got the microscopic picture, sir.
Okay, just let me adjust it for me and then I'll see. Okay, now I'm going to orient you. Give me the number
Yes, sir.
1 dilator. Always dip and give it like this. So these are the inferior incisors. Okay.
Okay.
Can you see
Yes,
this?
sir. Yes,
Yeah.
sir.
This is the tongue frenulum.
Okay.
This is my finger which is retracting the tongue.
Okay.
And you will have to find the papilla. The left papilla will be here and the right will be here. Okay, so we have to find it. What we have to always do is keep on looking at the papilla for all patients that come to your OPD so that you get used to the variations in the anatomy. Now, normally this looks like a papilla for quite a few people, but this is a vascular malformation over here. And I can probably see just here a papilla.
Yes. Yes, sir. There we are.
Okay, so can you see? Can you
Yes,
see a
sir.
black ring on the dilator?
Yes,
Just at
sir.
the papilla? Yeah. So generally that is 5 millimeters from the tip. So you are not supposed to go in too much inside. Okay. For beginners. But once you are used to it, you can put the dilator into a larger length, longer length. Okay. Can you see the papilla gripping the dilator?
Yes, yes.
Yeah. So
Do
what
do
I'm
we
going to
need to
do is
change the
I'm going to
direction?
change the direction of what?
So more
You want it
horizontally now?
centralized?
Actually, the picture which we are getting, actually, it's difficult whether it's a vertical one or we are more towards oblique or like.
It's a little bit oblique because I am operating from the right side. It is the same as I am seeing through the microscope.
The point is, I want to ask that as we go deeper, we can further make it oblique, so that means more horizontal.
Yeah, so the camera needs to be rotated from. There's an inbuilt camera.
Okay.
So I don't know if you can rotate the camera.
So we are having a microscopic picture right now.
Yeah. So can you see the dilator in the papilla now in the duct?
Okay, sir.
And this is my finger, which can tense the mucosa if needed.
Yes.
So we have 5. I use a set of 5 serial dilators. You can see one ring over here. That is number 1. The next dilator will be number 2. So give me number 2. Number 2. Hold on to this. Yes. When I ask you to remove, rotate and remove. Yeah, rotate and remove. I'm going to dip this dilator in saliva to make it more, rather less traumatic. Can you now see the dilated papilla?
Yes, very nice.
Right. So now the number 2 dilator goes in. Number 3 ready, please. Thank you.
It's a sort of Seldinger technique, I think.
No, Seldinger is like on a guide wire. Seldinger is the same. You put in a guide wire and put in hollow sheets, whatever you do. You can use this technique in any hollow organs of the body. It could be vessels, ureters, anywhere. So I don't use Seldinger technique. This is a more direct one. The other advantage is this black ring that you see. You can see this dilator is conical up to the black ring, and then it becomes cylindrical. So at the ring, the diameter is equal to the tip of the next dilator.
Okay.
Are you getting what I'm saying?
Yes.
So that's why this is called a serial dilatation, one after the other.
Got it.
Number 4. This moistening with saliva is very important because see, the moment you keep it like that, it frosts because of the AC. Okay, remove this.
So how much we should dilate, sir, to what level?
It depends upon what scope we are using.
Okay.
If you are doing a diagnostic scopy, you can dilate till dilator number 3.
Okay, sir.
But what I do always, I follow the philosophy of doing a therapeutic scopy, and if I fail, I label it as retrospectively as a diagnostic scopy. So I always dilate it to number 5.
Okay.
Retract the lip. Retract the lip. Number
Can't
5.
we have a dilator with like inflatable balloon sort of? So repeated.
I mean, when see when you have a simple thing like a steel conical dilator doing the job, why do you want to complicate it? Get into a balloon, disposable, throw up, more cost, difficult to introduce,
but
all those things. Yeah, when you can do it with simple instruments, I don't like to.
repeatedly
use
we are
complex
like introducing, so it will also induce injury. My point is this: if you put a
What will
balloon,
not
simple.
you mean to say if you use a balloon dilator, it doesn't anything that dilates will cause injury in a circular tube.
Like
Injury is
we
bound to be there.
introduce and then gradually inflate, like inflatable balloons are there.
You dilate whatever way you are causing injury.
Yes, that's
Look at the physics of it. Now, because give me the number 5. What we are going to do is keep this number 5 dilator in.
Number 5 will correspond to how much millimeters diameter, sir?
It is 2.5 millimeters
2.5
diameter.
Fair enough. Good. Our scope is 1.3.
Yeah.
And the outer the protective sheet is
No, the entire scope now is 1.3 millimeters.
so
Okay.
good enough then.
So yeah, but then for me, I don't want the papilla to be gripping my scope to prevent
Right.
smooth movement.
Smooth movement, yes. Keeping that thing in mind, we are dilating to a greater extent.
Yeah. Right. Now, if you can see, compare the diameters of the two, the dilator and the scope. This is the scope in my hand, which is moving.
Yes.
So we have dilated adequately for the scope to go in.
Yes, perfect, sir.
Yeah. Irrigate, please, a little. Irrigate. Or how did I tell you to hold the syringe upside down so that no air goes in? See, this is a scopy which is done under saline. Okay, so we are like submarine, if you understand what I say. So what happens is you cannot have air getting into the system, into the duct.
Yes.
If it goes in, it causes a reverse lens effect.
Yeah.
And then the entire picture gets distorted. So most likely we will get a few bubbles in, because this is like not everybody is used to the irrigation. So once the bubbles get in, I will let you know what I am saying.
It's a Euro
So now
surgery.
I'm going to remove this and introduce the scope. Convinced?
Yes, sir. Perfect.
Now,
Yeah, this is
please
going
give the
smoothly now.
auditorium. Yeah, the endoscopic picture. Give me a guide wire. Now you can remove this. Give me a guide wire. Leave. Okay. Now hold on to this plastic sheet. Yes. Pull it up. Yeah. So I passed a guide wire through this central instrumental channel.
Okay.
Okay. Now I want somebody to irrigate continuously. Continuously, I mean, you have to look at the picture. The moment you see the lumen, you don't irrigate, but you have to irrigate half a cc or even less. Okay. So keep looking at the screen. Those are my instructions to my assistant. I have a very good team out here. Yeah.
Yes, sir.
Yeah. Now irrigate.
Wow.
So this anatomy is what we all learned, but we never saw. When we were in medical school, we never saw this. Right?
Yes, sir. This is live demonstration. Yes.
Yeah.
This is the guide wire.
Yeah, that green thing is the guide wire. Okay. So
Okay.
Keep irrigating a little. So we are traveling in, which is from the distal end to the proximal end. We are traveling in the direction opposite to the
Yes, sir.
saliva. Irrigate.
Okay.
Irrigate. वहां मत देखिए वो, यहाँ देखिए आप. You have to see if the duct dilates. Okay. Okay. Irrigate. And also, I would like to remind the audience that
Yes,
this is
sir.
a scope which has about 10,000 fibers, which
Okay,
basically
yes.
means the image is 10 kilopixels. In endoscopic sinus surgery, we are used to megapixels, 2, 5, 10, I don't know what. So the
Yes,
picture
sir.
will be not as clear as that, but it's definitely something with which we can work and give good benefit to the patient. Irrigate. Irrigate. So as I can now see, that yellow thing that you can see
Is
is
the stone?
behind. Yeah, that is the stone. The
Yes,
thing
sir.
is, the stone is say 9 millimeters. Now the duct size is about 2.5 to 3 millimeters now. Okay.
Okay.
The stone is 9 by 8 millimeters. So for this stone to come out through this duct is impossible.
Yes.
Srish, Rakesh here.
Yes.
Can
Yeah.
you reduce the edema of by any way?
No, we have used dilute adrenaline, but I mean this doesn't reduce the edema to an extent where it can really give us some advantage while doing the surgery.
So can we use hydrocortisone?
On or balloon? No.
No, see, for the balloon, the stone is abutting right there. Where do you put the balloon now? The balloon will be in the part which is already dilated.
Yeah.
And the balloons are like go through this, like through this instrument channel. For this scope, there is no balloon. So we'll have to take another scope with a larger instrument channel, put in a balloon, try to dilate. But
Okay.
imagine it's like a 3 millimeter may get dilated to 5 millimeters, but this stone is 9 by 8 millimeters. Irrigate forcefully. So I'm going to try and clean it. Clean it by irrigation. That is the only thing that we can do. Why is it so? Just a moment. We're just having some, just irrigate. Let's see. Little, there should be no air inside the tube. Once there is air on that end, it is going to go in.
It's going to hamper the image then.
Bubble here. Right. So you can hold the syringe down so it is comfortable for you to irrigate. See, this guide wire can barely go. What I'm going to do is try to put in a basket through here, okay?
Okay.
And see if we can trap the stone. Irrigate, please. If the duct collapses, you have to irrigate. There's a lot of muck here around the stone. Can you see this mucoid thing?
Yes, sir.
Which I'm trying to move with my guide wire. I'm rotating my guide wire. Can you see the rotatory movement?
Yes.
Okay, irrigate. Irrigate, yes. Can you see it a little bit more clearer than before?
Yeah, before, yes.
Yes. Now it's
Yeah.
clearly visible again.
Give me the basket, please. So you'll have to put the tip in. Push it in till you see it coming out there. Careful, careful. This is a gentle procedure. We are working with very flimsy structures. Okay, so let's irrigate now. Can you see the stone?
Yeah.
Yes, very nice.
Yeah. So I'm trying to push the basket in through the gap.
Yes.
Can you see that?
Now you
Yeah.
can.
Yeah,
So
that's the
the
green. The greenish one is the basket. Irrigate. Keep irrigating. I have to see a clearer picture.
Yes, yes.
Right. So I'm trying to deploy the basket. If I am successful, it will all be because of you, Rakesh, because I don't expect this to trap the stone.
Yeah, I think you will be able to do it because it looks like
There is no spacing. Can you see what's happening? The basket is
yeah,
opening
yeah.
distal to the stone.
Yes.
Can you see this is the open basket?
Okay,
Irrigate.
okay.
Keep irrigate.
Yeah,
See,
I
if
think
you irrigate, you get a good picture. So that is why you have to look at the monitor. See, this is the closed basket. I pass it in. If I open it, it opens up here, not inside, because it doesn't have space to go in.
Yes, yes.
As
Space for
anticipated, because the stone is too large for the size of the duct. So now what my plan is, I know now I can see the glow of the light in the floor of the mouth.
you just give incision, combined
Yeah,
approach.
I'll incise, look for the lingual nerve there. Be careful of the lingual nerve there. I'll remove the stone and do a check scopy and make sure there's nothing abnormal inside. But as in all scopies, withdrawal scopy can give you a good view. It can sometimes give you surprising findings. So while withdrawing, it's not a rapid procedure. Okay, irrigate till we get the picture.
We mark the site.
I mean, in this case, because the stone is palpable, we don't need to. But if the stone was not palpable, then certainly I would mark the size. The other thing what we can do is we have silo stents of required length. So you can all of them. So if I measure 5 centimeters from the papilla, then I put in a stent and suture it to the tongue frenulum. So when I dissect, I have the stent as a semi-rigid kind of guide to go to the stone.
Okay.
So I'm
Anything
withdrawing.
like to break the stone or?
I'm not in favor. You can use a laser. Too costly.
Yeah.
Takes too much time, and the thermal damage caused to the duct wall is too much. So world over, they are shifting from lasers to, if possible, pneumatic lithotripters, but they are not manufacturing. So mostly the people in Turkey have it. I've been trying to buy one of them, but they have not been sending me one. It has been 3 years, so I don't know the reason. The other thing is, when you break a stone, you leave small nidi for the next stone to form. So I'm not in favor of breaking the stone, as far as possible to remove it in one single piece. Irrigate. Can you see the rugae of the duct?
Yeah.
The circular rugae of the duct?
Yeah.
And you can see beautiful vascularity, which you will not see in pictures.
So you'll be doing open combined approach.
Yeah, internal combined approach.
Okay.
The advantage is, after removal of the stone, I know that there is no piece that has stayed in. Okay. Also, if there is a stricture, I have dilated it. Just put on the microscope, please. I'll be dissecting under the microscope. You can come on this side. Just shut down the light source of the endoscope, please. Fine. Give me 2% xylocaine adrenaline, 2 cc, 26 gauge needle. Okay, thank you. Are you getting the microscopic picture? Yeah. Suction, please. Tongue depressor. dissection of the floor of mouth technically appears to be very easy, but practically is very challenging. You have to be very sure because it's a mobile, the entire unit moves, so the depth perception may change. Are you getting the endoscopic picture?
Yeah, we are getting the, not the endoscopic, the microscopic picture.
Microscopic, sorry. I want you to see the microscopic picture.
You have to reduce the light and then you put the telescope there, no? You are reinserting the endoscope?
No, I have removed the telescope now, the endoscope now. In this case, because the stone is palpable, so we don't need that guide.
Okay.
Okay, just hold on to the tongue depressor like this. Chhod dijiye. I can palpate it here at my index finger, so I'm going to give local infiltration here.
Yes.
Am I on the screen?
Yeah.
Okay.
You must have, you have operated so many places, you must be having good collection of all the stones, huh?
Yeah. I have a very good collection of stones.
Yeah, you just keep it in library. Like there is a Chevalier Jackson's library like that. All the foreign bodies which he was removed.
I have not only a good collection of stones, but also foreign bodies.
Foreign body also.
And I'll show you an interesting foreign body. Quite a few of you may have seen that. An interesting foreign body that I have removed. You'll see it in my lecture tomorrow.
Okay. In salivary ducts.
Yeah, salivary ducts, yes.
Okay. Foreign body. So you are using
on hai na?
Low setting. I think you are using Colorado needle.
Yeah, I'm using a Colorado needle because otherwise it chars too much for the floor of the mouth.
Anything you use. Low setting is go.
And low setting it is at 10.
10, yes.
Make it 12, please. 12. Pottery, make it 12, please.
अब छोड़ देंगे
15. Okay. Is this cautery working properly? Okay, make it 18. I started from 10. I'm slowly increasing rather than causing damage. Yeah. We are dealing with delicate structures. We have the lingual nerve just below this mucosa. Okay, this is good enough incision. Do you have a Caesar? Section Caesar. Okay, fine. This will be fine because we have to work at depth. So I'm going to open up this space. Give me that forceps, please. That forceps. No, no, we will require that. Yeah, okay. Because how do we show check scopy then?
Just leave the cloud. I just operate from my.
Yeah, yeah, that's how it is.
This is right angle, na? This is right
This is
angle.
like a not a right angle. This is at about less than that. This is specially made for the floor of the mouth.
Any name is particular?
Can you see the tongue depressor going into the incision? Yeah. So you have to retract that. Okay. So this is the tail of the sublingual gland, which is coming in the way. I'm going to, you can see I can find a space between this and the mucosa.
Yeah.
So I'm dissecting this area. I can see the lingual nerve coming into view.
Sure. Actually, it's not centralized. Not centralized.
Okay. Yeah,
Yeah,
I'm dissecting. The lingual nerve is not actually focused because it is deeper down. Okay, can you see that broad white belt?
Yes.
Yeah.
Now what you have to do is you have to be able to put this in here and retract. But when you're pulling, you leave this. What are you holding this with? This has to be like this. Retract the lip, please. Use a tongue depressor. That's the mylohyoid muscle that you can see.
long segment.
Just hold on, keep pulling. Don't release anything now.
मैं कहता हूँ
Today we are lucky because the anatomy is such that I can palpate the stone here. Okay, but can you see? Can you see this white structure here?
Yes.
I just have to be careful. Can you see this? Yeah, the stone is just below that. What I'm trying to do is define the lingual nerve, which is now sitting on the top. Can you see this this portion is the lingual nerve. Can you see this?
Yeah, middle.
Yeah. And the stone is here.
Just on lateral part of lateral
Yeah.
side.
So I'm trying to dissect the nerve out from the duct.
Yeah.
I mean,
Nicely.
sometimes I've been told that this surgery requires patience, and I've always said that I'm in the business of conserving organs, functioning organs. I can never afford to say I do not have patience. The lingual nerve is here. Just release this a bit. Release this a bit. Release this. Yeah. Hold on like this.
Yeah, you have put a instrument there.
Yeah.
Yes.
So I'm going to.
Yeah. Yeah. This is a stone.
Can you give me my forceps, please? My forceps. There are two forceps like this there. Just a moment. This forceps is a little bit longer, I think. The plain forceps, not the tooth one. Plain.
Not folded. It's seen there.
मैं यहाँ रख दूँ इनके साइड This is short. नहीं लेंथ ये इसका लंबा है. Just retract the lip. See, I'm now going inferior to the lingual nerve, trying to dissect it out. Okay, hold on to it. Correct. Keep it like that. Give me the cautery, please. Yeah. And sometimes it looks much better on the monitor, yeah. So see. Where is the stone? Not this one, this one.
दिमाग में चलता रहता है जाओगे तो परसों ना
Increase it. अरे निकल क्यों रहा है?
लक्षण कितने बजे चल रहा है? लक्षण लक्षण तो शुरू हो गया था. अरे हाँ निकल गई.
It was not cutting at 10, 12, something.
नहीं कर रहे नंबर क्या है? नहीं कर रहे राकेश. हाँ है ना बस.
The cautery, we are. Okay, just be careful about.
क्या अकेले अकेले बैठे हो? हैं? क्या अकेले अकेले बैठा है?
मेरे पास. You'll be surprised at the amount of adhesions that the stone can have. Can I have a smaller suction than this, thinner one than this? I can see the stone, but you can see the suction is much larger than what I would like. ये पहुंचेगा नहीं. Can you see the stone?
We can see.
Yeah.
हमारे स्टोन रोबोटिक भी निकाला लोग.
Will be surprised by the size of the stone, even though we know that it is 9 by 8 millimeters, and you will be surprised by the additions that are there inside.
Yeah, we can see.
Yeah. Do we have a ballpoint probe? Ballpoint probe, ENT, or maybe even the endoscopic sinus surgery one will do. Yeah, but can you see these mucosal adhesions over the stone? So for us to, I mean, be able to remove this stone with a basket would be a near impossibility. Okay, give me the ballpoint. Thank you. Can you see these mucosal adhesions? Can you see
Yeah.
this layer over there that is still trapping the stone?
Yeah, they have, it is adhered to the mucosa.
Hold on. Ballpoint. Can you see at this point the mucus going into the stone? Can you see where the ballpoint is there? Can you see that?
You've lost the picture. You've
Yeah,
lost the
lots of adhesions.
you lost the picture in the auditorium. Yeah, it's now it's there.
No space for this to go in, and for us to expect the basket to go in and hold it and get it out is asking too much from a very miniature thing.
Connection.
Hold on.
Connection की problem.
in the PowerPoint. ठीक है.
Audio visual? Yes, it is there.
Okay, so we'll have to dissect this part. Can you see?
Audiovisual, we are not getting the picture in the auditorium. And
Give them the microscopic picture, please.
we're not getting the picture.
Yeah, I'm waiting. You let me know when you get the picture.
No, we are getting the picture, but it's not clear, and it's the transmission is repeatedly getting lost.
Okay. I mean, there's some fault in the connections because here we have a very clear picture through the microscope and on the monitor over here.
Okay, but we are not getting the continuous transmission. It is breaking
Okay.
on and off. Yeah.
See now what is happening.
बच्चे देखने को डर गए हैं वो.
You'll have to pull to your side. Right. Give me. Okay, this the smaller one.
Look,
Only thing is
any
it
audiovisual guy
inside.
from the IT can
It
look
doesn't
into
reach
it.
in time.
When
You have to keep it. Yeah.
we're not getting continuous transmission in the auditorium. Hello? Anyone from
Hello.
audiovisual? We're not getting continuous transmission in the auditorium.
Audiovisual, please look into the matter. The auditorium is not getting. Here this is the ear ball probe. Can you see the? You cannot, but can you see the lingual nerve now clearly?
We can see the lingual nerve, but the picture is not
Yeah.
continuous. It's being.
It doesn't reach. That's the reason. नहीं ठीक ठीक I'll it's good that you're seeing the difficulty because otherwise you'll feel it's so easy to remove with the basket. Can you see the lingual nerve? Can you see the stone? Auditorium?
We can see, but the picture is not continuous, and the transmission is getting stopped randomly.
But for want of time, I'm going to now remove the stone. Okay.
Now we can see the still picture of the stone being removed. We are
Right.
not
Okay.
getting
Good enough. Give me some irrigation. Saline with irrigation. Connector.
now we are getting a look at the bed of the stone, bed where the stone was there.
Yeah.
And there are some concretions which are left behind.
Concretions.
Yeah.
So we wash them all. I'll just do the check endoscopy once and give me 2 minutes. Light on for the endoscope, please. You can release this. Okay, hold on. Give me number 3 dilator. Dilator number 3. Raise the low. Lip retractor. Number 5. अभी retractor. Give me the guide wire. मुझे 5 नंबर का डायलेटर देना है. एंडोस्कोप लाइट सोर्स चालू किया. थोड़ा इरिगेट करो. इरिगेशन दे दीजिए. ओके, निकाल निकाल. Okay, give me number 4 dilator. ये पकड़ के इसको ठीक से पकड़ के रखिए. गाइड वायर पकड़ के रखिए. निकल गई तो भी चलेगा. इरिगेट. Now, because we have breached the duct, the saline will leak through the incision. So that's why it will not direct to the extent that we could see
Sir,
it before.
sir, we are not
Keep on
getting
irrigating.
endoscopic picture, sir.
Okay, give the endoscopic picture, please. This is Vinodia, that's the incision area. Can you see that clearly? Yeah. Are you getting the endoscopic picture? Auditorium.
No picture is there, sir. Only that.
We are getting the picture, but transmission is not good. I think audiovisual people are looking into it, and till then, we are stranded over here.
Oh, okay. I can probably give you a running commentary that
Yeah, you can give us a running commentary whatever you are doing, so that we can
Yeah.
understand.
So what I'm doing now, I've now passed the scope again. I can see the entire submandibular duct.
Okay.
As I go deep where the stone was,
Mhm.
this was the region. I can see the rough area which we could see through the microscope when the stone was removed.
Okay.
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 Yeah. So this was the region where the stone was lodged. There is no other. This is the submandibular gland tissue. Yellow. It looks like that. It can sometimes confuse
Yes,
you.
we could.
If it is a stone.
We can get some glimpse of that.
Yeah. Yeah. Had gland tissue. But sometimes, most of the times, it looks like a stone. Okay, but you cannot have so much of stone remaining. Okay, we could see it from this thing.
Okay. So, what do you plan to do for the oral incision? Would you like to close it,
Yeah,
or
for the oral
like to
incision, I
hospitalize?
will close it off with 50 Vicodin.
Okay.
Yeah.
And how will you make sure
That's
that
all.
it doesn't get strictured? The patient doesn't get strictured.
Did
Will
you
you put
realize the size of the stone?
Yeah.
Did you realize the size of the
Yeah,
stone?
it was
It was 9 millimeters.
Yeah, it
So
was a
if
very
it gets strictured, even it comes down to 5 millimeters, that's fine.
Okay. So, would you not like to put a stent in the extension duct?
I generally would, but there is no specific stent available here.
Okay.
I generally put in all these cases, I put a stent.
Because after that, the opening of the duct, if you
Or
do
closure and then
vascularization or put a stent, that would be
do I do what?
whenever this type of granulations in the this duct is encountered, or there is a big stone, when there is a trauma to the duct, you either you should put a stent or vascularize the duct at that place only.
There are two schools of thought.
Yeah.
Some of them don't put stents in any situation. Some of them put stents in all situations.
Okay.
And both have equal results. So we are still, the jury is out on whether we should stent or not.
Yeah.
I think I will have to shift over the endoscopic camera to the next OR.
Okay. Okay. Thank you. That was a nice demonstration. Thank you.
Thank you.
Thank you.
Hello, can you switch on the mic?
Just give me
Hello, am I audible there? The auditorium?
Yeah, you are audible, sir. You are audible, sir.
Just close the light source for this.
I know it's running too late, but I just explained the concept here. Okay, maybe you won't be able to watch a complete surgery, but I can give you some steps. Can you see the scans?
No, sir. We
It's not there, sir.
We're not getting the scans in the auditorium.
Audiovisual scans. Are you getting it now? Please let me know when you get the scans. What about now?
No.
Okay. So we have a patient actually. What's the age of the patient? Age of patient. You don't know. Age is for age. So 45-year-old male, female. So 44-year-old male patient with the right sinusal mass. Were the complaints of the patient?
Yes, sir. CT
Please
scan
check.
is there. Picture CT scan.
Okay. So now we have the CT scan of this particular patient. You can see a mass in the right maxillary sinus, and it's coming out here through the widened
Shikhar.
posterior here into the nasal cavity.
ये जो आ
Is
रहा है
that
बार
this particular film? Again, gone.
नेटवर्क से थोड़ी ना तो केबल से आ रहा है ना.
Okay. So whenever you have mass coming from the maxilla to the nasal cavity, there are people of many different diagnoses. Here you can, one is the androconal polyp. It can be an androconal polyp. It can be some tumor. It can be a fungal sinusitis. Right? Are you seeing the scans now?
The picture is getting lost repeatedly. Yeah, now we can. The transmission is not continuous.
Explain the concept. So, okay, you can get the endoscopic thing ready, right? So it can be any of these. It can be a androconal polyp. It can be a fungal sinusitis. It can be inverted papilloma or some other tumor. So the here to do a contrast scan to differentiate these things. So the androconal polyp and the fungal sinusitis, they're hands, but the tumors in hands. And that is how you differentiate these pathologies. Because these hyperdense areas are pretty common fungal sinusitis. Are they getting scans now? Are you getting the scan now? No.
No.
No, sir.
Okay. 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 Just give me. Okay, you can just connect the endoscope. We'll start the surgery. Whenever that's connect it. Whenever you have the transmission and there is somebody left out in the therapy, I'll any open case. Generally, when I go for conferences, we have a couple of patients lined up for the faculty. It's very bad that if you don't operate, the patient complain. You told somebody will come and operate, but nobody operated. So I don't want to have this such things happen. So even if there is zero, I'm going to operate this particular. Okay.
Sir, we are also waiting here, sir.
Okay. Okay. No problem. No problem.
डिपार्टमेंट के लिए बहुत बढ़िया.
No problem.
Sincere. मेहनती की तो वो मेहनती है. आप कोई काम बताओ वो काम को.
And see, for all inverted papillomas, it is always better to have an MRI also, because with the MRI you can have some particular either the malignant tumor or just a pure inverted papilloma, because you can always have a simultaneous commercial carcinoma in inverted papilloma. Are you hearing me?
You are audible, sir. You are audible, sir.
Audible, okay. Okay. So it is always better that you have an MRI also in inverted papilloma, because in the MRI you can differentiate a malignancy. You can actually have some idea whether the malignant change is happening in inverted papilloma. Because this inverted papillomas typically have this MRI finding called the cerebriform convoluted pattern, the CCP. Whether you have some ball-like pattern from one particular bony point to is running along the entire length of tumor, and this CCP, this cerebriform convoluted pattern can be there in other tumors also, but the pattern runs almost like more than 90% of the length of the tumor. The long axis, it is most probably inverted papilloma. And in the particular area where you have the loss of the CCP, there is probably some necrosis. The necrosis usually happens with a malignant cancer. So those particular areas we have to send the biopsy. If you send the entire sample, the pathologist will not check the entire sample. So in those particular area where you have the loss of the pattern, those areas should be sent separately. Right? That is why MRI is important. And from the CT scan and the MRI, you can differentiate but papilloma from other tumors also. They're getting the scans now? Not okay. But can they get, do they get the pictures?
We are getting picture intermittently, sir.
Okay, okay. Endoscope.
No, picture is there, sir. External camera pictures are on the screen, sir.
Fax.
वो भी अच्छा होगा, temporal bone जान के वगैरह आ रहे हैं.
Fax. Okay. So I think now they have the scan, right? You're getting the scans now, right? Hello? Again, gone?
Sir, picture, picture is there, sir.
Okay. So in the scans, see, this is the contrast scan, this is the plain scan. One thing I need is to differentiate whether it's a malignant tumor or a AC polyp or fungal sinusitis. That I will get from doing a contrast scan. The contrast scan is an enhancing lesion, so it's probably a benign tumor or a malignant tumor, right? And other thing I look for is the area of hyperostosis. Can you see the hyperostosis there?
Sir,
Seeing this?
We are not getting the translation. Audiovisual guys, please reconnect to the connection.
Audiovisual, we are not getting the picture. And even voice is not, it is not continuous.
The other mic better. Both are same. Okay. So in the CT scan, we look for this hyperostotic regions because the hyperostotic regions correspond to the area of tumor attachment. When you get the pictures, I'll show you that. In this particular patient, I can see the hyperostotic region lying laterally in the zygomatic recess and going almost to the posterior aspect. And near the region. So that entire hyperostotic region I could fill away. The concept of surgery is that you remove the entire disease, the entire tumor. I try to remove the entire mucosa around the tumor. I try to ablate the entire bone and then I drill away the hyperostotic bone. That is what these four things are very important, getting a complete clearance of inverted papilloma. One is complete tumor removal, removal of mucosa around the tumor, ablation of entire bone of the sinus, and the fourth is drilling of the involved hyperostotic region. Right? Hello? Okay. So whenever you get the picture, let me know. I'll just cut the screen. Can you have this light off? Light off, please. And can we switch on this light? Super. Plus button.
नहीं सर नेट से हो रहा है.
Okay. White goes. Can we have the white balance? One more. Take more time. Okay. Don't do it.
अरे बात तो केवल का हुआ था ये करने के लिए तो.
So once you have the picture,
इसको अवॉइड करने के लिए
you can go
ये
for the
था कि
endoscopic picture. Okay, correct. Section.
इसी को अवॉइड करने के लिए
You have two sections.
केबल से ट्रांसफर.
So
जो डिसाइड हुआ था पहले.
see, somebody told me there's a contrast scan, but I don't think there's a contrast scan because like I'm seeing fungus there. That's a plain scan. And it was contrast scan. No. This is a fungus. Finish your sentence.
हाँ बोले भैया.
The previous student told that a contrast scan is enhancing and all. That story is completely wrong. This is not a contrast. Third section. Third section. No, but this one, somebody told me it's a contrast enhancing mask. This is not at all enhancing, it's a fungal ball. Fungal ball. Can I get it? And no, there is no audio visual. I think there's nothing to show. I actually enjoyed watching it because I stayed back not to do this quiz. I stayed back to watch.
नहीं ब्लड नहीं सब वो आवाज में थोड़ा
Yeah. So this thing I do regularly. I don't learn anything out of this. Now we have a fungal ball. See, this is very important. See, somebody gave me wrong information. The scan is enhancing.
मेडिसिन के थ्रू है
See, the LC polyphenols, they can enhance, but the enhancement happens only the periphery. The central part never enhances. Those hyper things mean actually not, it's a plain scan. So there is a fungus showing up, right? So what you're seeing on the other side, that one is see this. This is not enhancement. This is basically the same fungus which you're seeing here that is showing it. Okay. So the way you differentiate AC polyp, the fungal sinusitis and inverted papilloma is based on enhancement. Inverted papilloma enhancement is there all over the tumor. Fungus and AC polyp only in the peripheral mucosa, right? So I was seeing our diagnosis wrong, but then I think I convert some concept to MRI. And in inverted papilloma, you must always look for the hyperostotic region. The hyperostotic regions can be there in fungus also because of the inflammation, infection. Okay, but that hyperostosis is very much important in inverted papilloma surgery because that is the area where the tumor arises. Okay. Can I get the Colorado needle case? See, you can remove this fungus by doing a wide MMA, but the fungus is completely killing the spine. I will show some new technique. It's called a bilateral approach.
हम लोग correspond करते रहे बस
All fungus, huh? For finishing it quickly, I'll just do the bilateral approach. I take the Colorado needle tip like that. Okay. That is your inferior. This is your inferior terminate. Okay. You make an incision along the terminate like that. Okay. Okay. Now can I get the suction? Can I get the elevator now? I mean my elevator. Okay. Where's my elevator now? Okay. Can I get a mucosal pack? What is the BP like? And see, there is a bone of the attachment of the inferior terminate. Huh? What bone is that? What bone is that? Name of the bone, man. What is it? Osteoid. Yeah. Sinus osteoid. What bone is that? There's a frontal process maxilla. Okay. There's a frontal process. I expose the frontal process maxilla. Can I have some reverse Schellenberg question? Can I get the reversal pack? Some this position like that. Suction. Okay. And some saline wash. Wash. Enough. Okay. Can I get the Cheselham? See, what is the BP like? What is oozing from the incision sites like that? Can I get bipolar cautery? Bipolar? Okay, so there is a expose the frontal process maxilla. Section. Even with a wide MMA, you can remove this, but there are some parts of the maxillary sinus, like the alveolar recess. That part is hidden. You won't be able to see that with the, even with the wide MMA. So, some cases, you have to do this like this to view that region. Huh? Can I get the chisel hammer now? Okay. Now, if we did like that, give me 3 taps on the chisel. Hit harder, hit harder. Harder, 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 harder. Harder, man. Okay, okay, enough. Harder, harder. Not going to. Hold it, hold it, hold it. Hold it, hold it, hold it, hold it. Okay. Action. I don't know why it is bleeding like this, huh? Okay, but you can wash. This is nothing. I'll show you carotid bleed tomorrow. Okay. So I removed this bone from the lateral aspect of the frontal bone of maxilla. Okay. The only thing you're worried about is, can I get the bipolar? The only structure here which will come on your here. What is that structure? Nasal lacrimal duct. Okay. There's some bleeding from this mucosa. There is no known vessel there. But can I get the bipolar? Okay, can you hold the suction like that? Bipolar to me. Can I remove the suction gently? Remove it. Take it up. Okay. Can I get a small aerosol pack? Oh, it's a BP is like 140, 100. That's it's bleeding. Okay. Can you try to bring down the BP if possible? Okay. Wash. Elevator. Can I get the elevator? See the small vessels are bleeding. Can you see that? Huh? Can you see the bleeder there? Yes, sir. Can I just hold it? I'll just monopole away because I think it's the bipolar is not reaching that particular point. Can I hold it like that? The suction like that? Okay. I want to see the bleeder, but I don't want to have the suction block the bleeding side so that I can cauterize. Huh? I don't take my monopolar cautery inside. Okay. One minute. One. Okay. Let me remove it. No, it's still bleeding. Huh?
Hello, sir. Sir, we are from auditorium. Now we are getting continuous picture and transmission. And
Okay, see, now you're getting the picture, right? Okay.
Yeah.
See, the thing is that we saw some scans which showed some hyperdense areas,
Okay.
which somebody told me is a contrast scan, but actually it was a soft tissue cut. It is not a contrast scan.
Okay.
And this actually is a case of fungal ball of the right maxillary sinus. Okay.
Okay.
And right now the problem is the BP is like 140, 100. There is some bleeding because of the high BP. But I am still working around. See, the fungal bolts, you can just do the wide MMA and remove that. But I was just showing that if there is some fungus trapped here, I can, with much more ease, I can get it with a free lacrimal approach.
Okay.
So I made an incision like that about the inferior turbinate. expose the
Okay.
bone, the frontal process.
Uh-huh.
I'm removing that bone, and they say I go to the maxillary sinus.
This bone looks
But
very
because of
brittle.
the,
Bone looks very brittle.
what is that?
The bone looks brittle. In fact, this bone.
Brittle. That can be because
Yeah.
of fungus, or maybe
Yeah.
other possibility. Sometimes, no, if you if the what the PG told me, the contrast scan that's enhancing. You can always have fungus inside the tumor, huh? But I don't think that's that's a scenario here, because if the bleeding is because of BP and the brittle bone is because of fungus. Can I get the mirror, Sutra? There is a prelacrimal window into the maxillary sinus.
Okay.
Both are properly available, very nice. But the thing is that now the surgical field is not good because the BP is very high. You're bringing it down. Wash. One more pack. Okay. The mean BP is like 131, right? Or what is it? 90. Okay. Wash. See, there are a couple of techniques to remove the trapped fungus in the maxillary sinus. Huh? One is you do a wide MMA. You do a wide MMA and then you place a gauze and scrape that gauze in the maxillary sinus. So that will sort of dislodge the fungus. Second is you can use the peroxide washes. And the third thing, if you still have the fungus trapped in the alveolar recess, you can do the prelacrimal approach.
Okay.
Like this, huh?
So can we open this maxillary sinus from the anterior aspect, like by going from the sublabial route? We
That
can
is
get
also
better.
a good option. You can do that also.
Yeah.
You can do the canine fossa puncture, huh?
Canine fossa approach, so that we can directly tackle the bleeding head on.
So bleeding here is not because of it's not from a particular bleeding point, because the diffuse oozing from because of the systemic
Because
factors.
of the maxillary sinus.
That is okay.
Okay.
See, whenever you have bleeding, you must actually look for this. Whether it's a venous bleed, a diffuse bleed, an arterial bleed, it differentiates like that. Huh?
Okay.
So, an arterial bleed, you have to find the bleeding point, cauterize the bleeding point. A diffuse bleed, you have to control other factors. But you can also try packing. You can try peroxide washes, warm saline. All this will work in a diffuse bleed. Wash. So here the diffuse bleed is because of the increased BP. Straight black asleep. But it is coming down. Straight black asleep. Black asleep also. One. Wash. Do we have some warm saline? Straight black asleep. Wash. Wash. Can I get my elevator? Where is the nasal duct? Okay, elevator. See, there is this one here. This is the nasal duct there. Okay, I gone in front of the nasal duct to the maxillary sinus.
Yes, sir.
So now I can visualize the entire maxillary sinus. There is a floor of orbit or roof of maxillary
Floor
sinus.
of orbit. I think that is infraorbital nerve and
This
vessels.
is infraorbital nerve. I can see a lot of granulations
Yeah,
here.
this is.
Generally, fungal bowl doesn't cause so much of granulation.
Yeah, yeah.
And there is a zygomatic rhesus here. This one, okay?
This is zygomatic rhesus. Yeah, zygomatic
Make it
rhesus.
angled endoscope. 70-degree endoscope. 70. Yeah.
Akansha, इसको बोलो, Akansha, इसको बोलो.
Uh, Dr. Felix, will you be reviewing this medial wall of maxilla?
Beg your pardon?
Will you be reviewing this medial wall of maxilla?
That is opened by the fungus itself. But this soft tissue
Okay.
looks sort of atypical. Can I get the
This is
flecus?
open on the posterior side. The rest part of bone which is lying anterior.
No, duct is here. Duct is underneath this one. Duct is here. But there
Yeah.
is fungus here, and there is something which looks atypical here.
Yeah,
Which
yeah,
I'll
yeah.
send for
This is this one.
Just take for biopsy.
Mm-hmm. Oh.
Wash. This is the duct.
Yeah,
Can I get the elevator? See, can you just look at the scan report whether there is contrast or not? Because this area looks sort of atypical. I saw fungus also, but then can you just look at the scan report whether a contrast was found or not? Please look at the scan reports. Wash. Now, what about the enhancement pattern? I just want to know about the enhancement pattern. Whether a contrast. See, one minute. This is the duct, okay? This is the nasal ligament duct. And there is some bone left out there. So here we have gone anterior to duct.
Yeah.
So there is anterior duct. And this is the wide MMA which is actually made by the.
Yeah. This is
lesion
made by
itself,
the disease.
Okay. There is a coina.
Yeah.
What is it? Okay. Blackus. But see, from the contrast scans, the report is that there is heterogeneous enhancing lesion. Okay.
Mm.
But during the surgery, we found there is some fungus.
Mm-hmm.
And
So
of course, you saw some atypical mass here in this region.
There might be some
attached to the
superadent.
See, always you can have some underlying malignant tumor
Underlying,
trapped with fungus.
Yeah, can be there.
So fungus can happen with dental material getting dental metal getting into the maxillary sinus. You can get fungus. With tumors, you can get fungus. So you have to keep all those things in mind. And since the pathologist says there is an heterogeneous enhancing lesion, I would like to open the maxilla further. Can I get the scissors? The Mayo scissors. I'll do a minimum the big one, the minimum middle maxillectomy.
Yes.
So it is very easy to do the middle maxillary. Just put your scissors like that.
Mm-hmm.
Okay, the curved scissors. Cut the terminate like that.
You're cutting the posterior part of the in fact,
terminate. Okay.
Leaving the
yes. Okay. So that is it. Post lacrimal. This is the way of.
This is the post lacrimal part of the inferior terminate being cut.
So I preserved this inferior terminate. I preserved the duct. I have the I open the maxilla there. I'm going to open the maxilla here also.
Okay.
This part of maxilla.
In the floor.
I am sort of conservative also, but then I get a decent window to the maxillary sinus.
So,
I'm going to open.
Sir,
I'm going to remove this mucosa, drill the maxilla here.
Mm-hmm.
And I already have a window here.
Okay.
So do we want to preserve this anterior part of the middle turbinate? Why don't we
I would like to
remove
preserve
the
this part of turbinate so that there is no emptiness syndrome. There is less crusting. I would like to preserve the duct, right?
But
I don't. I
this
have to.
bone-
I need to keep. I need to have a good window also. That's why I have the pre-lacunar approach. I have the post-lacunar MMA, and here I'm going to drill this bone away. Okay. Can I get the coblation? Can we get the coblation? I think I'll just take the Colorado as of now since I don't get the coblation again now. Okay. And I need the drill. Okay. I need some sort of drill. Suction. Keep the suction there. Suction. 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 You got the coblation? That's a foot pedal. Connect the coblation. Connect the coblation. Connect the coblation. And suction. Connect the suction to the coblation. Connect. Where is it? And you connect the drill also, okay? Connect the drill also. Connect the drill also, please. Connect the drill. Connect the drill also. See, in the inferior meatus, there is no nasolacrimal duct. Okay, there is no duct here. The duct opens there, and so this part is in the inferior aspect of the inferior meatus. There is no nasolacrimal duct. The duct will be somewhere opening there, so I can safely remove all this mucus and bone. See, as somebody pointed, the bone is very brittle. Can you see that? As somebody in the audience already pointed out, even in the suction, I am able to break this bone here. This is the pyrima puncture, which is supposed to be very thick. Even that bone is getting opened up with a curved section like that. Huh? So there is something wrong happening. I don't know of this tumor. Coblation, please. Section on the coblation. So that is a pyrima puncture rim. See, based on a necessity, you can enlarge this approach. Okay, I can just get into the make a window there, go anteriorly to form a sort of Denge's approach if I need like that. I can go in like that. So I can modify this approach based on necessity. See, the morbidity comes when you remove this rim, when you remove the duct, or when you remove this part of the turbinate. So I try to keep this part, this turbinate, this duct, and this bone till the end of my surgery. So only if it is really necessary, I remove this bone. I can go laterally. I can go laterally and make a window there without removing this rim. Okay. So that doesn't cause any morbidity. Only thing, if I cut the nerve fibers here, I'll get some paresthesia. But other than that, there is no much cosmetic defect if I keep this bone intact. Okay, I can make a window there and drill the entire maxillary sinus. Okay, and if there is no tumor laterally, or I can just remove this bone and work through this window there. Okay, I can customize it based on my need. Can I get the drill now? See, this bone is very brittle. Look. Drill. Bigger one, big drill, bigger drill. This is a very small drill. You have a diamond one. No problem. Give that. So this is where we saw something like a tumor. This particular region, and we removed it. So I like to have it here. Can I get the drill? Where's the pedal? This one, okay. Okay, can you just we have only the diamond one, and this is actually the master drill. I'm using the master drill, so which can take some time. This, I think this is a 1,000-year-old diamond. Huh? It's not even working like a diamond. Okay, section. Wash. This is the problem when you use what do you call this drill. You will have the injury here. You have the nasal drill. You don't have that sort of. Can you see that? Huh? Now give me the chisel hammer. I'll break it with the chisel. Lying and backs. I'll do one thing. I'll straight away do the dentures into that. Not a typical complete dentures, but I'll make a small window there and I inspect the sinus. Can I get the elevator now? Elevator? Can you hold it like that? Hold the line back. Can I get the elevator now? Elevator? Okay. Yeah, bigger line backs, not this one. Can you remove your hand? If there is a frozen section, I will send for a frozen and confirm the diagnosis and procedure section. Chisel hammer. I'll make a small window there. Hit. Or can you hit? Just hold the endoscope. Just hold the endoscope. Hold the scope. Just show that. Just. Turn the head properly. Hit. Can I get the kerosene? Leave it. Kerosene. See, hold the head and hold this. Retract both. Okay. The head shouldn't turn too much. Everywhere it is bleeding also. That is why follow this feature. Here's a drill. This is really very difficult, man. There's a transnational drill is not there. 1 minute. You're a driver. This thing is getting in the wrong plane. Huh? Hold it like that. Hold it like this. Okay. Can I get the kerosene sponge? Punch. I need a bigger opening. Chisel hammer. I don't have a sort of drill here. That's why I'm just doing it like this. Huh? And the chisel is also sort of blunt. Hit strongly, man. Good. Very good. Good. Hold it. What is that? The ear drills are very slow. It will take a lot of time. And again, now the BP has gone to like 140/90. So a lot of struggles. Kerosene. Can somebody hold a suction like this? Like this. Hold it like this. If I just do the 10 gas, I'll get a lot of window to work, but it's trying to keep it up. But if the bleeding is too much and I'm not able to, I'll just remove this pyrophobicity. Suction block.
Sir, in operation theater, we have DCR bar, sir. You can use that bar.
No, there is a mastered bar. I'm making the mastered bar here.
No, sir. We also have DCR bar. true cut bar point with suction.
Okay, okay.
Yeah, that will be easy. So you will have filled at least.
Wash now. Can please reduce the BP also anesthesia side. With this BP is very difficult to work. I don't see anything there. Your retractor should come like that. It shouldn't go down. Okay. There is some sponge. And the entire maxilla is mobile. Can you see that? The bone is very brittle and mobile. So all that makes me sort of suspicious there is some tumor behind this fungus, huh? Suction. Publish. Blocked, huh? Just remove it 1 minute. Remove. Hold it. And now this suction is, can you give another suction if this not works? Big suction dip, the big straight, big curve down. Calstros. Ah, that one. Yes, correct. This one. Wash. Give me some more. Can you get the line back now? There is some soft tissue there. Huh? 1 minute. Wait, not like, don't put it. You're pulling a part of the soft tissue, getting a false plane. Huh? That is why you hold it like that. Okay. Can I get the coagulation? 1 minute. I'll sort of expose here better. Take care the head doesn't turn towards me, okay? Can I get a small Miracell pack? Hold it. There is some lesion there. Huh? Can you remove it? 1 minute. Can you remove it? Just hold the head for me. Okay. I'll place a pack there so the bleeding doesn't affect me there. Okay. Suction. See, there is some mass there. Can you see laterally there? The maxillary sinus? Here, huh?
Yes.
That is not a normal glucose. Huh?
Yeah.
Then no, yeah, what I thought was granulation looks like mass only, right? But see, I cannot remove this bone because I don't have the drill. Can I get the chisel hammer? I'll just remove this this rim and go. See, generally I keep this rim there intact, so to prevent a cosmetic deformity. But here, since I don't have the drill, I'm going to remove it. Just hit. 1 minute, hit. Okay. And a small amount of removal here, it's okay. But if I go superiorly there will be some cosmetic deformity. Okay.
Yeah.
Inferiorly, it's okay. Right, Black Kesley?
But this
Third section. Black Kesley. Hey, can you see the mark there? Can you see that?
yeah,
That is
there is a
tumor.
mask. Yeah, that is
Yeah, that is
tumor.
tumor.
Yeah.
But this one actually, there was fungus and there is tumor both. Right,
Yeah.
Black Kesley?
That is why this
Take
case
this
is
for
bleeding
biopsy.
actually.
Definitely mass there. Can you see that? Okay.
There is a mask.
Biopsy. Taking a Gosen. Take a Gosen. Like normal couch section tip. Can you give my couch section tip? And try to arrange an internasal drill. If you have an internasal drill, you give the rope. Well, I prefer to drill all this bone away.
Yeah. I think though this mucosa is also involved of
Yeah,
maximum
mucosa is involved.
mucosa.
You are right. You are right.
Yeah.
You are perfectly right. If I remove this particular bone, I'll get better window. I need to. That bone is actually.
In
That is
fact, I
impeding my
think
access. Okay, can
was
you give me
more,
lung force?
you can remove the part of the bone from the floor also, so that it
Floor
will
also,
be.
because I know. But
Yeah.
thing is that I don't have the drill to do that. That is why I'm just
Ah,
struggling.
yeah, that is the problem. That is the problem.
Can I get
Yeah,
my couch? Give me my couch.
there's a mass in the
The
floor
other one.
also.
So that's all the mass. Huh?
This is the mass, I think.
I'm trying to remove the mucosal cup. Can you see the mucosal cup there?
Yeah. There is a
Completely off.
mucosa. Yeah. We can see the bare bone below it, beneath it.
The entire mucosa, I'm just trying to strip it off.
Yeah.
Only thing, this bleeding, huh? I just sort of.
Bleeding is there.
Can I get a small mirror cell pack? Get him. Hold it. Wash now, wash. Wash. Okay, good.
Wash. Enough, enough, enough. Wash. Enough, enough. Can I get the legs forced up or the straight black to stay on? Sort of try to. So, do we have a debrader? Agent. That's the entire lesion. I can see the lesion. I sort of stripped off the entire lesion from the underlying bone, but I need some instrument to get it out. When you give me a straight section, please. Can you see a bleeder from there? From the bone actually here. Can you see the bleeder from there?
Yes, yes. Yeah, there is a
Probably
bleeder.
the tumor, this is like the infraorbital nerve. Huh?
Infraorbital nerve, infraorbital
There
vessels.
is vascularity from that small branch. The infraorbital artery should run close to the nerve. Huh?
Yeah.
This is definitely not a normal thing. There's some tumor there. Can I get the coblation? No, coblation. Put the suction under coblation. Can you connect the suction? The coblation suction is not working. Can you just place this thing like that? Place the curved section like that. Give me the monopolar. Let me try the monopolar for monopolar. No, not like that. Not like that. Okay, like that. Okay. Monopolar is not working. Is the coblation working? If nothing works, I'll just put a bone vaccine. Let me remove all this mucosa. Once the coblation is working, let me know. Okay. Do we have bone wax here? Yes, sir. And I need you have diamond drill. You had somebody brought the transnational burr right there. Where is the transnational burr? Oh, you connect that one. But this is not. This is a matured burr.
इसका सक्शन क्यों नहीं काम कर रहा? इसका सक्शन क्यों नहीं काम कर रहा ये वाला? हाँ?
Can you have changed the? This is working now. Coblation. Okay, let me try to get this. No, it is not working, man. No, this is not working. Suction. Third section. Just flush the coblation. It's not working. See, the thing is that I don't know how I will be drilling this bone because none of the drills are actually
helping me here. Okay, coagulation now. Coagulation. It's very unlikely coagulation will work because it is the bone is the bleeding is directly from the bone. When the bleeding is from the bone, the things which will work, one is bone wax, other things is diamond work. Okay, the dry diamond. Can you remove the section? Remove the section now, sir. Look, it's not working, man. Just change the section. Change the coagulation section. Change it to this one. Yes. Now it is working. There is a tumor attachment site. You can see the pores, the sort of neovascular there.
Yeah.
Can you give me the diamond burr you showed me? That is the section. Code section. Hold section. This is the entire tumor with the mucosal cup. Okay. That's all the tumor, huh? So straight black sleep. Take all this for biopsy, okay? Everything should go for biopsy. Section.
Hello.
Straight black sleep.
Hello, sir. Yeah, sir. Then
Yes.
ultimately, what do you think? Is it maybe a malignant tumor?
It can be because it is attached everywhere. The entire maxillary sinus mucosa is sort of abnormal. The bone is hypervascular. So, if it turns out to be malignancy, let you go for a completion maxillectomy. Section.
Okay.
Not working, man. Okay, the curve section. Please have 2 sections work, please. Nothing is working in a sort of. Give me a curved section. Come on. Give me a curved section. Give me a straight black sleep. You can see the entire bone everywhere is hypervascular, it's bleeding. It's very unusual. There is another bleeder from there. Here. One from here, from here. The coagulation to me. Working. Don't take it because of it's bleeding there. Okay. Okay, suction. Give me some bone wax. Bone wax, bone wax. I sort of completely removed that mucosa everywhere, but I would like to drill here. Mucosa also should go up. Can I get the straight elevator? Elevator. Or maybe and give me a J curate also. Suction. And this is the nasolacrimal duct, very clearly seen now. Okay. Like a sleeve, straight like a sleeve. Just hold the suction like that. Don't take it off and see like that, like that. Okay, and see that tissue. Straight like a sleeve. Okay. Suction. So I removed the entire mucosa and the tumor. Can you see there's no mucosa left out? Huh? We're just seeing that bone there.
Yes,
Okay?
sir. Yes, sir. Yes.
Okay. And this is an nasolacrimal duct opening to the inferior meatus there. Can you see the entire duct there? There is your duct.
Sir,
Okay.
can we cut it, sir? Nasolacrimal duct.
Yeah, that's an nasal duct. But you're seeing just lateral to my section is the duct. I can cut that, but as of now, I am able to work around. There is no need to cut that. That's I'm still preserving that. Okay. If you want, you can make a sharp cut, and there is still no. You can. There won't be any problem with that also. And these are the ethmoids. This is actually your anti-ethmoid there. It's anti-ethmoid.
Is there disease there, sir?
I think there's some disease here. Shape like this. This one actually sort of fooled us. We thought it's fungus, but somebody actually the PGS told me it's enhancing correctly, and I got. Once I saw the fungus, I thought it's just fungus, and somebody has given me the wrong interpretation. Section.
देखना सबसे बड़ी दिक्कत यही है।
This one is. I'll remove this one also. Okay, can you give me a scissors? That's all. Like you. This is sharp. Sharp cut. Sharp cut.
Ultimately,
Finally, we ended up doing this. Straight like a sleeve. Boom. That's it. More side. One minute. Can I get the suction tip? Scissors. Suction. The reason I cut this is because see, I don't have the typical endonasal burr, so I'd like to drill this entire sinus, and that is the cut end of your duct. here. Okay. There is ethmoid mucosa.
हाँ sir. This is orbit, na sir? Orbital. Orbital
Beg your
fat, sir.
pardon?
This
No,
is
no, no.
orbital
This
fat,
is,
sir.
no. This is the orbit. This is the anterior
Oh.
ethmoid.
Okay, this is anti-ethmoid, sir. Ethmoid cells.
There is a bulla ethmoidal. You can see the lamina, the lateral lamella there laterally. Okay. Section.
Okay.
Maybe since I'm putting it through a different window, you're not able to get that so easily. So that is your anterior ethmoid, and that's the lamina papyracea.
This is lamina papyracea.
Can I get now? I remove the disease completely. I just need to drill this bone. Can I get the drill? Whatever drill you have, give me the drill. Okay. The only problem when I use the master drill is that when I put drill like that, this part will keep on hitting here, and finally you get a sort of burns here, huh? Okay. No irrigation, no irrigation, irrigation, not irrigation, not irrigation, not irrigation. Just put the suction outside. Whichever area is possible, I will try to drill it. Huh? Suction drill now.
जाने का अरेंजमेंट है? कैसे जाओगे? गाड़ी है?
What?
बेलूपुर के पास में पहले डायमंड हो गया ये आराम से
Drill it here, yeah, drill it here, this bone. Here. Okay, drill to me.
ये हमको दे दो
चलो सर अंदर भी है ना
वैसे इसका तब कोई दिक्कत नहीं है
डिनर पे कहीं
वहाँ थोड़ी देर में डिनर ही है 9452 5628 00
So I drill here, I drill there. Okay.
अच्छा एसएसपीजी में हमारे तो बच्चे को पोस्टिंग हो रही है आपके यहाँ
Okay. Drill. I think sir, with I'll be finishing another 5 minutes. Just some drilling here. There is an anterior wall being drilled. Huh?
वो वेरी है अच्छा
अंजलि
अभी तक गानी और ये थी
Section.
डॉक्टर राजेश
डॉक्टर राजेश कुमार
And there is a part of inferior turbinate. Huh? So I think we are done sort of, we are drilled here. Huh? The bone is smooth now. Can you see that? Okay. I drill there also. I drill here.
डॉक्टर सुशील
There is this part of bone I have not drilled. This I can remove with a bone nibbler if you want. But I think this appears normal there. Huh?
तीन साल
Do you have legs posters? I'll just remove this bone also. Huh?
काफी सीनियर
ईएनटी के
हाँ ये
क्या नाम है
उससे दिल्ली दिल्ली
I'll just remove this bone because I'm not able to drill that. Huh?
आयत में मैंने किया होगा लेकिन
And this here I like to. Can I get the legs again? Hold head, man. Section now. Okay. There is a zygomeric recess. Okay. Can I get the drill now? Section. Just place a section.
Suction to me. Wash.
Completely drilled now. Huh? Here it is now. I can see the tooth impression there. Huh? This bone is normal. Look at this normal bone. That's normal bone. Okay. So this area is abnormal, and as per the scans also, this was the area I got. Huh? I drilled that entire area, and I think I can stop with that. So if this comes with inverted papilloma, well and good. But if something else, you have to go for a completion surgery. Yeah? Elevator. Can I get some gel foam? Okay. Straight black sleeve. I think I can wind it up here. Okay. So if there is somebody left out in the auditorium, thanks for being with us. And, okay.
Thank you, sir. Thank you very much for
Thank you, sir.
such
Thank
a
you.
wonderful dissection with limited resources and
I wouldn't
so much
say
bleeding.
it's the best case because there's so much of bleeding, and we'll always love to
Sometimes
have a case without bleeding, but unfortunately sometimes things don't work out the way we want. Huh? Okay. So anyway,
sometimes it happens, sir. Sometimes it happens.
yeah. Yes, yes. But anyway, it's always sometimes good to watch cases with bleeding.
Definitely, this
Because
is more
people
beneficial,
don't think
sir.
that things are simple. Huh? Things are
Thank
not
you,
simple
sir.
always. Thank you, thank
It
you,
was-
thank you once again.
Thank you, sir. It was wonderful watching you, sir.
Thank you.
Thank you, sir.
Thank you. Thank you, Manala. Thank you. Thank you, auditor.
अंजाम हो गया है ना.
Can I get, there's some pack left out anterior. Yeah? Can I get some surgical gel? Line box.